response to therapy. In AL is the free light change, the NT-proBNP, the troponins, and in ATTR amyloidosis, the troponin, the INGFR, and the natriuretic peptides. There is a strong evidence for restratification in AL for the use of natriuretic peptides, the free light change, and the troponin. Less evidence in the use of troponin in the diagnosis of AL, and in ATTR the evidence is less strong, but the biomarkers, the natriuretic peptides, the troponin, and the INGFR have a major role in the staging of risk stratification. So the biomarkers are used for diagnosis, staging, prognosis, and evaluation and monitoring of the therapies. There are biomarkers of the systemic disease, the amyloidotic precursors and associated proteins, and biomarkers of organ involvement. In AL amyloidosis, the free light chains make the diagnosis of the disease. They are used for risk stratification in the Mayo staging scores, and they are very useful to monitoring the organ response to therapies. The natriuretic peptides, the BNP and the NT-proBNP, are produced, released, and following volume overload and direct toxicity of the chains to the heart. Routine NT-proBNP recommended during the follow-up of monoclonal gammopathy of uncertain significance and in patients with an abnormal kappa ablation because this can predict the heart failure development in AL. The troponins are red flag in the vast majority of patients with AL amyloidosis without overt cardiac involvement, and the high sensitive is associated with clinical severity of the heart failure, the systolic dysfunction, the well thickness in patients with AL. The hepatocyte growth factor identify AL amyloidosis among patients with multiple, is used to identify patients with multiple myeloma with developed AR. And what the role of biomarkers in, which are the biomarkers first in transthyretin amyloidosis? At the subclinical stage of the disease, there is a decrease of the level of transthyretin and retinol binding protein 4, while gradually the NT-proBNP begins to rise, and the symptomatic stage, the NT-proBNP and the troponin are elevated. The transthyretin molecule is tetrameric with 2 binding sites for retinol and 2 for thyroxine. The main function of it is stabilize the circulating retinol binding protein complexes. Is synthesized by the liver, and it has a normal range in the plasma. Some conditions can reduce the level of it, the inflammatory disorders, liver dysfunction, malnutrition, and dialysis. This molecule is observed in TTR gene mutations, which the tetramer is not stabilized to be lower in the circulation. There are lower levels among carriers of the disease compared to the symptomatic and the asymptomatic ones. Increase in patients with the wild type following when they get therapy with stabilizer in the tafamidis cohort. Therapies reducing TTR synthesis, they decrease, of course, the plasma transthyretin, and the circulating levels of it also negatively correlated with the injection fraction and the left atrial volume, and positive correlated with the limb lead voltage. So the destabilizing TTR variants lead to low transthyretin levels, and stabilizing variants lead to high transthyretin levels. Also, we know that both the inherited form and the wild-type form are important contributors to the risk of heart failure. So, in a study, the Copenhagen General Population Study, they searched the possibility of these results to be compatible with the potential mechanistic association between the low transthyretin values and to be used this as a marker of tetrameric instability and find out through the general population the possibility to have heart failure from amyloidosis. The retinol binding protein 4 is synthesized also by the liver. It's observed that suggestion that this molecule is concentration may indicate the degree of misfolding transthyretin and therefore amyloid fibril formation. According to this, the group of Arvanitis, they make a diagnostic test that in African American patients with heart failure, they identify with the ATTR valinic 122 isolefkine type. They demonstrate that the concentration of this protein with a cutoff of 50 was having 100% sensitivity to find the people who had the amyloidosis from the, who had experienced the, as a cause of the heart failure. And so there is association between the low values of retinol concentration and destabilizing TTR mutations and suggests that both of these molecules and levels may hold similar value as markers of the instability of the transthyretin. And how we use these biomarkers for the diagnosis of the cardiomyopathy of amyloid in AL, the wall thickening and diastolic dysfunction, contributions to myocyte dysfunction and apoptosis. The circulating light chains contribute more in myocardial dysfunction, so the natriuretic peptides are elevated, and they shown in trials that the NT-proBNP cutoff value of 120/88 had 93 sensitivity and 90% specificity for the disease. With the same way, the BNP cutoff values have shown use of diagnosis and detection of the disease in the heart, but we have to keep in mind that the serum natrium peptides are influenced by renal function, particularly the NT-proBNP, and because it's cleared entirely from the kidneys. In another cohort, plasma NT-proBNP always was elevated in patients with clinical and echocardiography evidence of cardiac involvement, and the best cutoff according to this trial was the number of 152 to distinguish the people that they have affected by the light change, the amyloidosis in the heart. Furthermore, no patient with met the echocardiographic criteria of amyloid heart involvement had normal NT-proBNP, and this was stable within each renal function group. Patients with heart involvement had significantly higher concentrations of both natriuretic peptides compared to subjects without echocardiography evidence of cardiac amyloidosis. And in a cohort, there is suggests that the BN natriuretic peptides have good diagnosis accuracy in case of reduced GFR, but with higher NT-proBNP cutoff levels. A higher NT-proBNP cutoff was required to the detection of heart involvement in patients with moderate or severe renal dysfunction, and the BNP cutoffs were almost identical in the severe when there was a decrease in GFR compared to the NT-proBNP. So the amyloid cardiac involvement can be excluded if the NT-proBNP is less than a cutoff value. should be used with great caution as a prognostic marker in subjects with end-stage renal disease. Can be used in all patients, the BNP, in respective of renal function, but in more elevated cutoffs. And when we have an intraventricular septal thickness more than 12, in the absence of other cause of NT-proBNP elevation, and in the absence of end renal disease and atrial fibrillation, is widely accepted as a diagnosis criterion for detection of AL heart involvement in AL amyloidosis. The evidence for the diagnosis for the troponins are not so strong. It's known that the troponins are more elevated in AL than transthyretin cardiomyopathy, and this is supposed to be because of the cardiotoxicity of the light change. But anyway, it's useful for the detection of the heart involvement, and a cutoff of troponin high sensitive was shown to have sensitivity of 74 and specificity of 76 in the diagnosis of amyloidosis in patients with LVH. And this can be used with GLS as a in a stage system with GLS and the relative apical sparing in the detection or exclusion of cardiac amyloidosis. Other biomarkers of the diagnosis is hepatocyte growth factor, which has a significant difference among patients with AL compared from AL compared with patients with ATTR when there was LVH, and it's useful to detection the patients who have AL among individuals with clinical suspicion of the disease. Natriuretic peptides are significantly lower in ATTR than in AL. After adjustment for left ventricular mass and renal function are higher in wild type than in the inherited type. And in inherited type, the biomarkers variability increase according to the presence and the severity of the cardiac involvement and the mutation.
I hate to interrupt, Dr. Musta, we're running out of time.
I will go forward
Thank
to the risk stratification. Three systems are staging systems using the cutoff values of NT-proBNP troponin and the free light change amount in the plasma. According to this, there is a prognosis, the medial overall plausibility. All of the staging systems are having a statistically importance in the prognostic value. Other biomarkers in AL is under investigation. In ATTR amyloidosis, the troponin, the BNP, and the NT-proBNP and the INGFR are biomarkers that is very useful to the staging the disease. And I'm going to the future. In the future, at least other novel biomarkers have been studied in patients with amyloidosis. Also, a multi-maker strategies for stratification are proposed using the VO-max and NT-proBNP, and at the diuretic dose and NICA functional class as independent predictors when used with classical stage models. And as conclusion, to say that in AL amyloidosis, the NT-proBNP, the troponins, and the free light change difference can diagnose and risk stratification is useful for risk stratification and diagnosis. In transthyretin, the INGFR, and the NT-proBNP. And as a conclusion, we have to remember the cutoff values in the diagnosis and the risk stratification of the disease. Thank you. Sorry for the delay.
Thank you very much, Dr. Musta. That was a wonderful lecture. I, for one, was not aware of the importance of the biomarkers in this disease, so that's quite amazing. I pass over to Dr. Hadis for the next speaker.
And now, with immense pleasure, I'm going to invite to the podium my dear friend and colleague, a renowned scientist and researcher, Dr. Andrew Xanthopoulos, Assistant Professor from the University of Thessaly.
Good morning, everyone. I would like to thank Professor Patrikios for the kind invitation and for the topic of this presentation, which I think is very interesting because this is a typical example of the intersection between molecular biology and clinical cardiology. Can I have the presentation, please? Okay, excellent. Okay, so what is amyloidosis? Amyloidosis is a localized or systemic disease characterized by the deposition of misfolded proteins that aggregate into amyloid fibrils. Those fibrils deposit in the cardiovascular system, in the ocular system, in the kidneys, and several other systems. More than 30 proteins form amyloid fibrils. And the most common forms of cardiac amyloidosis is AL amyloidosis, characterized by aberrant plasma cell production of monoclonal light chains, and ATTR amyloidosis, which is characterized by the production of transthyretin by the liver. TTR amyloid deposition in the myocardium leads to the enlargement of non-cardiomyocyte area, left ventricular hypertrophy, and diastolic dysfunction. It's the typical pattern of restrictive cardiomyopathy. It increases reactive oxygen species and leads to left ventricular systolic dysfunction. The result is the alteration of the pressure volume shift downwards and to the left. Amyloid deposition leads to cardiac damage manifested by a spectrum of phenotypes. In other words, patients with cardiac amyloidosis may have either reduced, mid-range, or preserved ejection fraction. Diverse heart failure phenotypes converge to neurohormonal overactivity syndrome. Indeed, in this study by Vergaro et al., which included 3 cohorts, 190 patients approximately each, with heart failure with preserved, reduced, and mid-range ejection fraction, it was shown that neurohormonal activation is present not only in patients with reduced, but also in patients with mid-range and preserved ejection fraction. The same research group published a very interesting paper in the amyloid that showed that patients with cardiac amyloidosis have a greater neurohormonal activation compared to those with non-amyloidotic heart failure. NT-proBNP is a marker of neurohormonal activation, and Dr. Ioannou and colleagues showed that it's also a marker of disease progression in patients with cardiac amyloidosis. And as previously Professor Sinetos mentioned, there is a clinical spectrum of patients with wild-type cardiac amyloidosis. In other words, there are also women who are affected in a significant proportion of patients, patients who have asymmetric left ventricular hypertrophy, impaired left ventricular ejection fraction, and only in the study a minority had low QRS voltages. So let's move on to the medical treatment and the guideline-directed medical treatment for heart failure. What is the evidence in patients with cardiac amyloidosis? Should we use neurohormonal inhibitors in those patients? Let's start with beta blockers. Why beta blockers? Because cardiac amyloidosis may present not only with result, but also with reduced ejection fraction. And we know from the guidelines that the beta blockers have a major role in those patients. Secondly, regarding the pathophysiological mechanism, the main mechanism in cardiac amyloidosis is the amyloid accumulation in the interstitium, but also fibrosis is another mechanism, likely elicited by pro-fibrotic pathways, including adrenergic and renin-angiotensin-aldosterone system axis activation. Last but not least, cardiac amyloidosis is accompanied by neurohormonal activation, namely sympathetic overactivity, as shown previously. There are a couple of systematic reviews and meta-analysis in the topic. The first by Kang and colleagues, who showed that overall the results were neutral, but there was a clear trend in the subgroup of patients with reduced ejection fraction. And a more recent meta-analysis, which included more patients from the Kwok et al., which showed that all-cause mortality was associated with beta blocker use. Please note that more than half of patients in this meta-analysis were on beta blockers. A landmark study by Ioannou et al., which included 2,300 patients with ATTR cardiac amyloidosis, showed beneficial effect of beta blockers, especially in the lower ejection fraction. So there was no association between the use of ACE-ARBs and increased survival, and the use of MRAs was associated with better outcomes. So we have good data, promising data for beta blockers, especially in the lower ejection fraction, and MRAs, especially in the preserved ejection fraction. The evidence regarding ACE and ARB is neutral. In the same study, survival in patients treated with 3 heart failure medications was better compared to patients treated with 2 heart failure medications. Very interesting study by Sperry et al., published in JACC Heart Failure back in 2021, showed that a subgroup of patients from the TOPCAT trial with characteristics of cardiac amyloidosis, namely S-wave velocity in the TDI, in the echo TDI of less than 6 centimeters per second and IVS thickness more than 1.2 centimeters, those patients had a similar benefit with spironolactone compared to other groups. The P4 interaction was not statistically significant. What about safety and tolerability of the neurohormonal inhibitors? It seems that it is acceptable, especially if the uptitration is slowly and gradually, and also the follow-up is close. SGLT2 inhibitors, we have very important data with this class of medication, not only in heart failure in general, but also in cardiac amyloidosis. Their renoprotective and cardioprotective effects are established. This is a very interesting study by Percuri et al. This was an observational study in more than 2,300 patients with cardiac amyloidosis, which showed that the use of SGLT2 inhibitors was associated with reduced all-cause mortality, reduced cardiovascular mortality, reduced heart failure hospitalizations, and also with a lower decline in the eGFR slope compared to patients who were not on SGLT2 inhibitors, improved NT-proBNP without significant changes in the systolic blood pressure. Very interesting study by Augusto et al. Showed that the use of SGLT2 inhibitors was associated with better outcomes in patients with cardiac amyloidosis, irrespective of the presence of heart failure. Regarding the safety of AGLT2 inhibitors in cardiac amyloidosis, either ATTR or AL, it is very good. And let's move on to the guidelines. Despite the promising results from the observational studies that I just mentioned, the guidelines remain cautious, both in the 2021 ESC guidelines for the heart failure and the 2023 ESC guidelines for the management of cardiomyopathies. It is stated that there is no evidence to support the use of standard heart failure therapy, which often is not well tolerated apart from diuretics. However, in the more recent ACC Expert Consensus 2023 of the ACC, it is stated that MRAs and SGLT2s may be considered in patients with cardiac amyloidosis. In conclusion, dear colleagues, both in AL and ATTR cardiac amyloidosis, misfolded proteins aggregate into amyloid fibrils that deposit extracellularly in the interstitial space of the myocardium, resulting in restrictive cardiomyopathy. Patients with cardiac amyloidosis have a greater neurohormonal activation than those with non-amyloid heart failure. The clinical spectrum of amyloid cardiomyopathy is heterogeneous and differs from the classic phenotype. Women are also affected. We may have asymmetric left ventricular hypertrophy and impaired left ventricular ejection fraction. Beta blockers may be associated with better survival, especially in the lower ejection fractions. MRAs and SGLT2 inhibitors may be associated with improved outcomes based on data from observational studies. However, we need randomized controlled trials. This is my last slide. As our understanding evolves, the traditional one-size-fits-all approach to heart failure therapy must be replaced by careful, selective, and personalized modulation of the neurohormonal axis. Thank you very much.
Thank you so much for the excellent presentation. There will be time for questions after the end of the presentations. Let's move on with the next speaker.
Now it's time to call Professor Toutoutzas he will speak about amyloidosis, aortic stenosis, and TAVI. Professor Toutoutzas has a lot of titles, and we are out of time. The most important is the president of the Hellenic Cardiological Society. He's the most experienced, according to me, he's the best interventional cardiology in Greece. And he honors me with his friendship for more than 20 years, so we are looking forward to listen what you're talking.
Andreas, thank you very much. I think our friendship is shown by your comments. Anyway, I would like to thank Professor Patrikios and all the organizing committee to be privileged to be here. And I really enjoy all the session devoted to the amyloidosis. And I'm really happy to share with you all my experience with TAVI in this field. So we've heard already about the amyloidosis within the arterial wall, within the myocardium, within the aortic valve. Of course, it's a protein deposition disease. It can also be deposited also in the arterial wall, but also in the calcified modules of aortic valve and also in the myocardium. When we're talking about amyloidosis, especially in elderly patients with aortic valve disease, we are concerned about the ATTR amyloidosis. This is the variant which also involves heart, approximately to 70% of the cases. I don't want to waste more time about that. There is a concomitant pathology of aortic stenosis. Cardiomyopathy is common in older patients, can be predicted clinically, not always, but you can also have sometimes. And what we know that aortic stenosis with cardiac amyloidosis has a worse clinical presentation and a trend toward worse prognosis, unless treated. Therefore, we should do something. You should do something with these patients, either surgically or TAV. And of course, when we are talking about elderly patients, we're talking about the transcatheter aortic valve replacement. So this is the only answer that we have in this population. And this population is not so uncommon. It's approximately 1 to 1.15%, 10 to 16% of patients with severe aortic valve disease undergoing TAVR. So 1 out of 10 or 1.5 out of 10 in patients that are undergoing replacements of the aortic valve, they have also cardiac amyloidosis. It's not so uncommon. We should have it in mind. And the prevalence of cardiac amyloidosis, as you see in patients with aortic valve stenosis, it's more than heart failure, more than hypertrophic cardiomyopathy. So we should keep it in mind that always, especially in patients that we don't have improvement of symptoms after the replacement, we should keep in mind that this patient may have cardiac amyloidosis. So the pathophysiologic links also is represented by and expressed in the clinical field by the advanced age in these patients. The estimated prevalence, as I already told you, is this in our population, it's around 11%, not less, not more than others. However, where's the problem? We don't diagnose these patients. So these patients come for a replacement of the aortic valve, and we don't have it in mind that there are some red flags that we should diagnose the patients with amyloidosis. And this is very important because after the treatment, if we don't see a very significant improvement, then we should also be suspicious that aortic cardiac amyloidosis is not diagnosed. So 1 out of 10 is there when we look for them, but we don't diagnose them. And here again is the percentage of patients with aortic valve stenosis in patients with cardiac amyloidosis. So moderate or greater aortic valve disease is associated with worse outcomes in these patients. And you can see the calcification, the fibrosis, and also the amyloidosis that may play a role in the development of aortic valve disease. The infiltration of myocardium and valves is frequent and often comes as the red flag that raises the suspicion of cardiac amyloidosis. And which are the red flags? Here you may see the red flags. The ECG low voltage despite hypertrophy, pseudo-infarction pattern. Biomarkers, we've already heard about the BNP. The echocardiography, severe biventricular hypertrophy. Biventricular is not concomitant with aortic valve stenosis. So we should keep it in mind. The myocardial granular sparkling, also. Severe LV longitudinal systolic dysfunction with apical sparing. And of course, if we do CMR, then we have a diagnosis. Of course, we don't have CMR in our workout in patients with aortic valve disease. So if we have a suspicion, then we have to confirm this, especially by scintigraphy or CMR, and then we should also take into account the therapeutic approaches to these patients. In parallel with this axis, we also run the red flags for the aortic valve stenosis. That means we should find out where there is high gradient or low flow, low gradient aortic valve stenosis, and we should evaluate by CT, examine the deposition of calcium in these patients, the aortic valve infiltration, we cannot quantify this, and by CT, as I already told you, in women more than 1,200 Agatston score, or in men more than 2,000 Agatston score in men, then we confirm that there's a low flow, low gradient aortic valve stenosis. And the treatment is parallel again. Parallel with the therapeutic approach of amyloidosis, we should proceed also with the aortic valve replacement in these patients. Of course, we have to use also our clinical history of this patient and examination of these patients. So you can see that if there's dysautonomia or generally from the CNS system, if you have symptoms, it goes also, it raises a suspicion about cardiac amyloidosis. Trigger finger is also another sign. Bilateral carpal tunnel syndrome and other proteinuria and other things that we should keep in mind as some flags raising the suspicion of cardiac amyloidosis. In regards to the cardiac features, hypotension, natural cure of hypertension. It's also a patient gets antihypertensives, and suddenly, after 6 months, after 1 year, the patient is getting hypotensive, and he doesn't need these drugs. There's a suspicion of cardiac amyloidosis. Also, symptoms of heart failure, shortness of breath, edema, dizziness, syncope, and especially the ECG, if somebody develops, as I already told you, some signs, especially pseudo-infarct pattern, low voltage mass ratio, and AV block conduction systems. All these patterns are suspicious for cardiac amyloidosis. And we know that if we leave these patients only on medical therapy and not a therapeutic strategy, then we have 50% increase of mortality in patients with aortic valve disease. It's a very significant number, especially in patients that have cardiac amyloidosis. The same has been shown also by the surgical replacement. It's not only TAVI. So cardiac amyloidosis with aortic valve stenosis should be treated. If we treat these patients with TAVI, do we get the same results like the other population? There are conflicting results in this field. Some studies have shown that amyloidosis is associated with a higher thromboembolic risk after TAV. It means that stroke. Of course, this is only one study. In the Campos TAVI trial, there was 7% was severe aortic valve stenosis that with cardiac amyloidosis. They didn't see any negative impact of cardiac amyloidosis. Among patients undergoing TAVI, higher adverse event was also found in this study. They had increased risk of pacemaker implantation, which is logical because in these patients with cardiac amyloidosis, you have a conduction problem in the heart. Clinical outcome, there are several studies. I don't want to get into the detail in all the studies. Some have conflicting results. The bottom line is you have to diagnose this and you have to know it either before or after TAV. And why? Because it's associated with increased mortality risk in this amyloid trial and worse outcomes after TAVI. This is one of our studies. And in a large population of 407 patients, cardiac amyloidosis had a worse clinical presentation and a worse prognosis unless treated. So treatment changes the natural history. I have two cases to show you. TAV in cardiac amyloidosis patients with severe aortic valve stenosis. We did the SPECT, severe aortic stenosis and SPECT, and you can see we had the by scintigraphy, we had the diagnosis. You can see the cardiac amyloidosis pattern, which is typical for the radiologist. Again, you can see it here, that there is amyloidosis in this patient. So should we proceed with TAVI? Yes, indeed, although it has, you see here with the green, patients with aortic valve stenosis alone. And with the black, patients with aortic valve stenosis alone without treatment. Now you can see that it goes parallel. The blue is the patients that have cardiac amyloidosis but treated, and with the red, they have the worst prognosis, cardiac amyloidosis, and not treated. So you can see that if we treat these patients, we have a better outcome compared to the black, which are patients with aortic valve stenosis not treated. So we change the natural history of these patients. Question 2, does transcatheter cardiac amyloidosis affect outcomes and survival? As I told you, there are some concerns, especially regarding the pacemaker implantation. Other studies have not shown this. I don't want to lose more time on that. the bottom line is the treatment of aortic valve stenosis. And this is second case, 84 male patients, severe aortic valve stenosis and cardiac amyloidosis. Here you can see the coronary angiography. There is no, fortunately, there is no coronary artery disease, the third problem that we should lose, you should have. And you can see by the echo, the sparkling myocardium, especially for the experienced here echocardiographers, low voltage in the ECG, and very significant aortic valve stenosis with a Vmax more than 5. To the computer. Okay. Okay. As you can see, the Vmax is more than 4, so it's a significant aortic valve stenosis, and we had to treat this patient with aortic valve, with TAV. So in conclusion, I don't want to have more time, cardiac amyloidosis remains a vastly underdiagnosed condition in patients with aortic valve disease, especially in TAV, in the real world. Patients with amyloidosis undergoing TAVI have more comorbidities compared to the all-comers of TAVI. The presence of cardiac amyloidosis is associated with increased mortality risk in patients with undergoing TAVI, and the worst prognosis is the combination of valve disease with cardiac amyloidosis. Thank you very much for your attention.
Thank you for the excellent presentation and for keeping time. We will have a 10-minute interactive discussion. Please, we'll do some minor changes on stage, and I would like to ask for the presenters to join us on stage for the discussion.
So thank you to all our speakers for their fantastic lectures. Now this is a question and answer session, a discussion session. We've got 8 minutes, I've been told. I'd like to start off the discussion by asking Dr. Toudrouzas, whose lecture was very clear, 2 questions that are very closely related. The first, you've mentioned that 15% of TAVI patients have amyloid. Should we be screening not just from the red flags? Should we be screening officially every single patient, maybe with a bone scintigraphy or whatever? What do you think of that?
I think you can hear me now. Very important question, and I would like to ask you to answer clearly. In my clinical practice, I send every patient to do scintigraphy. It's half an hour, there's no problem, no side effects, no allergy things, so you know that this patient needs to be treated or not.
Wonderful. And the second part of my question relates to that because this is an extra cost, so economical implications, plus the fact that if we find these patients, which we will, the drug costs are going to be huge. So what about these financial implications? How do you view this?
You know, all these financial questions, of course, we have to keep them in mind. I fully agree with you. But if you see the history of cardiology the last 25 years, let's say from 2000, you're going to see that the prices that we have in several things today has nothing to do tomorrow. And I try to remind you that the prices of stents in the early 2000s were 3,000, 4,000, 5,000 euros, and now, at least in Greece, the same stents like the Giants is 120 euros. So I think that the cost effectiveness needs to be taken into account. On the other hand, if you do a TAVI to a patient that you know that has very, very bad prognosis, and you don't provide him the careful administration of drugs for our cardiac amyloidosis, then you lose the patient, and you lose also the money that you deposited on TARP. So I think, yes, we have to take into account, but on the other hand, we're talking about a very limited population, 1 out of 10. So we're talking about, if we are doing 2,000 TAVIs in Greece, that means approximately 100 cases, 200 cases per year. I think we can afford this.
Thank you. Very clear answer. Please.
I will come to strongly agree with Professor Toutoudas regarding the use of bone scintigraphy. Let's remember that this particular diagnostic modality has changed the landscape regarding the diagnosis of ATTR amyloidosis, thus obviating the need to perform routinely a cardiac biopsy, and we all know how dangerous might that be. Don't forget always that whenever we have a perugenic grade score of 2 or 3, we reach a sensitivity of about 100%, so it's worth it, that's for sure. Thank you.
Excellent, thank you. Any questions from the audience? Yes, Dr. Adamopoulos and then Dr. Kokinos.
Dr. Athanasopoulos, thank you very much. Yes. It was a great topic, so nicely given by Professor Toutoudas, and as the chairman stated, is of paramount importance to see the clinical relevance of this area. Kostas, in practice, in these studies, we have selected patients with aortic stenosis having a wall thickness of at least 12 millimeters. In real life, and according to our experience in our center, this is not a usual scenario. The patients with aortic stenosis, the mean age for TAVI in my institution is 82 years old. And half of those, they don't have increased wall thickness. So if you take into account this estimation, the prevalence is much lower, not 10%. In real life, if you take the patients without wall thickness, it's much less. And second, as the years go by, we know that in autopsies, patients, octogenarians, have in autopsies 20% deposits of amyloid in heart. The amyloid production is a biological evolution. So a third point is that the perugenic score, which is used, if it is applied in a widespread mode, you know the counting from 1 to 2 to 3, there is a great possibility to find perugenic score of 1 in a great percentage. So we should be very careful. Of course, there is a great advantage of the therapies, and also don't forget that the therapies produce their effect after 2 years, and the effect is related to quality of life and hospitalizations. It is not proven that these therapies, these expensive therapies, increase longevity in life survival. So I think that the community has to be aware of all these facts. There is an enthusiasm, it is understandable, we have to keep this pace you have described so elegantly, but we have to take into account all these limitations.
Thank you very much for this comment, and I would like to respond in this way. First of all, yes, indeed, in our population that we examine the whole population of TAVI population, that means not patients with hypertrophy or not, everybody. We include all the patients. It was less than 10%. It was around 8.6% in our population. So indeed, now I don't know if it's in a population-based study, if it's 8.6 or 11.1, if there's a great difference and impact of cost effectiveness. However, I agree with you that if you do scintigraphy to all the whole population, maybe less, and not just a criterion of hypertrophy. On the other hand, we're talking about expensive therapies, which I fully support with you, and I think it's very important to avoid to do to these patients TAV, because it's very expensive, rather than avoiding to provide him the therapy if you know that he has amyloid after TAV. So if you don't if you don't give any therapy to a patient of 90 years old, that's something that we have to answer as a community. But if you provide the therapy to a TAV to a patient of 90 years old, then you have to provide the whole packet. And that means also for amyloidosis. This is my perspective.
Thank you. Before we go to Dr. Kokinos, Dr. Sinetos has a comment.
I would agree with Professor Athanasopoulos. I think nowadays we cannot be sure about the cost-benefit of this therapeutic process, but at least what we can do is that we can identify the patients that we have to see them after the TAVI procedure more often, to understand more closely, to understand that we are speaking about the restrictive pattern, so that we have to be very careful about the follow-up or the treatment in the CCU unit of the fluids and all the balance, and even to identify patients that they will need earlier to go for a pacemaker implantation, even before the TAVI, as the Gary registry did in Germany. So maybe the balance, the financial balance, is not it's not enough. We cannot say about too many things, but at least we can help some patients to identify them, and they will have a better outcome.
Thank you. Professor Kokinos.
There is another aspect to that as well. In basic research, it has been proven that increased pressure by mechanotransduction increases protein misfolding. So possibly aortic stenosis itself may be precipitating more amyloid deposition. So this remains to be proven, but there are elements in that. So possibly doing TAVI earlier, we might stop the process of amyloidosis. And I think now we have enough data that we could be trying to study this with so many patients available and so much knowledge available. So we should not forget that there might be a causal relationship, not just a coexistence. And the other thing, for Professor Xanthopoulos, could heart rate variability by Holter help in diagnosing amyloidosis and neurohumular activation? Do you think, is there some data on that?
Thank you very much, Professor Kokinos, for this excellent question. Patients with cardiac amyloidosis have lost their chronotropic. They have chronotropic incompetence, and this is a very big issue for those patients. That's why they cannot tolerate beta blockers. So there is evidence from small studies that the variability in their heart rate is small, and but we don't have enough data to justify the use of heart rate variability in those patients for prognostic reasons.
Professor Nichoyanopoulos has a comment.
Great session. Now, there is a tendency to intervene earlier in patients with aortic stenosis. So the age population, Professor Toutos, as you mentioned, is probably octogenarians, septuagenarians, but if there is a tendency to intervene earlier, the incidence or the prevalence of amyloidosis is less, and may act as preventing the trigger of amyloidosis that Professor Kokinos mentioned. So where are we today in intervening earlier in patients with severe aortic stenosis? It's not quite in the guidelines yet, but I know many centers do it.
Yeah, at least in Greece, we have the cutoff value is still 75 years old. It was 80 years old. That's why in all our registries, 82 was the average like us. But now it's less. It's more than 75. In the guidelines, as you know, since September, 2 months ago, they had the cutoff value of cutoff age of 70. They proposed. However, this needs to be also passed in the regulatory authorities. So I think yes, indeed, the age will be more and more less, and we're going to see less and less cardiac amyloidosis. Now, regarding this, if the mechanical impact of aortic valve stenosis has a biological impact on amyloidosis, it's very intriguing, and we have to find it out. Yeah, definitely.
Any more questions or comments before we wrap up? Wonderful. Thank you for a great session.
Andrew. Κάνουμε μια φωτογραφία.
Hello everybody. Should we start the next session, which is the 14th session of this Congress? Thank you very much. It's my pleasure to introduce Dr. Konstantinidis, Savas Konstantinidis. He is an interventional cardiologist in Cyprus at two institutions, the German Medical Institute and the American Heart Institute. He is going to speak to us about the utilization of drug-coated balloons in contemporary percutaneous coronary interventions. Okay, Sava, thank you. Please start.
I would like to thank Professor Patrikios for the kind invitation and congratulate him on the organization of this excellent event. So, this beautiful journey started in 1977 when Andreas Gruzik performed the first balloon angioplasty in a proximal left anterior descending artery of a 50-year-old man, which went very well and lasted him for years. However, plain old balloon angioplasty, as we call it, has been problematic because of complications such as acute vessel closure, recoil, and restenosis. So then came the next milestone in interventional cardiology, the stents. With the gentleman on the right was one of the pioneers who implanted the first stent in the mid-80s. Bare metal stents solved the problem of acute vessel closure and recoil, but had the problem of very high wrist stenosis. So the story from then was a matter of improving the stents, coated stents with anti-proliferative drugs. The drug-eluting stents came along. They solved the problem of wrist stenosis, but were problematic in terms of stent thrombosis. And then this gradually improved to the point that the stent thrombosis was low. However, we began to realize that leaving behind a permanent implant in the coronary arteries was not without any problems. There was an idea of bioresorbable vascular scaffolds, in other words, stents that would dissolve in the artery after a few months, but they were disappointing because they were thick and difficult to deliver, and they had very high rates of stent thrombosis. So why do we need alternatives to stents? Late stent thrombosis is a problem. Persistent neointimal hyperplasia, neoatherosclerosis, the need for long-term dual antiplatelet therapy. Our surgical friends will agree that they hamper future bypass attempts, and they compromise late luminal enlargement by engaging the artery in a scaffold that doesn't allow the vasomotor function to perform properly. So what is the idea of the drug-coated balloon? The idea is to inflate the balloon at the site of a stenosis that would deliver an anti-proliferative drug, usually paclitaxel or sirolimus, into the vessel wall, and then the balloon is removed with no residual scaffold left behind. So could potentially PCI aim at using a drug-coated balloon-only strategy? In other words, perform PCI without leaving anything behind? Well, it is important to perform a good TCP procedure in order to have a good result. So the most important thing is to prepare the vessel properly. In other words, to dilate the vessel appropriately with a non-compliant balloon in a 1-to-1 vessel ratio, and if necessary, use adjuvant techniques such as scoring, cutting balloons, rotational atherectomy, or intravascular lithotripsy. And we should remember that the drug-coated balloon is only to deliver the drug and not to open the artery. The definition of a successful drug-coated balloon ideally would be a stent-like result, but we know that we don't very often get that. But anything less than a limiting dissection, type C dissection, normal flow, and less than 30% residual stenosis is considered to be a successful procedure. At the beginning of the learning curve, there's a low threshold for stent usage, but in well-experienced centers and operators, this is well below 10%. So what are the indications? The well-established indications are those of in-stent restenosis and small vessel disease. But as you see here in contemporary PCI, these indications have extended to large de novo coronary artery disease, bifurcation lesions, diffuse coronary artery disease, diabetic patients, patients with high bleeding risk, and even in acute coronary syndromes. The most well-established indication is for in-stent restenosis. It has the advantage of avoiding multiple layers of metallic stents, reduces the need for prolonged DAPT, allows repeatability of the procedure if restenosis occurs again, and it is a well-established treatment that gained the Class 1A recommendation in the 2023 ESC guidelines for revascularization. In small vessels, in other words, vessels with diameter of 2.5 or less, it has been shown that they fare better than drug-eluting stents, mainly by reducing vessel thrombosis. In de novo large vessel lesions, it has been shown that drug-coated balloon, even in patients with acute coronary syndromes, is non-inferior to bare metal or drug-eluting stents. And in some cases, such as in ostial lesions where putting a stent can be technically difficult, or in patients with high bleeding risk, it may even be superior to drug-eluting stents. In bifurcation lesions, they are very useful. We often treat the main branch with a stent and the side branch ostium with a drug-coated balloon, but we can do a drug-coated balloon-only treatment for both the main branch and the side branch. In diffuse long lesions, the hybrid approach of putting a drug-eluting stent in the proximal disease and performing drug-coated balloon for the distal disease has been shown to be non-inferior to drug-coated balloon only. But in comparison with drug-eluting stents, and after 2 years of follow-up, it has been shown that by reducing the stent burden in multivessel disease, we improve long-term outcomes. In other words, less metal equals better outcomes. Again, in acute coronary syndrome, there has been shown to be non-inferiority to drug-eluting stents. And in a large meta-analysis of 26 randomized controlled trials, it has been shown that at 3 years follow-up, all-cause mortality is significantly lowered with drug-coated balloons when compared to drug-eluting stents or bare metal stents or plain old balloon angioplasty, mainly by reducing cardiac mortality. So I'm just going to go through some case examples, practical case examples. This is a 74-year-old male with a previous anterior MI, a stent in the proximal LAD, and a severe in-stent restenosis. That was treated with a drug-coated balloon with good results. This is the final result. A second patient, a 77-year-old female with easy fatigue and an abnormal stress test. She had bradycardia during induction for spinal surgery, so the anesthetist canceled the operation and demanded that we dealt with her coronary disease before they could operate on her. So obviously there is an inability to take long-term dual antiplatelet therapy. She had no significant circumflex or right coronary artery disease, but she had a significant stenosis in the LAD, which was treated with a drug-coated balloon only. The patient underwent spinal surgery on aspirin alone after 1 month of DAPT with no complications. The third case is a case of a small vessel disease in an 80-year-old man with ongoing angina following an unstable angina episode, a mild aortic stenosis, a diagonal vessel, 2.5 millimeters vessel, was treated with drug-coated balloon only. And the patient remained asymptomatic after 1 year follow-up. Fourth case, a relatively young patient with acute coronary syndrome, an anterior non-ST elevation MI with a severe stenosis in the LAD at the bifurcation with a diagonal. Again, we performed a drug-coated balloon-only strategy with a good angiographic result in the LAD without leaving any stents behind. The last case is a 72-year-old Russian female who went into pulmonary edema as soon as she got off the plane for holidays in Cyprus. She had an acute coronary syndrome and diffuse 3-vessel coronary artery disease with severe circumflex LAD disease and an chronically occluded right coronary artery. The patient was in pulmonary edema when we treated her in the cath lab. So we performed the implantation of a drug-eluting stent in the circumflex, followed by a drug-coated balloon-only strategy in the long LAD disease. So that was a hybrid approach with a good final result. At 6 and 12 months, the patient was pain-free. At 12 months, she underwent total thyroidectomy without any complications, and she remains symptom-free after 6 years. And the reason I know that is that she sends me a happy birthday message every year from Russia, so I know she's well. So the take-home message, ladies and gentlemen, leave nothing behind PCI is an appealing concept using drug-coated balloons, perhaps while waiting for better bioresorbable vascular scaffolds. Currently, there are 3 well-evidence-based indications: in-stent restenosis, high bleeding risk patients, and small vessel anatomy. However, promising data for other situations such as diffuse long lesions, bifurcation lesions, acute coronary syndrome, calcified lesions, and finally de novo lesions in large vessels, especially in certain anatomies such as osteal disease. A wise man once said, "I believe the future is only the past again entered through another gate." It seems that for PCI, drug-coated balloons could be the gate to a safer return back to the future of old balloon angioplasty. Thank you for your attention.
Give me a second. Stay. Thank you for this excellent presentation. Please stay at the podium because I think it's better to take questions after each presentation due to the fact that there are different subjects. Okay. Any questions that you would like to? Yes?
Congratulations. Very nice overview of the use of and the examples for DCBs. I would like to ask you, in the light of the new studies that we had in TCT 15 days ago regarding the de novo lesions and the incident stenosis, because we had also, is this a class effect or not, according to the bibliography, or we should focus only on the findings of the studies?
I don't think it's a class effect. I think there are differences between the drug coating on the balloons. For example, paclitaxel has been shown to result in positive remodeling. In other words, the vessel grows after the treatment, after a few months. It's an effect that sirolimus hasn't been shown to have that effect. So no, I don't think it's a class effect, but I think like everything else in medicine, we should try and individualize for each patient an anatomy and do what we think is best for the particular patient.
Any other questions? Yes, please.
About this class effect, I think, in my opinion, is that, of course, there's no class effect. There's no question about it between paclitaxel and sirolimus, but it's also not a classic effect in terms of the delivery system, because we have a great heterogeneity of delivery system of wells that we don't know exactly what is the pharmacodynamics of the medication. So what we see in a specific study with a specific delivery system with a specific agent, like what we saw with the sirolimus, probably cannot be applied for all devices.
This is true. I mean, the properties of paclitaxel and sirolimus are different in drug delivery, and that's why it took much longer for the sirolimus eluting balloons to evolve.
Anybody else? Okay. Thank you very much, Sava. Thank you. Excellent presentation.
For our next talk, I would like to call Dr. Athanasios Kartalis to the podium. Dr. Kartalis is an interventional cardiologist, director of the Cath Lab and Heart Failure and Electrophysiology Unit in Chios General Hospital. He will give us a lecture on how to diagnose and manage myocardial infarction with non-obstructive coronary arteries.
Good morning. I'd like to thank Professor Patrikios for this invitation. MINOCA definition changes over the year. The definition now in effect is symptoms suggestive of acute coronary syndrome, troponin elevation, and when we perform a coronary angiography, we have non-obstructive coronary arteries, means that stenosis less than 50%. This is the definition of MINOCA. Many different causes underlying. Coronary causes, mainly coronary embolism, coronary spasm, thrombosis, rupture of coronary plaque, and spontaneous coronary artery dissection. This is coronary causes. There are non-coronary but cardiac causes like cardiac trauma, myocarditis, or Takotsubo, and many non-cardiac causes like pulmonary embolism, sepsis, or end-stage renal failure. Is the prevalence high? The answer is yes. About 10% of patients with acute coronary syndromes have MINOCA. We should suspect the diagnosis in young women with no classical atherosclerosis risk factors, and often involves microvascular dysfunction. The most common mechanism of MINOCA remains the plaque disruption, about 40%. MINOCA is a benign condition. The answer is no, because as you see here, about 10% 12 months after a Minoka will have another mace, and 3.5, they will lose their life. So Minoka is not a benign condition. Minoka is a working diagnosis, and physicians should perform more investigation to reach the final diagnosis. Let's see a practical approach to find the cause of Minoka. Taking in account that the ischemic pattern is the most common, we have to follow the cath lab approach to perform a coronary angiogram, including left ventriculography, to see carefully if there is side branch disease or spontaneous coronary artery dissection, and if we don't have findings, it's essential to proceed to step 2, to find if there's epicardial territory infraction. If there is territory infraction, we should perform IVUS or OCT, and if there's no territory infraction, we should perform microvascular assessment with functional coronary angiography using FFR, coronary flow reserve, index myocardial resistant, and vasoreactivity testing. In this slide, we will see that if we have abnormal values in index microvascular resistant and CFR, we can diagnose that we have microvascular dysfunction. And if we perform an acetylcholine test, then we can diagnose that the patient have epicardial spasm. It is very significant, this slide, but most significant is the role of cardiac magnetic resonance in Minoka, because we can diagnose the cause. This is the important, to diagnose the cause of Minoka, because different diagnoses have different treatment. You see that here is symbolic small infraction. Initially, we have edema in CMR, and finally, we have subendocardial scar. But in myocarditis, we have edema, and finally, epicardial scar. In Takotsubo, we have edema and no scar at the end. The next question is, when is the proper time to perform CMR? Here, we see that it's very significant to perform the CMR in patients with Minoka the third day, meantime, not 2 weeks after the episode, because we have 77 of patients right diagnosis versus 47 patients when we delay the CMR. This is an algorithm to diagnose the underlying cause of Minoka. We have patients with symptoms of acute coronary syndrome, troponin elevation, as we said before, and TCG findings. We perform the coronary angiography. The stenosis are less than 50%, so we have a Minoka patient. If the underlying of Minoka is not established with invasive coronary arteriography and we have epicardial territory infraction, we perform IVUS or OCT. If there is no epicardial territory infraction, we perform a vasoreactivity test, IMR and CFR. And if we don't have the diagnosis, we should perform cardiac magnetic resonance. And if we suspect coronary embolization, we should perform transesophageal or contrast echocardiography. The recommendation of most recent European Society of Cardiology is to perform CMR imaging in patients with Minoka if we don't have the diagnosis after the invasive coronarography. and the multimodality imaging is very significant in Minoka. When we combine OCT with CMR, you see that only 15% of the patients will remain without diagnosis. And Professor Toutouras will ask me, how often do you perform this difficult and very dangerous examinations like acetylcholine test? The answer is here. This working group says that PET is the reference standard for non-invasive assessment of coronary microvascular dysfunction, so we skip these difficult tests. And another very fine imaging, deoxygenating hemoglobin can be imaged to reflect the level of blood oxygenation and to demonstrate the coronary microvascular dysfunction. Are there randomized controlled trials on secondary prevention for treatment for Minoka? The answer is no. We have only registries. From this registry, you can see that only the use of statins and ACE inhibitors reduce mortality. Beta blockers have a tenth of positive effect and a neutral effect of dual antiplatelet therapy. The AHA recommends supportive care in emergencies in patients with Minoka, to treat any cardiovascular risk factor, and as we said before, low-dose aspirin, statins, and ACE inhibitors reduce MACE and mortality, a neutral effect of DAPT, beta blockers, and calcium channel blockers. And let's see the target therapies. If we have plaque disruption, then we have to use dual antiplatelet therapy, statins and ACE inhibitors. If we have coronary spasm, we have to use calcium channel blockers and nitrates to avoid beta blockers. If we have thrombosis anticoagulation, if we have spontaneous coronary artery dissection, there is debate for the use of aspirin more than 1 year and no doubt if there's no stent implantation. In microvascular dysfunction, we use beta blockers, dipyridamole and ranolazine. ACE inhibitors and MRAs may be helpful. And as you see here, according to the final established underlying diagnosis, we manage patients with Minoka. In Takotsubo, it is essential to use antithrombotic and heart failure therapy for the first 2 months, and myocarditis, where we have too many different causes, infections, non-infections, supportive therapy, heart failure treatment if needed, and treat the underlying etiology. Unfortunately, this randomized clinical trial terminated very early because had a low inclusion rate, the Minoka BAD, and the other one, the PROMISE, they have been included only 120 patients than 180, and we waiting the results. This is a case study. 30 years nurse without any classical risk factor for atherosclerosis, with history in thrombophilia and Ablazar PFO occluder implantation 7 years ago, came to ED due to chest pain, started before 20 minutes during strenuous exercise. After her arrival, as you see here, we have ventricular fibrillation. After defibrillation, the cardiac rhythm was restored. You see STEMI. The patient on shock transferred to the cath lab. Yes, Professor? Yes. We have a spontaneous coronary artery dissection, which starts from the left main and ends at LAD, and we have remnants of thrombus in LAD. 36 years old with no classical risk factors for coronary artery disease. The conservative treatment was decided from the heart team. The patient remained stable and asymptomatic. She discharged after 7 years hospitalization with ACE, DAPT and beta blocker, DAPT because she had thrombus. 3 weeks later, she underwent no invasive but CT coronary arteriography to estimate the left main lumen. Here we see the dissection membrane. And mainly due to the small area of the left main, the patient underwent a coronary artery bypass. After 5 years of follow-up, she is asymptomatic with a good ejection fraction. And take-home messages. Minoca is an umbrella term working diagnosis, is not a benign condition. Patients need a final diagnosis, so additional tests are mandatory. If the underlying cause of Minoca is not established using invasive coronary arteriography alone, further evaluation using intravascular imaging, OCT, IVUS, and functional assessment is suggested. CMR within 3 days median time is recommended. And about management, there are no randomized controlled trials on secondary prevention for Minoca. As we said before, ACE inhibitors and statins have favorable effect. Beta blocker stands forward a positive effect and a neutral effect of dual antiplateral therapy. Different causes have different treatments and prognosis, and it's fundamental to treat the cardiovascular risk factor in any Minoca patient. Thank you.
Thank you very much, Dr. Kartalis. Are there any questions from the audience? I'd like to ask something. You mentioned that an early CMR should be done if we don't have a definite diagnosis so far. Isn't there a logistic issue in an area with no access to CMR, and how would you comment on that?
Yes.
Would you need to transfer such a patient who has CMR or not?
Yes, this is right. We don't have cardiac MRI in HEOS, but as I saw in Smith's study, it's very significant to perform the CMR with a median time of 3 days, because if we delay, maybe we lose the final diagnosis.
Yeah, so you actually transfer the patient to
Yes.
the CMR? Okay, thank you. Thank you very much. We'll proceed.
Thank you. I would like to invite Dr. Panos Huntis to the podium. He is Chief Cardiac and Thoracic Surgeon at the Athens Naval and Veterans Hospital, and he is going to give us a presentation titled A Special Case Report, Chest Wall Reconstruction after Rib and Muscle Resections, Newer Techniques.
Okay.
Yes, thank you.
Thank you very
You're
much.
welcome.
Dear Presidents,
Please
I'm
start.
very thankful to be here today, and I would like to thank Dr. Ioannis Patrikios specifically for the kind invitation to have this lecture on chest wall reconstruction that has the purpose of restoring the anatomical continuity and functionality of the chest wall following resection of ribs and muscle. The final aim is to have a mechanical integrity of the thoracic cage. What is chest wall? It's the protective bony and muscular structure that protects the vital organs like the heart and lungs, that facilitates breathing through its ability to expand and contract, and contains a lot of other fascia, fat, skin, neurovasculature, which provide further protection and support. This is an anatomical depiction of the thoracic cage, which all of its contents and the interest of people on the thoracic cavity and its contents started from early centuries. Here is an anatomical depiction of Andreas Vesalius with two pictures with the thoracic cavities exposed, each dissecting the other. And you see that it shows exactly the vasculature and the contents of the thoracic cage. And another relief from the ancient years, from ancient Egypt, that shows a person probably having pectus excavatum. As you see here, in the center of the, okay, there is an embulging in the thoracic wall, so it's considered to be an early depiction of pectus excavatum. We have general indication for stabilization of the thoracic wall that it's the defect size to be more than 5 centimeters, loss of more than 4 ribs, the sternal resection at the same time, or exposed lung, pleural, and mediastinum. Of course, all these indications are very flexible, and there is no general consensus on this. Especially for the rib fractures, the indication has multiple displaced rib fracture, more than 3 ribs, concomitant fracture of sternum, clavic, and spine injury, severely displaced or penetrating ribs, flail chest, and, of course, chest wall deformity that may cause pain and respiratory symptoms. Why? Because rib fractures may have limited ventilation, abnormal gas exchange, impaired cough, and, of course, hypoxia that may lead to acute respiratory distress syndrome. I'm going directly to the cases that I would like to show you. A female case, 64 years old, born with her 3 siblings. All of them passed away. She was the only survival person on this boat. It was a naval accident. She had all her ribs from 3rd to 10 left ribs fractured, and we did the reconstruction of the thoracic wall with synthetic PTFE, fixation of the scapula with titanium blades. She survived the situation. You see here the chest X-ray of the patient. You see the ribs that are almost all the ribs on the left side fractured, along with the scapula. You see here the rib that has been, the ribs have been fractured and are inside the thoracic cavity, causing a very serious problem to the patient. She is intubated, of course, in the ICU, along with hemothorax. Here you see the ribs that are fractured inside the thoracic cavity. Intraoperative picture with, you can see the rib impacted inside the lung, and the reconstruction with the plates along with the scapula. Second case, male, 88 years old, fall to the ground from a park bench and an impact of a heavy object on the chest wall, multiple left rib fracture from 6th to 10th rib, again, stabilization of the chest wall with titanium rib plates. You see here the ribs that are completely broken and inside the thoracic cavity. We brought them back in position, one by one, and we stabilized the thoracic wall with the titanium rib plates. Here is a depiction. I would like to show you some forms of these materials that we use today in order to stabilize the thoracic wall, and some very important that may help patients to restore the anatomic continuity and the functionality, of course, of the thoracic wall. Male, 50 years old, rapid growth of a mass on the right anterior adrenolateral chest wall, around 12 centimeters, completely removed, right thoracotomy and reconstruction with PTFE and Gore graft. The histology revealed that it was a non-Hodgkin lymphoma. Here is the big mass. You see it on the right anterior adrenolateral thoracic wall, completely distorted the anatomical continuity of the area. You see the histology specimen and the reconstruction of the thoracic wall with PTFE. You see a depiction here that shows how, when we remove the ribs at the area, we use this dual mesh to cover the space that does not have, that's unprotected actually there. Male, 66 years old, at the same situation, mass on the right anterolateral chest wall, around 17 centimeters. It's bigger than the previous one. completely removed through the right thoracotomy and reconstruction of the chest wall with PTFE and gold graft. Histology revealed the same non-Hodgkin lymphoma. Here is the mass. It's a very big mass, as you see, 17 centimeters, completely invading the right thoracic wall. We completely removed it and reconstructed with PTFE. Male, 49 years old, non-specific history. He may refer that he had a trauma, may not. After that, he suffered a COVID infection. The PET scan showed an increased SUV of 5.3. It was an expansile lytic lesion causing bone enlargement and architectural distortion. We removed the second rib of this patient. I would like to show this because the pathologist that reviewed the histology specimen referred us to that it was a trauma, possibly, but he told us that it was extremely strange, and he attributed this condition to the COVID infection that he suffered at that time. Here is the CT scan of the patient. You see on the left side, the second rib has been completely absent, gradually thinning of the second rib, a young, and of course with very high SUV, as you see here. But it was not, and this is the post-operative picture of the patient. We did not reconstruct the thoracic wall, we just, why? Because the second rib is in such a position that it's fairly well area protected from the scapula and the anterior thoracic wall, so we did not reconstruct it. 71 years old, painful swelling on left 6th and 4th ribs, and the ribs were resected, of course. The defects in this case were reconstructed with titanium rib plates. Fibrous hyperplasia was the final diagnosis. You see here a small video intraoperatively how we use of newer techniques with energy production to dissect the area, to take it out. You can see intraoperatively how the gap is filled with these titanium rib plates. Female, 77 years old, postoperative CABS, sternal dehiscence separation with superficial inflammation, a very dangerous condition. You have to act very, very early. The trauma, the wound was opened, debrided, wires were removed. We have to remove it. There is a newer system with two interlocking, self-locking, self-fixating, adjustable length plates. And this is an intraoperative picture. You see that this, we didn't put wires because, why? Because the wires, as you can understand, have a tendency to cut the sternum and cause more problems than this that you may solve. It's something new. We, of course, dissected the major pectoralis muscles and covered the final result. Excellent postoperative course of the patient. This is the two interlocking materials. 37 years old, scaphoid chest, progressively worse symptom, constant all day, palpitation and heaviness. There was a shift of the heart completely left. The aim was to give some more space in the thoracic cavity in order the heart to get a more median position after some months. The patient, we used a technique called Rudakov. This is a mini bilateral thoracotomy under the use of a thermal memory nitinol bar. This operation was done first time in Greece in our department. The heart, this is the pre-operative picture. We signed the areas where we would do the operation. Bilateral thoracotomies. This is the material. It's nitinol bar. It has thermal memory. When you put it inside, in seconds, you can bend it. And you can do with the bar whatever you want. When it will get again hot, it will take the previous scheme intraoperatively. So you see here the Rudako technique. technique. Male, 44 years old, tumor on the anterolateral part of the sixth rib, rib removal, reconstruction with another system that's called Strakos, clips and bar titanium system. Excellent postoperative. You see here that it has bars, it has clips. At the same time, you can reconstruct the thoracic wall in a very good condition. The patient is asymptomatic and fully active because most of these, the young patients are active personnel of Hellenic Navy. 58 years old, motorcycle accident, chest X-ray fracture, displaced, third, fourth, fifth, and clavicle and scapula on the right side, respiratory failure. Just to see that on the right side, all the ribs are inside the thoracic cavity. Chest X-ray, you can see the fractures on the right side and the reconstruction with the Strakos system. Here you can see both systems, the clip and bar and the Strakos system. Male, 61 years old, removed, was present on the left anterolateral chest wall, removed, clear margins, not feasible to reconstruct the thoracic wall, and we just reconstructed with a mesh. The mass is here. Always reconstruction? No. In some cases, you cannot or not needed to reconstruct the thoracic wall, as here. It's just the only symptom of the patient that proved to be rheumatoid arthritis. You can see here, sorry, let's go. No. Sorry for that. You can see here, there is a mass. It was the first and only symptom of the patient, and the diagnosis was rheumatoid arthritis. Another case, not need to reconstruct. It's inside the pectoralis muscle, here, completely removed. Even if here you are prepared to reconstruct by removing the pectoralis muscle, you didn't need it. Historic operations in other cases that you may not need, you must not reconstruct the thoracic wall. Why? Because the left lung, as here, has been removed. And the only solution for the patient that has a dreadful complication called empyema is to leave a permanent thoracostomy. This is an operation from another era that the recent years you will not see it easily, but it's called a Loeser flap. It's a permanent thoracostomy, and there is a hole on the lateral wall of the patient. You see the patient, there is a hole, open and stays open. It's historic operations, and of course, we must not forget that diaphragm belongs to the thoracic cage as well. So, you may need to treat patients with a ventration of the diaphragm. You see where is the one hemidiaphragm and the other, postoperative, the one hemidiaphragm, and postoperatively, and the final here, on the right side, and directly postoperatively, equal diaphragms. Always reconstruction? The answer is no. Be creative, reasonable, think on the available resources. Hospital may not be able to cover the expenses for these operations. Use only where absolutely indicated and be prepared for alternative choices. Thank you very much for your attention. Thank you.
Thank you, Dr. Hundi. Any questions from the audience? Yes, go ahead. Yes. I'm not sure if he can hear you. Can we give a microphone?
Thank you. I want to know if you have made these reconstructions of the ribs with your titanium plates, normally bones need rest for 3 months to get no fracture anymore and no psoid arthrosis. And what could you observe later after some months? Or you made a control
Yes.
X-ray, I think.
If I understood well, the question is if we manage conservatively the patients, right? This is the question.
No, if you make the surgery with your plates,
Yes.
titanium, could you see a complete reconstruction of the bones?
Yes, yes, yes.
No psoid arthrosis later, or in only a few cases?
These are very, excuse me?
The psoid arthrosis?
Yes. If there is, no.
No.
We haven't noticed at the present time. Probably we use it very, very carefully.
Yes.
The use of these plates. We don't use it to all of patients. First of all, in Greece, most patients, especially for fractures, do not want to get operated.
Yeah, this is not the question.
Okay, but
this is true.
to the patients who have used the plates,
Yes.
who haven't noticed some complaints or any complaints actually on chronic pain or pseudoarthritis or in general, we haven't noticed complications in these cases.
And later, have you to remove these titanium bars or
No.
there's no problem
No,
to
we don't
get
remove it.
them?
We don't remove it.
Okay.
I have actually tried to suggest removal,
Yes.
but patients do not want to deal with this.
Okay, thank you
They
so
don't
much.
want to remember the accident and the situation, and they say, "Doctor, I'm okay. I don't want to come and take it back." In contrary to the orthopedics, that they come after 2 years and remove the foreign materials. But for thoracic surgery, it's strange. They don't want to remove it.
Okay, thank you so much for your wonderful work.
Okay, thank you.
Anybody else? Well, okay, I don't see anybody else. Thank you, Dr. Houdi, for presenting us a sample of your extensive experience on this subject. We appreciate it.
Thank you very much.
You.
Thank you very much.
So this concludes the session.
Good morning, everybody. So we continue with the session of the antimicrobial resistance. The speaker is Dr. Dimitris Kougios. Dr. Kouliatsis will present Dr. Kougios.
So Dr. Dimitrios Koukios graduated from the Athens School of Medicine. He completed his residency in internal medicine and subsequently obtained subspecialties in critical care medicine and infectious disease. He currently serves as assistant doctor of the intensive care unit at Limassol General Hospital. His main areas of interest include severe infections, antimicrobial resistance, and sepsis in critical care patients. So, Dr. Koukios, please.
Good morning to everybody. Thank you for inviting me to speak to this session. I'm very glad to be here. So the problem is obvious. As you can see, the AMR-resistant bacteria claim the lives of more than all the people killed by malaria and HIV annually. And the same problem stands for the USA, where the cost to treat infections caused by 6 only AMR bacteria is over $4.6 billion annually. That's why we have identified these bacteria with the acronym ESCAPE. And the ESCAPE bacteria actually escape our antibiotics. And they are the Enterococcus, Staphylococcus, Klebsiella, Acinetobacter, Pseudomonas, and Heterobacter. There are many mechanisms by which these bacteria become resistant. These mechanisms start with the porins that are down-regulated, so that we have decreased influx of drugs inside the cell. Then there is inactivation of antibiotics by enzymes that the bacteria produces. There are some proteins that protect the antibiotic target, or in the end there are these efflux pumps that bring the antibiotic outside the cell. Another very important mechanism of resistance is the biofilm. The biofilm is an extracellular matrix that is produced by an aggregation of bacteria that acts in many ways. First, it produces decreased permeability to the antibiotics. Then, inside this matrix, there is a low expression of target proteins. There are some persister cells. The persister cells are dormant cells that have stopped their growth, but they are alive, they are viable, and they can become reactivated once the circumstances allow it. Also inside this biofilm, there is extensive AMR gene transmission from one bacteria to another. And all these mechanisms are contributing to an extensive resistance. We use one of the most important classes of enzymes are the beta-lactamase enzymes that break down the lactamic ring. These are classified with the Ambler system to 4 categories, A, B, C, and D. Some of the most well-known beta-lactamases are the extended spectrum beta-lactamases, the KPC, the carbapenemases, also the notorious metallo-beta-lactamases that break all beta-lactams except astreonam. They're causing a very big problem in antibiotic resistance. And also the category D, the oxacillinases. The most known ones are the OXA23 that we meet at the Acinetobacter usually, and the OXA48 that we meet at the Enterobacter alles. Of course, Dr. Anna Pelagia Magiorakos has placed some pragmatic definitions of AMR, which are the multi-drug resistant bacteria, which are actually bacteria that we have some choices to deal with them. We have some antibiotics to kill them. But there are also the extensively drug-resistant bacteria, where we have only 1 or 2 antibiotics, so a couple of choices. And the pan-drug resistant bacteria, well, where we have no choices. They are resistant to all agents in all antimicrobial categories. So how serious is this problem? We can see here some of the major bacteria that we see resistance into. So the Klebsiella pneumoniae, the Pseudomonas aeruginosa, and Acinetobacter baumannii. And these columns represent the resistances in certain countries, the carbapenem resistance. So The first column belongs to Norway. So we see they don't have a major problem. You see only 3% resistance, carbapenem resistant on Acinetobacter baumannii. And the second column, unfortunately, is Cyprus. And Greece, we meet the same problem in Greece also. So we see here the Acinetobacter baumannii has 95% resistance in carbapenems. This is a major problem. This is very recent. A few days ago, it was published. It shows the trends in AMR at the Greek Tertiary Hospital in Evangelismos over a 7-year period, including the COVID-19 pandemic, where we see this transient rise of AMR resistance that happened around the time of COVID. And fortunately, it's showing some signs that it's coming down, but it hasn't reached the levels that were pre-pandemic, the pre-pandemic levels. Some other data are more alarming. Like in the United States, we see that the new Delhi metallo-beta-lactamase surged more than 460% in the United States. And if we continue at the current level of actions on antimicrobial resistance, there will be an average loss of 1.8 years of life expectancy globally in 10 years. And if we think that we're outside of this data, some countries in the Eastern Mediterranean region could see life expectancy fall by 2.5 years in those 10 years. So what can be done? In 2017, the WHO has selected 12 drug-resistant bacteria that they concentrated in order to produce some new antibiotics targeted on these bacteria. They have updated this data now in 2024, and we see some trends. So the Acinetobacter baumannii carbapenem resistant that was first on the list, it has gone to the 3rd place, and the E. coli has gone up, but we see mostly the Klebsiella pneumonia, carbapenem resistant. We see this very serious problem. It has gone up on the list of the bacterial pathogens priority list. There was this 15 years ago, in 2010, there was an initiative 10 by 20. So we're targeting for 10 new antibiotics by 2020. And actually, we have managed to produce some antibiotics, around 10 antibiotics, mostly beta-lactams with beta-lactamase inhibitors combinations. But really, they're not a breakthrough because they are in the same categories that we were using in the last 30 years. Some of these are ceftolazone tazobactam, which is most of these are inactive against MBL, so metallo-beta-lactamases render them inactive. We have ceftazidime avibactam, which is a quite potent antibiotic. It is active against ESBL, KPC, and some oxacillinases, again inactive against MBL. We have meropenem and vaborbactam, which have also MBL resistance, and it does not confer activity against meropenem-resistant Pseudomonas or Acinetobacter strains. Relebactam is a potent beta-lactamase inhibitor. It is structurally related to avibactam, and it is conferring activity against KPC, ESBL, AMP-C, and also it retains activities for some Pseudomonas that are resistant to ceftolazone tazobactam and ceftazidime avibactam. But it does not restore, of course, susceptibility in species that are intrinsically resistant to imipenem, such as Morganella, Proteus, and Providencia. Astreonam and avibactam is a new monobactam and beta-lactamase inhibitor combination that combines the astreonam, which is MBL stable, along with avibactam, which blocks most of the categories of beta-lactamases. And although the problem is that it is inactive against Acinetobacter and Stenotrophomonas, which are major problems in the AMR and especially in the ICUs. Cefiderocol is a new cephalosporin that binds extracellular iron and uses it as a Trojan horse to enter the bacterial cell through iron transport porins. Dr. Theodorakopoulou will speak about cefiderocol in the next presentation, and it is actually active against all classes of beta-lactamases. So are we happy with these developments of drugs? This is the pipeline of antibiotic production from 2000 to 2024. We see it's actually poor. We have only very few large companies that are investing in antimicrobial development and research. And most of these are private companies, and there are more than 50 small to medium-sized companies working on new treatments for drug-resistant infections. But according to the WHO, nearly half of these companies, which are often spin-outs from universities, have fewer than 10 employees and less than 12 months of funding. So they are really not solving the problem. We see here on this timeline, we see many companies have gone bankrupt or liquidified from 2019 to 2023. So there is a financial risk that these companies are taking. There's a high financial risk. And if we see the pipeline for new drugs directed against metallo-beta-lactamases in December 2024, we actually see many drugs on phase 1, fewer on phase 2 and 3, and only cefiderocol and astreonam avibactam are FDA and or EMA approved. In the meantime, these are the metallo-beta-lactamases that only Pseudomonas is producing, and you see all these different strains, this phylogenetic tree, with all these different strains along across the globe, actually. So we were aiming for 10 new antibiotics by 2020. We needed bad bugs. We needed drugs for the bad bugs. But maybe now it's bad bugs, no drugs. So are we losing the antibiotics war? Maybe we shouldn't have gone against the bacteria in the first place, because this war cannot be won. The ECDC has some key actions. We have to promote prudent use of antimicrobials in the community and in healthcare settings. We must be aware about antibiotics. What is this aware group? We have to use the WHO aware groups. So the WHO has divided the antibiotics into the access, watch, and the reserve group. The access group is antibiotics, older antibiotics that have a more small spectrum. The watch are newer antibiotics, and the reserve group are these antibiotics that we must use very, very carefully. We have to concentrate on infection prevention and control measures and policies. We have to increase surveillance and antimicrobial resistance and antimicrobial consumption, so antimicrobial stewardship. All these have to go hand in hand. So microbiology and diagnostic stewardship, along with infection prevention, control, and antibiotic stewardship should be going hand in hand if we want to have any good outcomes. Also, One Health is one major thing that also ECDC are focusing on. One Health is that we have to consider also the animal and plant health, the environmental health, along with the human health. So what we see in the ICU, we consider the ICU to be at the front line of the battlefield of AMR. And why is that? Because the ICUs concentrate all high-risk factors for AMR. Which are these? These are the broad-spectrum antibiotic use, the invasive procedures, We have hospitalized immunocompromised and colonized patients with many AMR bacteria. We have a high patient turnover, and we have high staff turnover. The ICUs serve as amplifiers and hubs. The resistant genes and MDR pathogens can spread from ICU to the rest of the hospital and vice versa. But also, we see larger results. So we have highest impact on infection control, antimicrobial stewardship, and surveillance programs. They show the highest impact on the ICU. The ICU can serve as a hub that they can transmit not only bacteria to the rest of the hospital, but also knowledge and pathways, and also behavioral changes. So this is a surveillance platform for antibiotic resistance and awareness, SPARTA, that was developed and is implemented at the intensive care unit of Limassol General Hospital. It monitors the cultures of the patients. It monitors the infections and antibiotics using the ECDC definitions of infections. We are monitoring foreign bodies, and we are monitoring clinical data. And also, we are monitoring antimicrobial stewardship parameters, such as the daily defined doses, the length of therapy, the days of therapy, the antimicrobial use according to WHO aware classification, and also we are using another index that is called Antibiotic Spectrum Index, ASI, that is used to show how wide is the spectrum of the antibiotics we are using, which is also very important. So to conclude, we see that the AMR is a problem, is a global problem. We have to contribute, everyone, in many scientific fields. It will represent one of our modern medical thermopyle, we would say. And we consider the fight to be a stand of science, vigilance, and collective responsibility. So thank you very much.
Do we have any questions from the audience? We have a microphone.
Thank you for a very comprehensive and very engaging presentation, which is also very relevant, and it was perfectly on time, by the way. It was fantastic. So you mentioned a lot, but you did go into bacteriophages as possible antibiotics. Is this still sci-fi in daily routine, and that's something that is either not realistic or is on the further horizon?
Mm-hmm. Okay, thank you for the question. So you're talking about phages. It is being done on some research and development drugs, but they have not reached phase 2 or phase 3. So there is some research, but to tell you the truth, if we see how financially these companies go, it will be a very big risk to take. But yes, it is promising. It might be promising in the future.
Any other questions?
Thank you, Dr. Carsten Leder from the Institute of Neurology. Thank you.
Any other questions? Okay. So shall we proceed to the next speaker? It's a great honor to present Dr. Maria Theodorakopoulou. She's a surgeon intensive care specialist, head of the ICU of the General Hospital of Attica in Athens. She's a current president of the Hellenic Society of Intensive Care and treasurer of the European Society of Intensive Care. And I have to also say that she's a great supporter of the intensive care community in Cyprus. And hopefully we will continue to have a very good collaboration in the next coming years. Thank you very much for being with us, Maria.
Thank you, George. Thank you all for being here, and thank you for the invitation, of course. Cyprus is Greece, so we're together, we're united in this. Well, my topic today, it will be kefidérocol. the Trojan horse that Dr. Koukios reported. Let me figure out. Great. So these are my disclosures. Let's see the background. I think Dr. Koukios said it in a few words, but I'm going to remind everyone. Antimicrobial resistance is the big problem that we're facing, not only in intensive care units, but everywhere in the hospitals. We have microbes that we cannot kill. 5 million people died annually, every day, in 2019, and if nothing will happen from now on to 2050, we're going to lose 10 million people every day. And the big challenge is that we have gram-negative pathogens that are responsible for most of the infections we have in our units, for the sepsis and the death we face every day. And the common pathogens are the ones that are listed, Acinetobacter and Pseudomonas and Stenotrophomonas, and Klebsiella and the carbapenem-resistant strains of Enterobacterialis. What are the challenges and why are we here? Is because we have, as Dimitri said, a very short antibiotic pipeline that is decreasing every day. The empirical therapy that we're using in our units, it doesn't work all the time. Critical illness alters the PK/PD of the antibiotics, so the standard doses are not very effective to the drugs, to the pathogens we have, and we do have a rapid deterioration of the patient if early therapy fails. So this sets the stage for why innovation is very important and urgent to have new antibiotics, or at least new ways to tackle these drugs. And we do have some. We have the novel beta-lactam, beta-lactamases. We have the bacteriophage therapies that are trying to gain some part in developing and attacking these pathogens. We have monoclonal antibodies and antimicrobial peptides are all on the work and they're promising, but we also have cefiderocol. What is, and I'm going to focus on that today, what is cefiderocol? It's a novel siderophore, I carry iron, that's a Greek word, cephalosporin. And why it's called the Trojan horse? Because it uses the bacteria's own transport system to get into the bacterial cell. What is very different for this cephalosporin? It has a catechol siderophore moiety that binds to the iron. And it's still a cephalosporin. So it has the C7 chain and the C4 chain of the known cephalosporins we have, but it has the catechol moiety that binds to the iron, which is very important to be transported into the cells. And once this microbe gets into the cell, then it binds to the penicillin binding protein, and that makes the molecule very stable. So it cannot be catalyzed by the lactamase enzymes. So this molecule has the ability to overcome all three major mechanisms of resistance. And it does have a great spectrum of activity. It can attack most of the gram-negative MDR pathogens. And what is the clinical evidence we have to support all this that I said? And I'm going to focus on these 5 studies initially, and then I'm going to introduce 2 or 3 more that have appeared in the last 2 or 3 years. The first study is the APEC study that evaluated the cefiderocol for complicated urinary tract infections. It was a phase 2 randomized, double-blind, multi-center study. The population that was included in the study were adults with complicated urinary tract infection, including pyelonephritis, and they compared cefiderocol with imipenem cilastatin. The primary endpoint was clinical and microbiological outcome at the end of treatment in 7 days. Randomized 452 patients, included in the study 371, Pathogens that were found were E. coli, Klebsiella pneumonia, Pseudomonas aeruginosa, and Proteus. The baseline uropathogens were balanced in both arms, as we see here. And the results of this study tells us that cefiderocol was non-inferior to the other arm of the study and maybe slightly superior. We see the differences in clinical and microbiological cure. It has a strong activity versus gram-negative pathogens, and the safety profile of cefiderocol was exactly the same as the previous cephalosporins that we know and we have been using for many years. And then we move on to the APEC NP trial that evaluated this new drug for nosocomial pneumonia, hospital-associated pneumonia, and ventilator-associated pneumonia. The population that was included in the study were adults with hospital-acquired pneumonia and ventilated-associated pneumonia, and compare this drug to meropenem, high-dose meropenem, the ones that we use every day, 2 grams 3 times a day. The primary endpoint was all-cause mortality at 14 days, and the secondary endpoint was cure at the end of treatment. Randomized 300 patients, included 292, and the main pathogens that were found was Klebsiella pneumonia again, Pseudomonas aeruginosa, Acinetobacter baumannii, and E. coli. Important to note here that 60% of the patients were ventilated, and they all had high severity scores. The baseline for these patients were balanced. They were all severely ill patients in both arms, as you see. And also, the pathogens were also balanced in both arms. We have the same pathogens here and there. So the end result of the study was that cefiderocol was non-inferior to high-dose meropenem. It was effective against MDR and carbapenem-resistant microbes, and has similar mortality and safety as the meropenem, and so the drug is supported for nosocomial pneumonia due to difficult-to-treat gram-negative infections. And we go to the credible CR trial that evaluated cefiderocol for CR-resistant gram-negative infections. It's very important in this study to see 3 things. The first thing is that included patients infected with CR gram-negative pathogens, regardless of the site of infection. It was phase 3, it was multi-center, open-label, pathogen-focused trial. It included adults that had confirmed CR infection, resistant infection, gram-negative, and the comparator was compare the drug with the best available treatment, whatever the physician decided to give to the patient, depending on the country, depending on the unit protocol. And the primary endpoint was clinical and microbiological outcomes at test of cure. 150 patients were included. Most of them had Acinetobacter baumannii, 46% of the patients. The rest had Pseudomonas aeruginosa, Klebsiella, and E. coli. All isolates were carbapenem resistant, many MDR and many XDR, and very critically ill population. Many of the patients were in ICU, and they had high Apache scores. I put this here to realize, because when we read the study and we analyze the study, there are certain points we have to keep in mind while reading it. This is, unlike most trials, the credible CR included multiple infection sites to start with. It was also designed to provide descriptive statistics only, no inferential testing. And then, if we decide to analyze particular subgroups, we have to be very careful not to interpret or over-interpret the data. So the final results of this study was that we did find a higher mortality in CR Acinetobacter baumannii in the subgroup that it was analyzed. No clear cause was indicated, not even found. Cefiderocol showed comparable efficacy to best available treatment as far as CR gram-negative infections are concerned, except the CR Acinetobacter baumannii. This study supports the activity against MDR, CR, Enterobacterales, and Pseudomonas, and mortality imbalance was only attached when Acinetobacter infections were concerned.
But looking at the study more carefully, one can see 3 or 4 different things. First of all, if we see both arms, we see that, okay, the patients were severe on both sides, but the renal function was worse in the group that had cefiderocol. We had a higher proportion of patients with moderate to severe renal impact and lower median creatinine clearance. The other thing that was different in this group is that in the cefiderocol group, the proportion of patients were more severely weak with the Apache and against the BAT arm. And the last one is that the people that were in the cefiderocol group, the arm, they had prior shock and or were in ICU when compared with the BAT arm. And if we see at the therapies these people took, we see that most of the people that were on the cefiderocol arm was monotherapy. Over 80% of the people took only cefiderocol for the gram-negative MDR infection they had. But in the BAT group, almost 3/4 of them, they took colistin-based regimens with combinations. And if we look at the mortality, that it was the conclusion of the study, we see that the group of cefiderocol indeed had a higher mortality, but no death was due to a cefiderocol-related adverse event. And if we look closely at day 4 to day 28, we'll see that all deaths, the mortality was similar in both groups, in both arms, but the deaths were higher in the cefiderocol arm after day 28. And we're not really sure if the death was due to the cefiderocol or to the underlying disease or the new infection. And one last thing is that cefiderocol was active in vitro against all gram-negative isolates, and it has better activity than any other drug that it was used. And we move on to the proof study. We move on to the real-world evidence. Those so far that I reported were trials. Now we're going to the real-world evidence on cefiderocol for MDR and CR-resistant strains. The proof study is a post-marketing real-world evidence study that evaluates the use of cefiderocol in the real world. The population used were patients with documented gram-negative infections, MDR, or carbapenem resistant. The data was collected for 2 years across multiple countries, and the endpoint was clinical success, microbiological success, and all-cause mortality. 190 patients were included. Most of them had pneumonia, and the rest of infections was either bloodstream infection or intra-abdominal infections. We see that Acinetobacter was almost in 40% of the cases, and the rest of the pathogens were Pseudomonas, Klebsiella, and Stenotrophomonas. And most isolates were either MDR or XDR or carbapenem resistant. The results of the proof study showed that cefiderocol demonstrated good real-world effectiveness, has clinical success, but it was higher for Pseudomonas enterobacterales and a bit lower for the CR Acinetobacter cases. The combination therapy, however, in some cases where cefiderocol was used along with colistin or along with a sulbactami, often used in severe infections, the results were much better. So, in conclusion, it does confirm this study that cefiderocol has broad activity in the real world. Outcomes align with the trials APEC and CREDIBLE, and supports that cefiderocol is a valuable option for MDR and CR gram-negative infections. But caution gives us a caution when used for CR Acinetobacter baumannii infections. And we come to the game changer, a very promising study that was multi-center, randomized, open label, population that was used were adults with hospital or healthcare gram-negative bloodstream infections. All had positive cultures, and the primary endpoint was all-cause mortality at day 14, And the margin for the non-inferiority was set at 10 percentage points. 504 patients, equally divided in two arms, subset with the carbapenem-resistant isolates. They created a group of 127 patients. And the patients, the sources of infection came either from UTI infections, intravascular line infections, intra-abdominal infections, and pneumonia. The game changer showed that cefiderocol and the standard of care treatment that was compared with had the same results. So it's not inferior, but it did not show superiority either. The other thing that showed is that in the carbapenem-resistant group, there was an increase in mortality. But the statistical difference was not enough to create a statistical significant result. The trial met the non-inferiority threshold, but the cefiderocol was not shown to be superior to standard therapy in this setting, and additional data is needed to clarify the optimum use, the combination, and the outcomes of the drug. And we go to the ARA study. The ARA study is the Acinetobacter real-world evidence study, multi-center, observational, retrospective, for 1 year, 20 to 21, Italy, Spain, Germany, and France, and 27 hospitals. Populations included were adults with carbapenem-resistant Acinetobacter baumannii infections treated with cefiderocol. The patients were 147, 92% in ICU, 85 ventilated, 81% had co-infection with COVID-19. Main infection site, respiratory tract, bloodstream, and catheter related. The results showed that cefiderocol showed moderate effectiveness in critically ill patients with CR Acinetobacter baumannii. Better outcomes in patients with less severity of the disease, patients that didn't have COVID, patients that didn't have sepsis, and demonstrates real-world feasibility of cefiderocol, but highlights the limited survival in severe ill ICU patients. But we don't know where death comes from. It comes from the inability of the antibiotic or from the total deterioration of the organism. So the ARA study confirms the activity against Acinetobacter baumannii. Early initiation and milder illness seems to have better results, and the outcomes remain challenging in high-severity ICU cases. My time is out, but give me another 5 minutes, and I will go on with the Perseus study, which is a real-world study that happened in Spain for 4 years. It's retrospective, multi-center, hospitalized patients with Acinetobacter baumannii again. They started cefiderocol 72 hours after the initiation of the infection. 261 patients, 63% in ICU. Most common infections, respiratory tract, intra-abdominal, and urinary. Pathogens, mainly Pseudomonas aeruginosa. The end of the study concluded that in real-world, highly ill patients with difficult gram-negative infections, excluding Acinetobacter baumannii, cefiderocol achieved high clinical cure rates and modest mortality. So for all the gram-negative MDR, cefiderocol is the drug of choice. Best outcomes seen when used earlier, before prolonged prior antibiotic therapy or mechanical ventilation. Supports the use of cefiderocol as the gram-negative infection with limited options. This is a study that supports the cefiderocol in the, as a choice for Acinetobacter baumannii bloodstream infection, 104 patients, both divided into two arms, one with cefiderocol and one with colistin. The results that Alessandra Olivia said in her study was that the clinical cure was higher with cefiderocol, mortality was lower, but not statistically significant. Conclusion was that cefiderocol may be an effective and safer option compared to colistin in this setting. And I'm going to take you to this study. This is a big meta-analysis that happened last year. It provides the strongest evidence to date supporting cefiderocol over colistin as the preferred treatment for carbapenem Acinetobacter baumannii infections. It's a systematic review and meta-analysis, and it compared cefiderocol-based regimens versus colistin-based regimens. 8 study, 900 patients, both from clinical trials and from real-world data. And the end result was that cefiderocol associated with reduced mortality, better outcomes, better bacterial clearance, and significantly safer for the kidneys. And the pool relative risk for mortality was 0.64, which is statistically significant survival benefit with cefiderocol. So the conclusion of this meta-analysis was that cefiderocol-based therapy is superior to colistin-based. And higher cure rates, lower mortality, and much less nephrotoxicity. And the trial sequential analysis confirms the evidence was strong and reliable. It's very small, but all it says us is that we have a safe drug, which is non-inferior to the other drugs we have, but we have to preserve it because it belongs to the third category that Dr. Koukios referred to, the reserve group. And if we compare it with the new antimicrobials that are in our agenda, it does have overcome all the main resistant mechanisms for all carbapenemases. It's active against most MDR gram-negative microbes. The only weakness is that we have to pay attention and do more studies for the C. Acinetobacter baumannii, and its indication from FDA and EMA so far is for UTI, HAP, VAP, MDR gram-negative infections. And if we see very quickly the placement we have from IDSA and ESCMID, we do have it as an alternative antibiotic. The thing that I want to say here is that the ESCMID guidelines are from 2021. The revision will be next year. And the IDSA guidelines are from last year. So at 2021, cefiderocol didn't have enough data to enter the ESCMID guidelines. So don't take it as a negative that is not in the guidelines. It wasn't ready the time that the guidelines were created. So IDSA says that for Enterobacter gives cefiderocol as an alternative therapy. The same for OXA48 and for MBL. For Pseudomonas aeruginosa is also in dragon choice, and definitely the first choice for MBL Pseudomonas aeruginosa producing. And of course, in carbapenem-resistant Acinetobacter baumannii is the choice if we have refractory to other agents, non-achieving therapy. And of course, for Stenotrophomonas maltophilia as a combination therapy with other drugs. So to conclude, cefiderocol represents a major step forward in MDR gram-negative infections, consistently demonstrates non-inferior efficacy, strong in vitro and clinical activity against MDR and carbapenem resistance strains, and the real-world evidence tells us that is a valuable first-line or last-line agent, especially for Pseudomonas and Enterobacter. Warrants for a bit caution in Acinetobacter, best when we use it in combination. The meta-analysis of 24 provides robust evidence that cefiderocol outperforms colistin in survival and safety. But we should use all these preserved antibiotics with careful consideration and stewardship. And we need more studies that will define its role in critical care. Thank you.
Thank you very much, Dr. Theodorakopoulou, for the comprehensive presentation. Are there any questions from the audience? Okay.
I was either very clear or very unclear.
I think it was good. I have some questions, but I would like to save them for the panel.
Okay.
So we proceed to the panel. It's an interactive discussion about this topic, and I urge you all to ask your questions or any queries you have. I don't know your clinical, interaction with this, but it's good to have an opinion or share some thoughts and questions. The panel will be considered from Dr. Theodorakopoulou and Dr. Kougios. We have the absence of the other two speakers, but we can take their role, Dr. Kouliatsis and I. So we keep the distance. Maybe we play the devil's advocate in this situation. So, George, you can ask a question.
Dr. Theodorakopoulou, how confident are we in regards with the dosing in continuous renal replacement therapy of cefiderocol? CRRTs, CVVH, stuff.
It's the drug has the SOP of the drug tells us to reduce the dose on CRRT. When the patient is on CRRT, there are definite instructions on how you were going to use the drugs. So we go with the SOP of the drug on that. I have used the drug, and I have used it in combination in CRT patients. My two patients that I have used it went really well, very severely, with high score. With the first time I used it as a salvage therapy, while the patient had taken tons of antibiotics prior, had gone 2 or 3 septic shocks, and it was a young patient and a polytrauma patient, and it was my only choice. And honestly, it went really well. He was cleared from the infection. He had Acinetobacter baumannii CR infection, and it went really well. And I was very surprised, to tell you the truth myself. But and then the second time we used it on an older patient with chronic renal failure, but we used it in combination with colistin. We never stopped colistin. We didn't have sulbactam at that time, because sometimes, you see, most of those drugs or the ISDA suggests that we use aztreonam because it's the only one that, especially for beta MBLs, has the ability not to be distracted. We don't have it as a drug sometimes. We're missing it. So colistin is our best choice. And most of our patients, I don't know yours here in Cyprus, but in Greece, all our patients take colistin.
Yeah.
For many, many days.
And all our dogs also.
Yeah. Yes, yes. So we didn't stop colistin, but we added Fetroia, and it did work. It did work. And from the little studies that I saw, and I tried to show you today because I was looking for them, it shows that wherever in very severe cases, the combination seems to work than the monotherapy. So it's a combination of things that help the patient.
Would you say a combination with colistin or a combination with other drugs as well?
Well, the suggestion if you add DSA is sulbactam. And,
Our infectious care specialists tend to prefer sulbactam.
Yeah. Because probably they've already used colistin and they don't want to use it anymore. They think that the patient has taken it for a long time, but I use it with colistin. Yeah.
Since we have young doctors coming to the market in some years or in short time, I would like to emphasize on the use of the antibiotics. There is the problem. And since medicine is diagnosis and preemptive therapy, I guess the main issue in our countries, Cyprus and Greece, we have the most highest scores in multi-drug resistant bacteria, is the insecurity when we use antibiotics. All doctors, I see it all the time in the ICUs and in hospitals and in general doctors, they change antibiotics all the time. Every 2-3 days, they don't even let the drug work because drugs need some time to work, antibiotics, I mean. So if they don't see a result, they quickly change to something else and then to something else, and this is causing the drug resistance. I'll share my personal experience in a newly working ICU, the one I was until very recently. For the first 6 months, we didn't have multi-drug resistant bacteria. And the reason it was a single doctor-run ICU, so I was very cautious about the use of antibiotics. I had the experience in Switzerland where I visited the university hospital there, and their furthest, I mean the the end line actually antibiotic was Pip-Taz, which was something amazing, going from Greece and Cyprus, where we use colistin like you use pills for headache. So we tried to do this, and for 6 months we didn't have multi-drug resistant bacteria. When we had the first one, my nurse in charge was devastated. He said, I wanted to do it for a year. I say, you can't do it in Cyprus, especially if you get patients from other hospitals. As far as cefiderocol, and I will finish with this and let the audience and the rest, we had the clinical experience with 2 patients in my ICU. I have to say that, like we say in Greek, you don't burn a medication which is good. Depends on the timing you use it, on the patient you use it, and since we had it as a last resort, we usually use it in the very bad patients. We treat the infection, but they die from other causes. So, starting from stewardship and cautious escalation or de-escalation. We don't know, we don't use this in many ICUs in Cyprus. We don't know how to de-escalate our antibiotic treatment. When you have result, you have to de-escalate to something lighter for the patient and not giving the rise of multi-drug resistant bacteria. So everything comes from education, and this is a very good start for you to know about this. You don't lose patients because you use antibiotic, you lose them because you don't use them wisely and correctly. Thank you.
Okay, just a small, yeah. Okay, just a small question well, 2 questions to the maybe now extended panel, maybe Dr. Koukios, but maybe others. So one is, in how far is the handling of antibiotics coordinated across ICUs of private and public hospitals in Cyprus? It's a small place, so in principle, if there are no teeth, then it's problematic, but it would make sense, right, to integrate this. And the other question is there a problem of overlap of antibiotics used in agricultural use? And if so, are there steps to remedy this?
If you allow me to take the second question and allow Dimitri to take the first one. Something that I like Dimitri's slide about WHO and the One Health approach that WHO has, which is the environment, the agricultural use, and the use in the hospitals. To surprise you, 70% of the antibiotic use goes to agriculture. Agriculture, animal health, and all that. And that goes to the system, and then it goes to us, to our system. So we might be exposed to antibiotics without us knowing it. And that hasn't changed on the last 10 years. If you look at the WHO, the 73% is still, it's 70 now. So this approach, we have to change the approach. What Dr. Minas said, we have to change our mentality on how we use antibiotics, but it has to be One Health approach where everybody has to change mentality, agriculture and people, and when it's used in animals as well. So the decline of antibiotics should happen there as well.
So there are no specific studies on this exposure in Cyprus?
No,
okay.
no.
No, but it's a global phenomenon. Now about your first... Yeah, all right. About the first question, if there is coordination between ICUs and hospitals, private and public sector, they are trying now through WHO and ECDC, which is the European Infection Control Society. They're trying to use some common platforms to coordinate these actions actually, and to see what resistances there are around Cyprus. But it's now beginning. We are at the starting of.
How granular is this? Is this about specific antibiotics, or is it about the general approach to use of antibiotics?
It's both. It's both, but they are mainly targeting, you know, the specific antibiotics and specific bacteria and specific infections, like the bloodstream infections, which are some of the most serious infections a patient can have. Thank you very much.
Just what the EDC has, many countries all over the world have give the bloodstream infections, the pathogens of bloodstream infections. I think Cyprus and Greece are those countries that give their annual report to EDC. And in the charts we are, but we're very low. Low meaning that we don't have good surveillance and we don't have good use of antibiotics. So that should be our next step.
Yes, hello. Pavlos Neofidou from the Mendel Center. Do you use molecular tests to identify which antibiotic resistance genes a patient has?
It is being done in Cyprus, mostly at the Nicosia General Hospital, but also we use some molecular mechanisms in Limassol General Hospital. Yes, sometimes they help us to focus our antimicrobial approach. Yes.
It is happen in big hospitals in Greece, but it doesn't happen everywhere. So it's something that it should be entered in our practice, because we'll know the pathogen much faster. We'll know if it's multi-drug resistant or not. And then, especially in the patient in ICU, where the patient deteriorates, or even in an in a pathological clinic, deteriorates, we give a broad-spectrum antibiotic, which is normally on the reserve group, and then we do not de-escalate. And we're waiting for the result. And the result might take 2 or 3 or 4 days, depending on the ability of the microbiology department has. And that would, it's even worse for the patient, because it's probably would be taking an antibiotic that doesn't need it at that time. So it's something that we should do. It's not happen in every hospital, it doesn't happen, but it does happen into big hospitals where the microbiology departments have this ability.
Okay, thank you.
If any of our students here have a question regarding multi-drug resistant microbes or infections in the hospital, we would be very happy to see you contribute in the discussion. So in the meantime, I have a question. I actually have a point I would like to raise. I don't know, Dr. Theodorakopoulou, how is it still in Greece? Does an ICU doctor have the ability to prescribe cefiderocol, for example, if a patient is in septic shock?
No, it goes through the effect. We don't have the drug. We have to make an application.
So other antibiotics like Zavicefta, for example.
That. Hello. Zavicefta, yes, we can prescribe. Yeah. We have it as a drug, but there is still now what is happening in Greece. We're trying to preserve the drugs as much as we can, because it's exactly what Yorgos says. We have to. We don't use antibiotics to make us feel better. We should use antibiotics to cure our patient. And it's sometimes our own inability to de-escalate, because we think 4 or 5 or 6 antibiotics is good for a patient that is dying. It's not true anymore. So we have to start to change our mentality first. And second of all, we have to have all this support from the system, from the microbiology department and everywhere, to tell us what pathogen we have. But then, yes, the doctor of the ICU has the ability to prescribe the preserved antibiotic. Now, and sometimes they do it more often than they should. Or they do it ahead of time, just to make sure that I have covered everything. Or I'm giving a new antibiotic that I haven't used, so that will definitely cure my patient. That's in our mind. So what the Greek government has done lately is it has created a platform where all hospital drugs in EDAP, where all hospital drugs are listed in that platform. And every 6 months is going to have a check of all the drugs, including the antibiotics. So if a unit or a clinic or a department has increased in certain antibiotics, it has to justify the choice. It's a form of control of the medication, but as well is a way from us to see what we're doing daily that we don't have the ability to do it right now.
So in Cyprus, they are more strict, and they have a list of advanced antibiotics, and only with the consultation of infectious care specialists can we provide them to the patient. And to tell you the truth, this has always caused me some kind of concern, because I know that if a patient is in a septic shock, he should receive the proper antibiotic within the first couple of hours and not the next day. Because I don't think, and Dr. Koukios, please, you can contribute to that, that there are so many infectious care specialists that can respond rapidly to every septic shock. Maybe, just a thought, an intensive care specialist could be licensed to give 1 or 2 doses before a proper infectious care specialist consultation, just in cases of septic shock, I mean.
Yes, Dr. Kouliatsis, I agree totally with that. And we do that in the Limassol ICU. I mean, a doctor is allowed to start a new antibiotic if the condition is very severe, like in septic shock. But then after giving, so he's allowed to give 1 or 2 doses, and then he has to have the approval of the infectious disease specialist. But he has to give it, actually. We have to start, sometimes you have to start high and then de-escalate fast. But if in a couple of days you don't have evidence of multi-drug resistant bacteria, then you have to de-escalate very, very fast. And also I would like to concentrate on short duration of treatment. So the trend now is to have very short duration of treatment of infections, like pneumonia, 5 days or 7 days, or a bloodstream infection, 7 days. You don't go to 10 or 14 days that we were going before. So this is also very important.
Since I took the role of the devil's advocate, I will stick to the point that everything has to do with prevention. And prevention is not always having to do with the government rules and tactics. We have to implement that in our hospitals too. And I'll say again the experience from my days in Switzerland, in Geneva. There was a questionnaire there that actually it was a test which everyone had to pass in order to work in the hospital. And it started from the cleaning ladies to the director of the hospital. This had to do with preventive measures to the spreading of infections, how to treat patients, how to move patients within the hospital. And if someone didn't pass it after a period where they tested, they postponed his contract until he was able to pass this test. So this can be a good, I say motivation, I don't know, for us starting to be more cautious about measures to prevent both infections, and then up to the clinical part, how to use antibiotics, escalate or de-escalate treatments like we said, and also in junior doctors when they start seeing patients in their offices, in their in small hospitals in the countryside, so they don't misuse or overuse antibiotics, because we see people coming, they're already on the second line of antibiotic therapy, and they come to the ICU and we say, oh shit, what do we do now? What do we give now? He's taken everything and he's dying. What do you do? So prevention before treatment, and we have to do it because you're students, you're coming to the market. I insist on this. I may be the bad guy, but it starts from you. If you don't use it correctly and wisely, the problem comes to us, and the solution, there's no solution. The patient dies. Thank you.
I totally agree. If you allow me, last sentence is that it's something that Yorgo said, and I want to repeat it, for the prevention within the hospital. We do get patients in ICU that they have taken all antibiotics, and when they come into the unit, we do not know what else to give because they have taken everything. So I think very important, and since there are students here, education. Education is the major step in everything. In everything we do in life, we have to be educated to see what happens, to go back and see the results, to go forward and learn new things. And education is very important. And education convinces people that this is the right way. And the right way is preservation of the antibiotics. And the good drugs that we have, like the Kefiderocol or the new antibiotics we have, they'll do the job when they have to do the job. I'm very certain of that.
So if there are no more questions, Dr. Theodorakopoulou, Dr. Koukios, thank you very, very much.
Thank you very much.
We thank you.
going to be cardiologist, but I hope that you will be inspired somewhat to become a cardiologist. It's a great, great specialty. Now, I'll start with this lady. She's 76, breathless, and in pulmonary edema. You can see the upper lobe diversion, systolic blood pressure above 167, so high blood pressure, pulmonary edema. And this is the echocardiogram. That's how generally we start. What you see here with the parasternal long axis view. Let's see the aortic valve, the mitral valve here, the left ventricular walls, the septum and the posterior wall. In the middle is the mitral. And on top here you see the right ventricular outflow tract. What you see immediately from this projection is that the left ventricular cavity is normal. There is concentric left ventricular hypertrophy. And there is, importantly, good, very good left ventricular function. On the right, you have the apical four-chamber view. It's just another projection of the two-dimensional echocardiogram. Here you have the left ventricle, the apex on top. On your left is the right ventricle, and here at the bottom is the mitral valve as it opens and closes. And again, you see a concentric left ventricular hypertrophy and a very good ventricular function. The ejection fraction estimated about 60% can be measured. On the bottom, you see the Doppler indices. This is the transmitral velocity with the E and A wave. The E wave is reduced somewhat. And on the right bottom here, you have the tissue Doppler. It's another method I'll mention briefly later on, where you see, you take the signal, the moving signal from the ventricular septum here, and you record the E prime and A prime waves. And what we want to do is the ratio of transmitral E to tissue Doppler E prime, and this ratio, 120 is the measure in centimeter per second, and 5 is the E prime. The ratio is 24. Normal limit is up to 15, and I'll show you later on what it means. The measure is very high. The ejection fraction is normal, 60%. So, what are the criteria for diagnosing heart failure with normal or otherwise preserved ejection fraction? We want symptoms. Our patient had pulmonary edema, so major symptom. We need some signs typical of heart failure, normal or mildly reduced ejection fraction, but importantly, the left ventricle not to be dilated. Relevant structural heart disease, such as left ventricular hypertrophy or enlarged left atrial size. So in our patient, we have left ventricular hypertrophy. And or diastolic dysfunction. The transmitral velocities and the tissue Doppler velocities I mentioned are indices of diastolic dysfunction. And I will focus during my talk on diastolic function. However, a comprehensive assessment of the left ventricular diastolic function, yet in the guidelines, has not been fully integrated in routine clinical practice in the majority of institutions, although it gains popularity. Quantitative echocardiography, and echocardiography is a very quantitative method to measure things. The criteria for quantitation have to be clinically useful, not make a measurement for the sake of it. We need to have clinically useful measurements. One criteria is to be feasible in the vast majority of patients. Not good to do it in a few patients. Must be obtainable with minimal disruption of our daily practice, busy practice. it needs to be cost-effective. It has to have a limited increment in interpretation time, so don't go back to the department and spend an hour or 2 hours to interpret the findings. And importantly, to be consistent between and within observers, inter and intra-observer variability. And eventually needs to be linked to clinical outcomes. The simple view is that diastolic dysfunction occurs when there is a change in left ventricular filling, remember this terminology, important, and or an increase in pressure when the heart fills. So not in systole, but in diastole when the heart fills. Only echo and Doppler combination may assess diastolic function non-invasively. So it is an important tool we have in hands, and we need to interpret it wisely. What constitutes now a diastolic screen? The simple view is left ventricular size and function, left atrial volume that needs to be increased, the transmitral velocities that I just mentioned in the echocardiogram, the ENA ratio, and the deceleration time, and the tissue Doppler indices, the E to E prime ratio. Sometimes we need more. When do we need more? When we need to refer for diastolic function, referral for dyspnea, new unexplained signs of pulmonary hypertension that some patients may have, and a markedly abnormal screen. Now, diastolic function. Yes, it is important. Why it is important? Because it is linked to survival. And here on the green line, what you see is the normal survival in a person who has normal diastolic function. The orange line is when the patient has mild diastolic dysfunction, and the yellow line is what you do not want, severe diastolic dysfunction. So you see that survival is reduced as the diastolic dysfunction gets worse. Criteria for definitive diastolic dysfunction, we need to have definitive evidence of congestive heart failure, led by symptoms, signs, chest X-ray, pulmonary edema, response to treatment, and an objective evidence of normal systolic function of the left ventricle, generally more than 50%, 60, 55%, within 70 hours of the event of pulmonary edema, and objective evidence of diastolic dysfunction, abnormal left ventricular relaxation, filling patterns, and distensibility indices. Nevertheless, we need to exclude valve disease, cor pulmonale, and patients who may have volume loading conditions such as mitral or aortic regurgitation or septal defects. There are several ways to skin a cat. We can assess diastolic dysfunction either by transmitral flow, velocities, either by pulmonary hepatic vein flow, with color and mode, so we can assess the propagation of the mode. I'll show you a picture. Tissue Doppler imaging that I showed you a couple of images, which is important because it is relatively preload independent, whereas the transmitral velocity ENA waves are more dependent on loading conditions, and the deformation parameters such as strain and strain rate imaging that I will not go through in this, this time. So this is the pattern of the echo parameters we have to assess diastolic function. This is the transmitral velocity, the ENA wave, the normal person, deceleration time, the tissue Doppler. You see that the E prime is higher than the A, the propagation velocity by color and mode, and the volumes of the left atrial size. Conversely, a patient with systemic hypertension has abnormal diastolic function. Here we have prolonged relaxation. It is stage 2 of diastolic dysfunction, so it is at least moderate. We have lowered E prime, impaired relaxation with prolonged relaxation time here on propagation of the transmitral velocity, and understandably an increased left atrial volume. So all these are easy reproducible parameters to assess diastolic function. Tissue Doppler, the Doppler signal from the tissue of the left ventricle can assess the regional diastolic function, not just global, but also regional, quantitate diastolic function. It is not influenced by translation movement of the heart. It's less preload dependent. Normal, the E prime is 10 centimeter per second. More, it is abnormal. Moderate diastolic dysfunction is less than 8 centimeter per second, and severe, it is even less than this. Importantly, we need to exclude patients in atrial fibrillation because all these parameters may be affected. This protocol is simple and amazingly useful to assess the patient with symptoms. This is the tissue Doppler as we progress from normal transmitral velocity and ENA wave and the tissue Doppler, as you see, the mirror image more or less. And as the diastolic heart failure progresses, the E wave is going up. Our patient has this pattern, grade 2, whilst the E prime, the tissue Doppler measurement, remains stable. So the ratio of the E to E prime is increasing as the grade of diastolic dysfunction progresses. And this is an important slide because it shows you the significance, the clinical significance. We can non-invasively estimate the pulmonary capillary wedge pressure, which otherwise you have to do an invasive catheterization. So, and in this, you can see the pulmonary capillary wedge pressure in the y-axis, and the x-axis, you have the TDI measurements. So what you see is that when this TDI measurement is less than 15 or better, about less than 8, all your patients have normal pulmonary capillary wedge pressure, which is about 15 or less. Whilst when it is above 15, the tissue Doppler ratio, then you see that all patients have raised pulmonary capillary wedge pressure. There is a bit of a gray zone between 10 and 15 centimeter per second, where you have a little bit of overlapping patients. But if you have less than 8, more than 15, the tissue Doppler indices, then you can very reproducibly estimate the pulmonary capillary wedge pressure. Very, very important. And this, as you probably know, in heart failure, you have a biomarker, the BNP, the natriuretic peptides, that are linked to pulmonary capillary wedge pressure and heart failure. And this is the relationship between BNP and wedge pressure. It's okay, right? But on the right here, you have the significance of the E to E prime ratio and the pulmonary capillary wedge pressure. I think this is a lot better. So the combination of the two, you have a very accurate, quick, non-invasive estimate of pulmonary capillary wedge pressure. And this is another important slide about the survival. So ejection fraction less than 40%, so left ventricular systolic dysfunction here. You see that the survival is much worse when E to E prime is more than 15. But also in patients like ours with ejection fraction preserved or normal, you see again when the E to E prime is above 15, the survival is worse. So not only in systolic dysfunction, but also diastolic dysfunction, the E to E prime ratio is linked to survival, something that we want to know. I will not go through the details of this slide, Just to focus on the middle line, you have three axes. The middle axis is TDI measurements in the center of this diagram, more than 15, in between 8 and 15. If they are normal, you need the biomarkers and make the diagnosis of heart failure with preserved ejection fraction. But also, if you choose the line of biomarkers first, then you have an abnormal biomarker, and then you need also the help of tissue Doppler. And if that is more than 8 or 10, then again you make the diagnosis. Otherwise, you have other echo Doppler parameters that you can use to make a more refined diagnosis. This is a line of tissue Doppler, and why it is important, because probably some people say, oh, I cannot get good pictures on echo. Yes, it doesn't matter, because with tissue Doppler, you don't have to have a perfect picture. The machine knows more than what you see. So if you position your cursor in the ventricle or the lateral wall, you can have a very nice line and estimate of the E prime. So Doppler data, frequency shift, high frame rate, obtained when even with suboptimal images. Now, in systemic hypertension, cardiac remodeling change in shape, size, and function of the heart. We know that. This involves cardiomyocyte hypertrophy, fibroblast proliferation, and fibrosis, and eventually to cell death. Fibrosis may be contributing to diastolic dysfunction, at least in the animal. So on the left here, you have a normal myocardium with no collagen, no infiltration of collagen. On the right, you have a hypertensive patient with a blue staining here. You have the interstitial collagen. And that is a problem, because left ventricular dysfunction is affected by high blood pressure. Interstitial fibrosis may be related to diastolic dysfunction, and cardiac magnetic resonance imaging can detect the presence and the distinct pattern of fibrosis. And this is such a pattern. You have mid-wall fibrosis, this white dot here in the middle of the lateral wall, in this patient, hypertensive patients with high blood with concentric hypertrophy and late enhancement fibrosis. So CMR, we have a tool that can detect fibrosis. And finally, is there something else? Well, maybe, because normal ejection fraction heart failure in systemic hypertension, you have these pressure volume loops, as you know, diastolic. The volume in this abnormal patient with diastolic dysfunction, the end diastolic volume is increased. This is in systole, the systolic ventricular and arterial stiffening. So this line tells you about the elastance, the end systolic elastance and the effective arterial elastance that we are focusing mostly on the EA here. So the steeper this slope is, the stiffer the left ventricle is. And this is a nice slide that shows you on the left the normal pressure volume loops in the low end diastolic volume, the end systolic volumes here, stroke volume in the middle, the elastance and the arterial stiffness is normal with these figures. In contrast with the patient with arterial hypertension and heart failure, you have a normal but not increased end diastolic volume, but instead you have, with normal volume, you have an elevated pressure. So you have a normal volume but high pressure. So that constitutes the patient with heart failure. The steeper the effective arterial elastance with this line describes the presence of diastolic heart failure. And in this analysis, the white column is normal controls. The black line column is the controls with age matched. The dotted column is controls hypertensive patients with normal function. And on the right hand column, you see the patients with heart failure and normal preserved ejection fraction. So that you see that these patients, the effective arterial elastance is increased. So that's a good measure to assess patients with heart failure. And that is, again, the different parameters. In the middle, the pressure volume loop in a normal person. In a remodeled patient, that is an asymptomatic, with increasing left ventricular size and volumes, yet keeping the pressures low. In contrast with the hypertensive patient with diastolic dysfunction, you have normal ventricular volumes, but high pressures very, very quickly. So that constitutes your patient with diastolic dysfunction.
Professor Nichoianopoulos.
I'm finishing.
Thank you.
So arterial stiffness appears to play an important role. I will not go through. And then to conclude, Mr. Chairman and Mrs. Chairman, tissue Doppler and other deformation parameters depict left ventricular diastolic dysfunction early. Interstitial fibrosis and hypertension may be related to diastolic dysfunction. Here we need a good MRI to avoid artifacts, and diastolic dysfunction is linked to reduced arterial compliance and eventually outcomes. Thank you.
Thank you very much, Professor Nichoianopoulos. A quick question for me. Do you think that the implementation of artificial intelligence will make a busy cardiologist less busy or less cardiologist?
Both. I think it is a tool, an amazing tool we have in hands. We need the wisdom and the smartness of the cardiologist or any doctor to use it to help him or her rather than be helped by. So, an amazing tool.
It's with my pleasure that I'm calling to the pod Associate Professor Dr. Kaliroy Kaladji from University of Ioannina, Department of Nursing, School of Health Sciences, to talk about, okay, the topic of the whole session is the personalizing cardiovascular care. So, very interesting. Talk about the balancing in controversies of antithrombotic therapy in cardiac thrombosis.
Good afternoon, everyone. I would like to thank Professor Patrikios and the organizing committee for the kind invitation. It's a great honor to be part of this Congress for the first time. So today I will be talking about controversies and challenges in antithrombotic therapy. I have found more than 50, but believe me, I have chosen some of them, the most important, by my opinion. So antithrombotic therapy consists of anticoagulant and antiplatelet drugs, and the antithrombotic therapy always balances between ischemic risk and bleeding risk. And there are several determinants that could affect this balance, such as patient's characteristics, clinical presentation, and comorbidities. One of the most important controversies in antiplatelet therapy is the optimal duration of dual antiplatelet therapy. The default strategy by guidelines is 12 months of dual antiplatelet therapy after an ACS, but we can either prolong DAPT or shorten DAPT in order to avoid thrombosis or bleeding. Since 1995, several studies have evaluated different strategies focusing on ischemic events or bleeding events, but the most important thing is to evaluate the bleeding risk, either by using scores like the precise DAPT score or the research consortium for high bleeding risk. You can see all these factors associated with an increased bleeding risk, but remember that these factors are also associated with increased ischemic risk. So, DAPT strategies to reduce bleeding risk in patients with ACS are abbreviation of DAPT duration or de-escalation of DAPT intensity. Lately, there is a trend of dropping aspirin from the antithrombotic cocktail, and this is due to the high bleeding risk that is involved with aspirin. And I would like to say that when aspirin was established, there were no novel antithrombotics or statins. So considering the fact that ischemic events usually occur in the first 30 days after an ACS, we should not shorten DAPT duration on the first month after an ACS. This is very important. Most data concern ticagrelor monotherapy that reduces bleeding risk without increasing ischemic risk, but if you want to continue with clopidogrel monotherapy, according to Smart Choice study, you should do this after the first 3 months post-ACS. So European guidelines suggest aspirin or a P2Y receptor inhibitor monotherapy after 1 month of DAPT, or if the patient is event-free after 3 or 6 months of DAPT and is not high ischemic risk, single antiplatelet therapy should be considered. The same applies to the other side of the Atlantic Ocean. As for de-escalation, it could be unguided or guided by platelet function testing and genetic testing. It could be an alternative DAPT strategy to reduce bleeding risk, but de-escalation as abbreviation is not recommended in the first 30 days after an ACS. And let's go quickly to the opposite strategy, the prolongation of DAPT duration. The risk of ischemic events in patients with CAD is not stopped after 6 months or 1 year, so we can prolong that if the ischemic risk outweighs bleeding risk, especially in patients with complex PCI. The default strategy is aspirin monotherapy after the first 12 months, but we can bypass this default strategy either by adding rivaroxaban or by adding P2Y inhibitor to aspirin, or to continue with P2Y12 inhibitor monotherapy. And we have arrived at these alternative strategies using the results of the COMPASS trial, of Pegasus-TIMI trial, or DAPT trial, but there are no direct comparisons between strategies. Another great challenge is the combination of antiplatelet and anticoagulant therapies, the known triple therapy, in patients with AF undergoing PCI. Why? Because of increased bleeding risk. Key clinical trials as Pioneer, Redual, Augustus, and guidelines advocate the use of that, especially in patients at high bleeding risk. So, guidelines shorten the triple therapy for the first week after the PCI, or at most for the first month, and then continue with DAT, OAC, anticoagulant, and DAPT, and then OAC alone. So let's go further and talk about anticoagulants. DOACs are as effective as heparin in preventing thromboembolism in patients with AF, and some of them are even safer, like apixaban. But there are several clinical scenarios where DOAC lacked safety and or efficacy compared with standard treatment, or they didn't show a net benefit compared with standard treatment. Which are these scenarios? Mechanical heart valves, rheumatic AF, thrombotic antiphospholipid syndrome, pregnancy, breastfeeding, or patients with end-stage renal disease and AF. Some of the greatest controversies are when we want to manage anticoagulation in patients with comorbidities. So if our patient has chronic kidney disease, we should modify the DOAC doses according to renal clearance. When DOACs are used in patients with advanced chronic liver disease, they should be used with caution, and when the patient has cirrhosis, Child-Pugh C, DOACs are not recommended. Another issue is anticoagulation management in extreme body weights. When the BMI is over 40, we should use NOACs with caution and consider NOAC plasma level measurements or even VKA. Let's talk about the patient with cancer. Unfortunately, there are limited data regarding anticoagulation for cancer patients with non-valvular atrial fibrillation receiving chemotherapy. Consequently, data from other populations or clinical scenarios have been extrapolated and considered in the context of efficacy, of safety, of drug-drug interactions in case of chemotherapy, and of course, the patient preference and quality of life. And we should not forget patients with thrombocytopenia. When the platelet count is less than 20,000, we must avoid OAC therapy because of the risk of spontaneous bleeding. And when the platelet count is between 2,000 and 50,000, we should proceed with great caution and have our patient in a very close clinical and platelet count monitoring. I think that the most important controversy is anticoagulation management in the elderly. Older patients are at increased risk of both fatal stroke and OAC-related bleeding. In real-life clinical practice, a fear of OAC-related bleeding might lead to the underuse of OAC in older individuals, unfortunately. Published data, however, clearly demonstrate the beneficial effect of anticoagulants for stroke prevention in older patients with AF. There are several factors to consider in the management of elderly patients with AF, such as CKD, end-stage renal disease, polypharmacy, frailty. We should calculate the clinical frailty scale and score, and of course, recurrent falls. Falling per se is not a contraindication for NOAC use, but precautions should be taken and modifiable bleeding risk factors assessed. You already know that there are recommended doses for DOACs, and underdosing of DOACs increase poor outcome and, of course, mortality. So we should not underdose DOAC only if there are several criteria that are met. So there is this guidance for the specific doses that we should follow when we manage elderly people with atrial fibrillation. Another big, great challenge is when a patient with AF have stroke despite taking NOAC or VKA. You should know that we call this as anticoagulant failure. So the optimal timing of OAC initiation in this scenario is unfortunately uncertain. Guidelines suggest to restart anticoagulation between 4 days and 14 days. Of course, when we exclude hemorrhagic transformation by brain CT or MRI. Remember that a multidisciplinary team approach appears mandatory in this challenge situation. And of course, there are no data if we want to choose one NOAC over another. A change in NOAC type is often practiced in these situations, but there are no data, and maybe we increase by this management the rate of stroke. A certain level of fear among both clinicians and patients is the anticoagulation in patients with previous intracranial bleeding. Patients with intracranial bleeding excluded from the RCTs. But the observational studies showed that the institution of OAC therapy after intracranial hemorrhage compared with no treatment was associated with a lower risk of ischemic stroke and all-cause death. So, we should consider reinitiation of NOAC after 4 or 8 weeks after multidisciplinary team assessment. Brain imaging, again, mandatory before reinitiation of NOAC. In conclusion, advances in STEM technologies, personalized medicine tools, and pharmacogenomics have further refined treatment strategies toward tailored approaches. Despite these developments, the optimal duration of antithrombotic therapy remains debated, particularly in complex patients and scenarios. Emerging therapies and real-world evidence are promising, aiming to reduce bleeding risk and improve long-term outcomes in patients with CAD and atrial fibrillation. Thank you for your attention.
Thank you very much. Just a comment, I think that the precision medicine, actually antithrombotic treatment, it's one of the most everyday paradigm for precision medicine that we definitely need precision medicine. That's what
I agree,
I
but
believe.
it's not always easy to calculate this course and implement them in our patients.
Definitely not.
So just remember the risk factors for bleeding and stroke and proceed with anticoagulation management.
Okay. So any questions from the audience? Yes, please.
Hi, thank you very much. Excellent talk. Two quick questions. Recently, there have been a lot of trials saying that we should stop aspirin and continue with clopidogrel for chronic therapy rather than aspirin in secondary prevention because of more safety. What's your personal take? Do you believe in that, or is it a bias because of the trials done? And second, I don't know if you come across, there was one trial published in the New England Journal of Medicine end of August in France, where they added aspirin on top of chronic anticoagulation in patients with established coronary disease, and aspirin not only increased bleeding, but increased ischemic events. So is aspirin maybe not as this wonderful little drug we all believed?
Of course, aspirin is not a wonderful drug. It increases bleeding risk. For the first question, most studies advocate for ticagrelor monotherapy and not clopidogrel monotherapy. The SMART choice, the last trial about this, told us to use clopidogrel monotherapy after 3 months and not in the first month, because they think that ticagrelor is more effective and safer than clopidogrel. So we should probably use ticagrelor monotherapy than clopidogrel monotherapy. Aspirin is not, I think it's not an ischemic drug, of course. It's an antiplatelet. It's the first antiplatelet drug established in the antiplatelet therapy. To tell you the truth, this trial has a lot of controversies and challenges, like the title of my study. The most important, the truth is that aspirin increases bleeding risk, and I think that it increases afterwards ischemic risk because we have data that a patient with CAD that has suffered from bleeding has also an increased ischemic risk afterwards. He could have a myocardial infarction afterwards. So I think this is the mechanism through which aspirin induces and increases ischemic risk, also as the bleeding risk.
Thank you very much. I think we must move on. So,
thank you.
So the last speaker of the session is Professor Katerina Naga from the Medical School of the University of Ioannina. The title of her lecture is When to Worry, Controversies in the Management of Acute Heart Failure, Guidelines versus Real-World Practice. Is there a gap between these two entities, Katerina?
Well, difficult to say because guidelines per se are controversial in that area. So thanks to Professor Patrikios for the honor to be here with this difficult topic and having Professor Fuster also in the audience. So in the next 15 minutes or so, I'll try to guide you through the guidelines of acute heart failure, mainly because real-world practice is not really known or studied in the current era, and it probably also depends on the country and the part of the world where you practice medicine and cardiology and emergency medicine. And guidelines, as you're going to see in the next few slides, they're also, they mainly involve a level of evidence C recommendations, so they are controversial and they're based on expert opinion themselves. These are my disclosures. So acute heart failure is a syndrome characterized by rapid or gradual onset of symptoms of heart failure that are severe enough to lead to an unplanned hospitalization or a visit in the emergency department. What I think is not really known, and that's a controversy to me, is that it's very common. It's the leading cause of hospitalization in patients aged more than 65 years. And it's also very severe because it has an in-hospital mortality that goes up to 10% and a post-discharge 1-year mortality that goes up to 30%. And I don't even think that cardiologists have appreciated the severity of this condition. I think we all agree that the diagnostic workup of such a patient that starts in the emergency department is laborious. And we need, let me see whether I can use that, yeah? We have to do it properly, I'm afraid. Yeah, I think I managed. We need to identify the clinical presentation of the syndrome. That is something that we don't often do still, despite the guidelines, and also find any potentially reversible life-threatening conditions that accompany the syndrome. We have the natriuretic peptides that we are, they recommend to use. Well, they're not easy to use. They're supposed to have a high negative predictive value, but their rule-in value for acute heart failure is also complicated, and it depends on the age group of the patient and other parameters such as whether the patient has atrial fibrillation, has acute or chronic kidney disease, the BMI, whether he's obese, whether it's a very acute condition, or whether it's right heart failure. We have to identify early whether we have a very severe patient with cardiogenic shock and or respiratory failure, because we have to treat that in a specific way. Then look for specific causes using this acronym. Acronyms are very popular in cardiology and in emergency medicine. And if we exclude this acronym, then we have to proceed to different clinical presentations. I think this is very useful addition from the ESC guidelines. We're trying to classify the patients in one of these 4 categories, whether it's an acutely decompensated chronic heart failure patient, an acute pulmonary edema, an isolated right ventricular failure, or a cardiogenic shock. The cardiogenic shock is a history and not just a single talk on its own, so I'm not going to touch upon this. We still haven't reached a very useful definition. It has many stages, etc. So I'm trying to avoid to talk about cardiogenic shock. This classification, I think it comes as an improvement or an addition to what we have used to see as a classification of acute heart failure based on congestion and perfusion of the patient. So it's, we still have to think of those 2 important parameters. And if we look at the clinical presentations, I think it's very important to see that the 3 of them have diuretics as the main treatment. So we have to learn to use diuresis appropriately. Cardiogenic shock has inotropes and vasopressors, and this is what we have to resort when diuretics fail in the other 3 syndromes, and obviously short-term mechanical circulatory support. And we only have vasodilators in the acute pulmonary edema when the systolic blood pressure allows. So the most common is acutely decompensated chronic heart failure, up to 70% of patients, congestion with normal or low systolic blood pressure with a gradual onset, and it's mostly people who are already diagnosed with a syndrome. Acute pulmonary edema is different in that it has a rapid onset compared to the previous presentation, and it's mainly characterized by lung congestion with a high afterload, with a high systolic blood pressure. If you look at either, the algorithms are quite complicated, you know, whichever clinical presentation you look at, you'll see that they're mainly C, maximal B level of evidence. It's worth looking at the oxygen therapy and the non-invasive ventilation. Oxygen is, should not be used if the patient hasn't got hypoxemia, and this is a controversy that we should point to. We should learn how to use non-invasive ventilation with either a CPAP or a pressure support, because that's very helpful for the patient, and that's an important thing that we should point to. And this is the recipe we have for diuretics. For patients who are naive, what to do for patients who are already on furosemide, how we should monitor the urinary output and the urine sodium to step up or not. We should go very high, look at the doses that we should aim for IV furosemide, and even higher for patients who have a severe chronic kidney disease. And if those fail, we should even combine other types of diuretics. Level of evidence C, and this strategy, that to step up or not, it was actually tested after the publication of the guidelines. And it showed in this nice study that we may have an increase in diuresis and natriuresis, but no real differences in the clinical endpoint. And well, it sounds easier in Greek, acetazolamide, that has been used and tested in this trial, has shown some effect in the diuresis and the natriuresis, but it wasn't, it's difficult still to use because that's an IV drug that is not available in any country so far. And we still are waiting to see how it's going to be combined with the rest of our treatments. Vasodilators 2B, only for patients with a decent systolic blood pressure, well, acute pulmonary edema. Inotropes, complex situation for patients with a low systolic blood pressure and hypoperfusion who do not respond to initial treatment. We mainly use dobutamine, but we should have, we should pay attention to the use of levosimendan, which may be preferred over dobutamine for patients on beta blockers, and it's very popular in Greece and in some other Mediterranean countries. Vasopressors, norepinephrine is usually preferred in patients with severe hypotension, and we usually combine those medications for patients who are in a very critical state and also in cardiogenic shock. And looking at this slide, we have tried to artificially break the phases of management of this complex syndrome in 3 stages. And one can appreciate it's almost impossible to test an intervention in a placebo-controlled randomized trial, just looking at this slide. People have done some important studies looking at that. In the immediate phase of acute heart failure, there's this publication of the Elizabeth trial in 2020 that showed by implementing an early and comprehensive care bundle, including nitrates, compared with usual care, improved the adherence to guidelines. But although this was improved, the 30-day outcomes did not improve. Maybe because there's not much into the guidelines anyway. And what has recently attracted a lot of focus and attention is congestion. We know that we should pay a lot of attention in the pre-discharge phase of acute heart failure in congestion. Most of our patients come in hospital wet and warm, congested, but a decent proportion of them also leaves hospital with congestion. So we haven't really achieved much there. Why? Because assessing congestion is difficult and complex, as you see here. And apart from diuretics, we also have to use all the other heart failure drugs to achieve decongestion. And we know that we're not doing this well. The optimal guideline-directed medical treatment in these patients remains low for the chronic and the acute heart failure. And although we are told early on that we should follow them up closely and give them either a telephone or an outpatient follow-up within 7 days of their discharge, and making sure that they receive all heart failure medications, this is not being regularly done. And this is why this study, the Strong Heart Failure Study, has, I think, is very important. It's a complex study, but I think 3 points should be remembered. Before discharge, make sure we have introduced half optimal doses of the heart failure therapy. Within 2 weeks, up-titrate the doses to as optimal as we can go, as tolerated by the patient. And remember that this study was prematurely discontinued actually because the active arm of the study did so well compared to the usual care. What we know from this study, an optimal dose can be achieved. It improves hemodynamics and it improves congestion. Does it improve clinical endpoints? It did improve the 180-day readmission for heart failure or all-cause death, although the all-cause death was not significantly different. This is an important endpoint for this group of patients, and it can be done safely. We have some more adverse events in the high-intensity care, but the serious adverse events do not differ between the two arms of the study. We also have data from the Pioneer heart failure that the ARNI treatment is beneficial for these patients. We also have from the EMPAL study data on the SGLT2 inhibitors that they improve at least the quality of life in this type of patients. And this is why this strong heart failure, let's say, strategy to treat as aggressively as possible these patients before discharge has got a recommendation, a class 1 recommendation in the latest update of the heart failure guidelines. And I'll close with that. In this journey of the patient with acute heart failure, we know many more things now for the whole journey. And although we have many sort of failed randomized controlled trials, at least we know this. We have to think of the non-invasive ventilation early. We need to assess hypoperfusion and think beyond blood pressure. We need to target congestion, which is the main cause that these patients are admitted, and we need to assess that comprehensively and treat aggressively. Use diuretics as recommended in the latest guidelines, because at least we have a recipe and we can improve on that. And aim to, for an optimal discharge therapy, this is extremely important, and try to achieve it within 2 weeks after discharge. And with that, I thank you for your attention, and I hope I didn't exceed the time limit.
Thank you very much, Professor Nakati. It was an excellent talk. One comment, I would mainly focus on the fact that there is a gap between the optimal medical therapy and the implementation of it, since we know that every case of acute heart failure after discharge will beget and will initiate a next case of a readmission. So focusing on implementing optimal medical therapy is of utmost importance, and is a crucial intervention that every clinician should know and should implement.
Yes, so I fully agree with that. We need to aim to have all the drugs, all the classes of the drugs on board before discharge, and have a 7-day either outpatient follow-up or a telephone phone call to make sure that the patient still receives the medications or has an adverse event, or at least make sure that he or she is liaised with a heart failure clinic or a heart failure doctor, or at least a cardiologist, to improve on the discharge recommendations.
Thank you very much. One question from my co-chair.
Okay, excellent talk. It was very nice. As a hospital doctor, our only everyday concern is when to discharge a patient. When do we consider him that he's decongested really? So just your experience, I mean, your everyday practice. Is it the biomarkers? Is it the X-ray? Is it the ultrasound? What counts the most?
Yeah. Well, whenever we admit an acute heart failure patient, not a cardiogenic shock in our department, we all know and we inform the patient and the family that the mean duration of the stay is 7 to 9 days. This is monitored in our hospital. We can attempt, and our director, forces, do it shorter. Well, the price there is that the things are not going to be done to a satisfactory degree. Then the congestion is something that you tackle from the beginning. And we use biomarkers. We're not so, fun users because they're still quite costly in Greece, so we are not used to them. We just started having regular NT-proBNP in our hospital. But it's important to examine the patient, do an orthostatic assessment as well. And we also use a lot lung ultrasound and IVC ultrasound. So by the bedside ultrasound, along with a good examination of the patient, and some use from the natriuretic peptides is of paramount importance. But cardiologists and trainees need to learn how to examine the patient. So that's something that we need to reinforce in our teaching.
So thank you very much. We have to deliver the next to the floor. Thank you very much, Professor Naga. Thank you, everybody, for your talks.
Thank you.
Good afternoon from us as well. I'm Dr. Theodoros Christodoulidis, and along with Dr. Evagoras Economidis, we'll chair the next session. And to proceed quickly, I will call the first speaker, which is Professor Gerasimos Philippatos from Athens, from Attikon Hospital in Athens, who will talk about controversies in heart failure in 2025.
Thank you very much. Dear chairs, thank you, Professor Patrikios, for the invitation. I think that is not only my lecture, was also the previous lecture, the one before the previous, the whole afternoon is about controversies. And I will talk about controversies in heart failure. I think that the first controversy today is the classification, even if you see the word universal, is the classification by left ventricular ejection fraction. And why? And I think Professor Triposkiadis described this very elegantly several years ago. It is not clear in the clinician why therapy like an ACE inhibitors is good for a patient with an ejection fraction of 38, but not good for an ejection fraction of 42, when even the intra-observer variability in an expert in imaging, like Professor Nichoyanopoulos, like Petros, is more than 5%. And also, I think what is important, if we want to understand what we see these differences in the efficacy of treatment, we need to remember that neurohormonal activation in some, at least in some system, increases as long as the left ventricle increases in size, and I think that this is something that we should also have in mind. Something else that is also important, and we've seen from the registries, and this is from the Swedish registry, that at least 20–25% of patients, they move across the ejection fractions over time. So we need to find a better classification, and it has been already discussed in this Congress, could be personalized biomarker genetics, but this is suboptimal. The second area where we need something new, I will just present the concepts. In some of the controversies is the dilemma. I will tell my personal opinion, but I hope that we have time during the session or after the session to discuss it more extensively. We need better definition for advanced heart failure. Another area of controversy are the devices. Devices are the future. On the left part of the slide, we see the devices that have been approved recently or they are under in clinical trials approved by FDA. And there are many that we know. The cardiac contractility modulation, the atrial septal, the atrial septal, some devices. Also the devices for the valves. You know, over the years, the possibility to see decreases, and I forgot my glasses. So on the right part of the slide, something that is also important, the ventricular assist devices. The ventricular assist devices, the implantable, the ventricular assist devices for children, the ventricular assist devices for patients with congenital heart disease, and the artificial heart. But all these devices are expensive. We need to find and try in clinical trials a cheaper device. In the middle of the slide, you can see the PULVAD. That is the one invented by the late Professor Nanas. That is much cheaper and probably could be implemented easier. So we need methods to evaluate these devices, not only for clinical practice, but also for the recommendations to find which of these devices will be reimbursed, and also find the devices, how they should be evaluated, because we have a non-homogeneous system of evaluation of these devices in Europe. If we move from the treatment devices to monitoring devices, you know that we have the same problem. What we usually use, which is the weight change, appears very late, it's just before symptoms in the process of accumulating liquids in congestion of the patient with heart failure, as presented nicely by Professor Naka in the previous lecture. So we try to identify other areas like to evaluate the filling pressures or evaluate the autonomic dysfunction from the ICDs or the CRTs. I think that we are not there yet. And also, this is also a problem because even the devices that they have several trials, like the CardioMEMS, they have the problem that we don't have at the national level or at the European level discuss to see how from a hospital level these devices could be evaluated and regulated and coordinated at the national health system level or at the heart failure network, heart failure clinics network level. Professor Naka made my life easier for this presentation because one of the areas of controversy is the up-titration of heart failure drugs. You remember how it was 10–15 years ago, as we can see in this slide, and the main problem was, and this is from US, from the get with the guidelines with hundreds of thousands of patients, from those eligible for 4-drug therapy, and in this specific time period was more than 80% of patients eligible for 4-drug therapy, only 41% of these patients were on triple therapy. And as you know, it has been already estimated that this cost to the patient in hospitalization and mortality. There is also another reason to support what Professor Naka presented in the previous lecture. We know now that from the SGLT2 inhibitor trials that we see the clinical benefit very early after initiation of the drugs. Within the first 2-3 weeks, we see the benefit of the drug, and this is one more reason. And I will not discuss more the strong heart failure trial. We had to stop the trial earlier because the Data Safety Monitoring Board of the trial said that it is not safe for the patients to continue this intensive treatment versus usual care group because there was an improvement in the hard endpoints but also in the quality of life. Let's move to the other part of the discussion. In strong heart failure, did we have only patients with ejection fraction less than 40%? No. The benefit of this early initiation of the drug was across the spectrum of the ejection fraction. One of the problems of this strategy is that probably the burden for the heart failure systems or the heart failure clinics is very high, and I fully agree what it has been said before, that sometimes we have to monitor the patients early, but sometimes we have to evaluate the results of the biomarkers, of the biochemistry of the patients from a distance, because otherwise, especially in the busy heart failure clinics, the burden will be extremely high. Should we start the drugs in patients with heart failure preserve ejection fraction early? Yes, this is also from our Emperor Preserve trial, and as you can see, we've seen statistically significant benefit within the first 2-3 weeks. What happens in real life? In real life, most patients receive beta blockers or ACE inhibitors or ARB across the left ventricular ejection fraction. Where we have problems is with mineral corticoid receptor antagonists. As you can see here, in the middle, MRAs. These are patients eligible for MRAs, and we can see even in patients with left ventricular ejection fraction less than 40%, less than 70% of patients, they receive MRAs, and in patients with preserved ejection fraction where there was lack of evidence, less than 30% of patients receive MRAs. Despite the fact that MRAs in patients with heart failure reduced ejection fraction is class 1A, we have more than 2 trials showing a mortality benefit, but in everyday clinical practice in the registry, you can see 30% in US, and we have an explanation why on the other side of the Atlantic, they underperform even more in MRAs, but even in specialist clinics, like in biostat heart failure, less than 60% of eligible patients receive MRA. Probably we underestimate the perceived benefit, or we overestimate the perceived risk. What is also worrying, and I think is also part of the lack of the implementation of the guidelines, is if there is different interpretation, and it has been already discussed during this Congress, if there is different interpretation by the task force of the guidelines across the 2 sides of the Atlantic. Forget the reduced, the mildly reduced, and let's go to the lower part of the slides, to the preserved. Is 2B level of evidence B, that means 1 trial, and is not recommended in the European guidelines. Why? Because this is different interpretation of 1 trial that we all know, the TopCat. A neutral trial, but in a subgroup analysis showed different results. So it's very difficult for the clinician to evaluate the trial, Sometimes the clinicians, we just look what the guidelines say. I don't know if this is correctly wrong, but if we, from the both sides, from the sides of the Atlantic, we don't give the same message, this creates even more problems, and this is really big problem. Do we have other data in this field? We have the non-steroidal MRAs with different characteristics, and recently the fine arts trial with a steroidal on-MRA has given positive results. So hopefully we see better implementation of the guidelines in this field. What about comorbidities in these patients with HFpEF? For many years we thought that comorbidities is only a part of HFpEF. As you can see in the registries, across the spectrum of heart failure, we have comorbidities. And what should we do? We should evaluate the evidence and give the appropriate therapy. Of course, in iron deficiency, we have more evidence in reduced. Now we have more evidence in preserved. According to our clinical experience and the existing evidence, I think is not a dilemma, is not a controversy. We should do the best waiting for accumulating evidence. Last, I think that it's important to move, if we want to treat effectively heart failure, we should move to the prevention of heart failure. And we know patients with a history of cardiovascular disease, patients with diabetes, patients with chronic kidney disease, they are stage A, at risk for heart failure, or stage B, pre-heart failure. We did some years ago with the late Josh Bakris, we took these patients, and in the Fidelio trial, patients with severe chronic kidney disease and diabetes, we've seen with a non-steroidal MRA prevention of cardiovascular events, 13%, 14% relative risk reduction, but also in patients with less severe chronic kidney disease, what we've seen also 13% relative risk reduction, and what is important, all this benefit was from a reduction in heart failure hospitalization. Where is the controversy here? Where's the dilemma? Who should take care of these patients? Who should test for UACR, for albuminuria, and start this new therapy to prevent heart failure? I think it depends on the eGFR. Most of these patients that have been randomized in the Figaro trial were patients, 50% of them, with a history of cardiovascular disease, with eGFR above 60 and albuminuria, and these are mainly patients being treated by us in the first row, cardiologists, and I think the rest by internal medicine and diabetologists, and less by nephrologists. So I think this is not in my mind a controversy anymore. We should all try to implement heart failure prevention. Thank you very much for the invitation and for being here.
Thank you, Professor Philippatos, for a great talk. There are so many controversies in heart failure indeed. Are there any comments or questions from the audience? Yes, please.
Thank you very much, Professor Philippatos, for a masterly talk. One lesson for the students: the best teachers are the experts. Because, you know, anybody can learn something and teach it. But the expert, the authority in a field, must always be the best teacher, because he gives his own experience and knowledge. The second is, as you said very correctly, all those drugs, don't forget the diuretics, because with all those new drugs, we tend to underestimate the diuretics, which is a serious mistake. The third is MRAs, when coupled with SGLT2I inhibitors, have less danger of hyperkalemia. And the question as regards the fourth: where do the inotropy increasing drugs nowadays are placed, the myosin energizers and the calcium sensitizers. Thank you very much again for a great talk.
Thank you for your kind words, Professor Kokinos. About the second that I think is the most important, I fully agree that if you start an SGLT2 inhibitor with an MRA, you see less hyperkalemia, and also you see less reduction in the dose of MRAs, but also you see a smaller number of patients to stop to be withdrawn from the MRA. So I fully agree, and it, as you know, first has been found in the dapagliflozin trial and now in our eberol trials. So about diuretics, it's a continuous controversy how to use it, but I think that Professor Naka covered it nicely in the presentation, and the same applies, and there are several ongoing trials on this. How to combine the diuretics, I fully agree, is an area that, I mean, is a drug that has a lot of controversy, but would not cover all the controversies that we have in heart failure. And last but not least, inotropes also has been covered by Professor Naka, what we do today. But you asked about omecaptive, you asked about cardiac myosin activators. As you know, the previous trial was positive, and there is now an ongoing trials where most of the centers that they're here, they participate. I think that we should wait and see. This is always a problem because we cannot live without the inotropes, but we don't want to live with the inotropes. So I hope that omecaptive, one of the cardiac myosin activators, will give us a positive result. There was another one that, as you remember, many years ago, Staroxim gave some very positive results. We've just finished the SIMSMIC trial also with positive results. The problem with this drug is that it's at the end of its patent, and I don't think that any company is willing to invest on this, and this is one of the problems, because I don't think that we have, at least in Europe, a big organization like NIH to give money for a non-industry trial. Which one? I think the way that it is going now is to try to find specific gene therapy targeting a specific SERCA or some. There are some also going trial on this, and there is a phase 2 trial targeting the SERCA with the support of Litsacranias, but I think it's early to discuss about this today.
Thank you so much, Professor Philippatos.
Don't give me all the credit for the delay. Give it all some to Professor Kokinis.
We'd love to be here with you for the next half hour, but we have to get going. We welcome now Professor Dr. Lambros Michalis, who is an interventional cardiologist and a professor of cardiology in the School of Medicine at University of Ioannina, and who has a special bond with the island of Cyprus for many, many years now. He's going to talk to us on functional mitral regurgitation, diagnosis, and management. Professor?
Thank you. How does it start? How does it work? The slides? Okay, thank you very much. First of all, I would like to thank all of you being here, and also I would like to congratulate and thank Professor Patrikios for inviting me to this spectacular but also intriguing event. It's very intriguing, and I'll come back to that. And I would like to ask you, are there all medical students there on the top, there, sitting? Yes. And why do you sit all over there on the top? Can somebody answer me? I did that when I was young, but now, since many years have gone, I've forgotten it. Oh yeah, I got it. Because you want to get out without being seen. That's very simple. Thank you very much. Then let's go back to why this is intriguing. Why is this intriguing event? Because you have a very sort of diverse audience. And why should I be here? To try to impress Professor Fuster, which is impossible. I can't do that. I failed already. I know that. I have to stop. Try to teach you. And teaching, starting from what Professor Kokino said, that the experts should teach. Yes, the experts should teach. They are very good. But how they should teach, what should be the format? That's a very intriguing thing. So what should be the format of this talk? Thinking of that, and I've been thinking for many years, because I've been here for lots of times with Professor Patricios, the only way is to try to be simple. Simple as much. Because science is truth, and truth is simple. It's the truth we think we know, the truth that we try to find. And this has to be simple. And let's start now the journey about the functional mitral regurgitation. Well, mitral regurgitation, who has seen this shadow theater ever? You're very young. You've never seen that. Mitral valve is like what we've seen in the shadow theater, which if you don't know, that's fine. But it's like a door which is moving with cords. Somebody is moving from away, and that moves and closes and opens. That's what the mitral regurgitation. It's not just a symbol, it's not just a valve. It's a whole apparatus. It has the leaflets, the doors, and has also the moving mechanism, which has to be either from the above or the below. From the below is the annulus, is the chordae, is the muscle, is the ventricular wall. From the above is the left atrium and the annulus. So when something is not functioning, and mitral regurgitation is that this valve is not functioning, something is going wrong. So what's going wrong? Can be wrong everything. So we have done, trying to be simple, we divided and we say, if the leaflets are not working, that's primary, not part of my talk. If all the other mechanism is not working, it's secondary, dysfunctional. So this is my talk. So secondary mitral regurgitation is which everything is wrong except of the leaflets. Now, having said that, we have the mixed. This is not described. It's in the guidelines. It's what we see almost every day. It's quite often. And then both of them, for whatever reason, are not very well functioning. But the management for this part is the same like the secondary. So this is part of my talk as well. And there you can see this slide, which I tried to read it, I tried to understand it. I failed it all time. I can't remember it. Type 1, type 2, type 3A, type 3B, the Carpentier sort of classification. Useless. This is easier. I try to make it easier, although it does not look much easier. Look there. You have either the morphology, when the leaflets do not work, or the movements, when the others, or if both. So movements, secondary. Morphology, primary. Both mixed. Easier. So what is the etiology? When you try, you say something is not working, we have to find out why it does not working. And it does not work for many reasons. Why does all this movement does not work? Because you have ischemic cardiomyopathy, so the muscle does not work, does not shrinks. You have dilated, very dilated, the gait does not sort of shrinks very well. Or you have the left atrium enlarged, which means that the whole door is opened much more. Or you have the leaflets do not work because they're not very good, but due to the whole, because it's mixed. Or the leaflet does not work because the heart is dysynchrony, the left band block. Or you have hokum, which again makes funny movements of the leaflets. That's the etiology. And then when you find something that does not work, what do? Do you treat it? You have to fix it. Is that right? Do you have to fix it? Nobody answers. No, you don't. Does not mean that that's why in medicine 1 + 1 is not always 2. We have to find the reason why. It's not just because it's not working, and you have to think that the secondary mitral regurgitation is one of them. We don't treat it per se. We treat it only in patients with heart failure and only in symptomatic patients. And it's not our first line of treatment. First of all, we start with drugs. Second, we try to see if there's something which can be fixed, like aortic valve disease or ischemic heart disease. Then we have to put a pacemaker, which makes the heart sort of moving and shrinking much better. And then we have to look at the right part of the heart, the right ventricle, and the tricuspid valve regurgitation. And then, if we've done all these things and still does not work, then we try to fix the mitral valve. And how do we fix it? Well, there's only one way nowadays. Me being sort of an interventional cardiologist and having spent most of my life, now, 35 years or even more, in the cath lab, that's the only way which can be fixed. The others are under evaluation, and I'm not going to do that, sort of evolving, and so I'll stay there. And what we do, we fix it from right to left. We try to fix it, and I'll tell you how we do it. And there you see all the sticks. They haven't gone. Now they're all the ticks. I forgot them. All the sticks means that the only treatment for that is this type of treatment. But not to start with, after we tried and failed with all the others. And why we do it? We can either, when we treat something, either because we will improve prognosis, we make people live longer, or because we make them feel better. And feeling better is very important. It's very important for medicine. And cardiology has forgotten it, and we always went for gold to make them feel longer. That's not only the only important thing in life. We have to make them feel better. But can we treat all of them? Are they treatable? Well, we've got this criteria, the QAP criteria. There are 3, all of them, all and all, simple, 3. The heart is not be very enlarged, not more than 70. 70 in systole is very enlarged, but still here we are. The ejection fraction between 20 and 50, and the mitral regurgitation to be of quite severe. That's a way of measuring it. Not the best, not the only, but one way of measuring it. So you have severe mitral regurgitation, dilated, but not just a bug. The heart, the left ventricle, not to be just a bug, and the ventricle with an ejection fraction 20 to 50. Do we treat? If we treat this type of patients, then we make them feel longer, make them live longer. If we treat the others, still we can treat them. Then we don't go for longevity, we go for improvement of quality of life. Very simple. And this is a bit more the same of this thing. There's no point looking at this. And this is our simple tool. This is the mitral clip, or the Pascal. There are 2 of them now. Soon is going to be another one from India, possibly still good. And what do we do with that? Well, what we do with that, we try to mimic what the surgeons, or one surgeon, Italian one, who lived in UK at some point, and decided to do, to try to put a stitch between the leaflets, to try to bring them closer, and not to close them all together, bring them closer. What would you should have done if you have a door which does not close enough, but still you want to do something with it? This is what we do. We put a stitch there, but we do it not with opening the heart, cracking the sternum, having a severe operation, just going from the groin through a vein. Whenever you go through a vein, is not very dangerous. But in medicine, in order to do something, it's not that should be done. Has to be done and is useful only if can be done with small danger, and only if we can achieve through this method a good result. Otherwise, not do it. All these things, people live longer only if what we've done is successful. And what does it mean is successful? That we have a good result without putting people in lots of danger. And how can we understand, how can we predict the good result? Again, it's simple. It's simple. Just we do an echo. Oh, this is a good candidate. Big MR, but a good candidate. Let's see this one. Look there. There is a chunk of calcium. That's where we're going to put the stitch. Can you stitch a calcium? A chunk of calcium? No, don't do it. You will fail. So if it's calcified where you're going to put the stitch, don't do it. And there, look, this one, they don't close. They create a huge gap. How can you close this huge gap? You can't do it. So you see it, you say, no, I can't. I'm sorry, sir, I can't treat you. There, you see there that the flare there is a long width there. So if you're going to stitch that, you have to stitch for long from top to bottom, so don't do it. Again, these two, they don't close. They have a huge gap between them there. So you can't grasp them. Far too low, so you can't do it. Don't do it. And also, you are going to stitch something which is stitchable. So you have to find the tissue. If there's no tissue, you can't stitch. So you need, the length there has to be at least 7 millimeters. If it's less than 7 millimeters, you can't put a stitch. It's very simple. And another thing is that many times this mitral valve is not just 2 doors. It's more two leaflets. It's not 2 leaflets. It's more. And the one is sort of one from the other has a gap. And this is a cleft. That's what a cleft is. It's a gap. Should be 2, but sometimes nature creates 3, creates more. So you have clefts. And if something goes through this, through this faults of nature, again cannot be treated through this way. And also when you try to fix something, not create a bigger hazard. What is a bigger hazard from the mitral regurgitation? Mitral stenosis. Mitral stenosis is even worse. So if you're going to fix the mitral regurgitation, creating mitral stenosis, then again, don't do it, don't do it. And why all these things? Because it's good, the method, if we manage to create a small MR. Then, again, the survival is 22%. Heart failure with mitral regurgitation is a very bad disease. Even if we manage to treat it, 21 of the patients will die. If we fail, 50% will die in a year. So it's a bad disease, it's a severe disease. Don't underestimate it. The other thing is, when you go to a doctor, make sure that this doctor knows what he's doing with you. And not only the doctor, but also the environment where it works. So you need a center of excellence. And the more the doctor has done, the center, the more has done, the better the results are. So we're finishing now. I think you learned everything about the mitral regurgitation, how to treat it. First of all, has to be severe. Don't treat less than moderate mitral regurgitation. The patient has to have symptoms, and these symptoms have to be due to mitral regurgitation. The patient is going to live longer. If somebody is dying or is very frail or has other diseases, don't do it. There's no point. You have to have a good center and a good surgeon. You have to have something which can be technically done, and also should not be something else which creates prohibits the procedure. So symptoms first, optimal management, drugs second. Do all the other procedures that you want third. And then, if it's feasible, technically, do it with the mitral, treat the mitral regurgitation. Thank you very much.
Thank you, Professor Michalis, for the very engaging talk. We have time for 1 or 2 very quick questions. Dr. Christodoulidis.
I have a question. First, congratulations. It was a very interesting presentation. It's a rather technical one. I see a lot of patients with advanced heart failure who you are thinking that they are about to get an LVAD, and they have already also a severe mitral regurgitation. And we have the question, should we clip this mitral regurgitation and see if they get better, or this would make the LVAD's life difficult because we have a narrow mitral valve against?
Thanks a lot for the question. It was one of the part of the slide there that this type of patients that they have that are in a transplantation list or we're thinking for LVAD, we can use this type of treatment as a bridge, and about 20% of these people get out of the list because they have a very good result, so they don't need the further treatment. In our center, we do quite a few of these patients. We are referred back from the transplantation center in Greece, from the Onassis, to have this type of treatment as a bridge, because, as you know, in the Onassis Cardiac Center, there are about 12, 15 maximum heart transplantations per year, and also that the LVAD is also a bridging the treatment, it's not a destination treatment, so we get quite a few of these patients. They are difficult patients, they have to be optimized, treated. Possibly you have to put an intra-aortic balloon pump before you do the procedure, but it's worth doing them. And some of them, they are benefited quite a lot, and they will not forget, they will be very sort of pleased with what you've done for them.
Thank you so much.
Thank you. And I have a quick financial question. The treatment of valve disease has exploded recently, and many are blaming the cardiologists for the increasing costs of keeping patients alive with very expensive equipment. What's your take on that?
Thanks a lot. If you're going to blame the cardiologist, what you will do for an oncologist? Unfortunately, medicine is expensive. Now the priorities, I'll tell you something. Now we are going to an era that the Hippocratic oath is under question. All of us, we say that we give an oath. What is the oath? That the only person that we are responsible and we are sort of we are going to give to answer is our patient. Now, to whom we are sort of referring? To the patient or to the society? The society is the Spartan sort of law. If somebody is unable, throw them to the gorge to die because he's unable. But that's a sort of a thing. My feeling is that with this type of patients, it's not very expensive because you bring them back to life, and some of them they become they can work. They are not people that they are out of the sort of the social doing and the social everyday life. They are back to the sort of work and sort of offering back to the society. So I'm not very. I don't feel very bad about that.
Thank you so much. We're going to move on now. The next speaker will join us online. We are very happy to have Professor Randall Starling, who is a professor of medicine at the Cleveland Clinic Lerner College of Medicine in the Ohio, United States, who will talk to us about optimizing the treatment of heart failure with effective implementation of guideline-recommended therapies. Professor Starling, hello from Cyprus.
Hello. Good morning, and I am going to share my screen so that hopefully everything comes through the way it is supposed to. Can you confirm? Can you see my screen?
No, we cannot, Professor. Now we can, thank you.
Okay. All right, so let me begin. I just first I just want to extend my thanks to the organizers and Dr. Patrikios, and also extend my sincere regrets that due to the government shutdown in the United States and flight delays, I was not able to complete my journey to Cyprus. So very disappointing, but I'll look forward to seeing everyone again next year. So my topic today, which you've gotten some introduction to this from Professor Philippatos, is on implementation. And my specialty is heart failure. And I have spent the bulk of my career developing new therapies. But despite the fact that we've developed many new therapies, there's challenges ahead. And that is what I'm going to review today. So the problem is that we have, as you have seen, excellent evidence-based medications to treat patients with heart failure. That's what we do as physicians. We develop new treatments. The problem is that these medications are actually used by a minority of eligible patients. Why is that? What can we do about that? That's what I'm going to discuss to some degree today. As I have moved through my career, I have, over the last 5 to 10 years, become very interested in implementation science. So what is this implementation science all about? This is the science to figure out what are the gaps, what are the challenges, why are we not getting medications to patients, what are the barriers? We have excellent guideline-directed medical therapy. It is evidence-based, and we could significantly improve the health of populations if we could do a better job. So, as you've heard in this Congress, over the last 25 years, we've gone from the development of ACE inhibitors to angiotensin receptor neprilysin inhibitors, beta blockers, MRAs, as well as device therapies. We have significantly reduced the mortality, but the mortality is still far in excess of what we've heard, what we hope to achieve. And as you've just heard in the prior lecture, with something like the MitraClip, it is imperative that the patient first has background medical therapy deployed. So we today have quadruple therapy for heart failure with reduced ejection fraction. This includes the angiotensin receptor inhibitor, the beta blocker, the MRA, and the SGLT2 inhibitor. So in a perfect world, what could we expect? An improvement in health status, an improvement in ejection fraction in some patients, reduction in hospitalization, reduction in readmission, and reduction in mortality. All fantastic. If you look at this publication that shows the sequential benefits from placebo to quadruple therapy, the hazard ratio for mortality is 0.39. This is another study that was completed by colleagues at Brigham and Women's Hospital that looked at the theoretical benefit in a 55-year-old male with quadruple therapy. And it was estimated that successful deployment would add 8 years of life free of cardiovascular death or heart failure hospitalization. This amounts to a relative risk reduction of 73%, an absolute risk reduction of 26%, and number needed to treat of 3.9. I think you may have seen this slide from Professor Philippatos, but what it shows is with the ARNI, sacubitril valsartan, and with the SGLT2 inhibitors, we can expect to see benefits within weeks. And from STRONG-HF, which was led by Professor Mabaza in France, we have learned that it doesn't matter whether it's ischemic cardiomyopathy or non-ischemic cardiomyopathy. These therapies, quadruple therapy, the fabulous four, as some refer to them, they work. We also know that all of our populations are aging, certainly in the US, certainly in Asia, and in Greece, I'm sure. And we know from large registries that there's no reason to hold this therapy back in the aging population because the benefit is there irrespective of age. So what is happening currently? So you saw some data from this registry from Professor Philippatos. And if you look at the countries in red, they have about 66%. But you can see in Italy, for example, and other countries in Europe, the use of ACE inhibitors and beta blockers is much less. And despite the encouragement to follow the ESC heart failure guidelines, only 22% of patients reached the recommended dose, and 12% of patients achieved a recommended dose of beta blocker. You saw this slide, which shows from country to country that far less than 100% of patients are receiving core medical therapy for heart failure. And this again shows the results in India and other parts of the world. So I want to reflect on the Italian registry. This is a very recent population or publication from 2025. So they have developed an excellent registry in Italy. And you can see that the beta blockers are 95%, but the MRIs are less. Now, let's look into what are the reasons behind this? And we'll touch on that in the next slide, but this is a key point here. Only 41% of patients are on quadruple therapy with HFrEF, 41%. If you look at target dosing, less than 50% versus greater than 50%, we do very well with MRA and SGLT2, which essentially is a single dose. But in the drugs that require titration, it's only about 50% of patients that are on target dose. They also looked at contraindications. So any database that is looking at what percentage of patients are using a drug, you have to acknowledge that in some patients, their GFR, their potassium level, or their blood pressure may preclude the use. But they were able to show even in patients, for example, that had no hypotension, 24% of patients were not on therapy. So is it important to get a target dose, or is it just adequate to initiate the drug? We think it's very important to achieve the target dose. And this is the CHAMP registry, which is from the United States. This is from 5 or 6 years ago, but less than 20% of patients were achieving target dose. And this particular sub-study from the CHAMP registry shows that there is a correlation between quality of life and patients being titrated to a target dose. So more recently, we saw this combined effort in the Evolution Heart Failure Registry that included Japan, Sweden, and the United States. And this was published in JACC. And what was the conclusion? There is an urgent need for effective strategies, not developing medications, but getting them into the hands of patients, implementations of 4 pillars of GDMT. So looking at green, which is target dose, again, we do pretty good with SGLT2 inhibitors because they're so simple, but looking at the ARNI, only about 25% of patients achieved a target dose, and similar with beta blockers, which require titration. So again, looking at age, we see something else that's somewhat disturbing. And what we see is that patients that are elderly tend to have less GDMT use by age strata and less combination therapy. So why is this occurring? What is the problem? So Dr. Boskart, past president of the Heart Failure Society and past editor-in-chief of JACC Heart Failure, a very knowledgeable heart failure cardiologist, broke this down into patient-related components, provider-related, which is very important, and what are the obstacles related to health systems, payers, and insurance companies. So this is a very complex problem that we have decided to tackle. So if you look at medication dosing, what are the barriers? Again, we're all faced with time constraints in our clinics. We see patients with low blood pressures and orthostatic symptoms. Heart rate affects our ability to titrate beta blockers. And oftentimes, a subjective complaint of fatigue causes the physician or the practitioner to pause. So this is the list. Patient is already at a maximally tolerated dose. That's subjective. We should not be stopped by a patient that is clinically stable. So most of these are subjective, and I think we need to challenge these in our practice and focus on the emphasis of reaching a target dose. Cost is certainly a problem in the United States, where government insurance does not assure that these drugs get into the hands of patients. So in my mind, it is a real travesty when a patient is in front of me and has a $500 copay for a life-saving medication. So this is a challenge that we hope with our government support that we can remove that barrier in the United States. So one of the things that we did a few years back was we decided within our electronic medical record that if we could develop a scoring system for guideline-directed medical therapy, and we're not the only ones that have done this, that this would provide us with a tool to follow our patients. So this is the modification that we came up with, and we have embedded in our electronic medical record at the Cleveland Clinic, where the patient gets the score for being on an ACE inhibitor, sacubitril valsartan, a beta blocker, et cetera, et cetera. The score is weighted depending on whether they have achieved 50% or less or greater than 50% with an optimal score of 8. So again, within our electronic medical record, when a clinician has a panel of patients in front of them, they see highlighted what is the GDMT score, and this now provides a tool that we can use for a variety of applications, which I will show you in subsequent slides. So one of the first studies that we looked at in a large registry of over 6,000 patients, some from Cleveland Clinic, Ohio, some from Cleveland Clinic, Florida, we wanted to look at the utilization and impact of cardiovascular specialists on guideline-directed medical therapy. And this was multi-state based within our electronic medical registry. So what was intriguing to us was that we found that cardiology encounters, particularly those with heart failure specialists, were significantly associated with prescribing of GDMT. And here you see on this the odds ratios for a variety of different variables, including did the patient have at least 2 cardiology visits? Did they see a heart failure physician, etc.? And a higher GDMT score was associated by seeing a heart failure physician and or 2 or more cardiology visits over the prior 12 months. So can we use this scoring system to measure process and improve implementation? So one of the things, and this is just one example that I'm showing you, we have built into the electronic medical record triggers, and these triggers will calculate the guideline-directed medical therapy score. That will then send a message to the patient's provider, which oftentimes is a primary care physician. If they click and give their approval, a pharmacist will immediately become engaged to facilitate consultation and to work toward titrating the guideline-directed medical therapy. We also have developed a patient messaging to engage a virtual pharmacist to accelerate SGLT2 implementation. So the patient receives a message. It also goes to their physician, which they can override. And the patient, if they agree with their provider's blessing, again, the pharmacist will go through the pre-authorization to get the SGLT2 inhibitor on board with the patient. Finally, I want to mention something that has been developed now over the last 5 years, and this is through the Heart Failure Society of America, which is a tool called OMT Heart Failure. This is one of a number. ESC has also developed similar programs. So this is a very simple 2-hour educational-based program to teach a primary care physician, a nurse practitioner, a pharmacist about optimal medical therapy for heart failure. This can be purchased by a health system, and we believe that further education may be an initial cornerstone to improve implementation of guideline-directed medical therapy. So we have a pilot that has been in progress in Cleveland. There are a number of others around the country. This is one recent publication where we asked the people that took the course before and after their comfort level in prescribing various medications, including sacubitril valsartan, and we showed that they improved their confidence and knowledge. So lastly, I want to mention an initiative developed through the American Heart Association. This is known as Implement HF, and this looks at the use of OMT at discharge and 30 days later. Again, this is a multi-pronged implementation program. It looks at the data is abstracted from the electronic medical record. There are 7 sites around the US. They all work cooperatively and share best practices. There are efforts through the electronic medical record to facilitate medication deployment and adherence. And importantly, there are educational tools for the patients as well as the team members. So this was just reported this year in Circulation Heart Failure. And what they saw was that in patients being discharged from the hospital, and similar findings were seen 30 days later, but the use of quadruple OMT improved significantly with this program. The last thing I want to mention, and this is kind of new and exciting information for us, is this is, again, our data through the registry at the Cleveland Clinic Health System, where we have looked at the GDMT score in patients with heart failure with preserved ejection fraction, mid-range ejection fraction, and reduced ejection fraction. Not surprisingly, the scores are higher in patients with heart failure and reduced ejection fraction. We used the GDMT scoring system I've explained to you, and acknowledging all the faults in a registry, we're very excited to see that there appears to be a relationship between how high the GDMT score is and the patient's event-free survival. This is a similar challenge in the IMBMC, American Heart Association Registry, where they hope to look at outcomes and their ability to improve as GDMT score improves. So in summary, there is a need for implementation science in everything we do in medicine to get therapy into the hands of our patients. We need to assess the effectiveness, the scalability, and the sustainability. There's certainly cost involved, and we believe that through tools like AI and electronic medical records and deploying triggers, I've shown you a few examples today, that this will provide us with the guidance to the future. There are a variety of tools, many of which I've summarized for you. We've seen examples both of STRONG-HF and IMPLEMENT-HF that implementation science will improve deployment and hopefully outcomes. And treating a heart failure patient today is truly a team effort to improve using electronic health records, remote technology, algorithmic initiation, patient empowerment, we believe is extremely important, and the multidisciplinary approach. So thank you very much for the opportunity to present, and I look forward to engaging in this Congress in the future. Thank you.
Thank you, Professor Starling, for your talk, and especially thank you for managing to give us your talk despite the difficulties in traveling. We have a quick comment by Professor Philippatos on your talk.
Thank you very much, Dr. Starling. Actually, I have 4 short comments. First of all, congratulations, Ruddy, from this Cleveland Clinic initiative for the implementation. Second, we measured some years ago that there are more than 80 obstacles for the implementation of heart failure guidelines. And what I think is missing from Beckham's article is the obstacles related to the guidelines. I know that you, as president of the Heart Failure Society of America, and who were in the similar time when I was president of HFA, we tried to start some implementation program, but in my opinion, I want your opinion on this. The implementation programs should be run as clinical trials. This is what is missing. That's why I congratulate you for this initiative in Cleveland Clinic. Thank you.
Thank you very much, Professor Philippatos. And, you know, I think the point that Professor Philippatos is making is that implementation needs to be initiated at the origin, which is at the time of the clinical trial. And if you look historically, we've often wondered why, when we develop a clinical trial, we calculate endpoints such as heart failure, hospitalization, and mortality. And usually in a typical clinical trial, the endpoints and the events are less than what was calculated. And why is that? Because clinical trials are oftentimes not the real world. Patients are more closely supervised. They are getting messages, they are getting alerts. And the lessons learned in clinical trials, many of those I think we are now transitioning into our clinical practice. But I think what we learned in the Heart Failure Society of America, and we had a consultant that helped us look into this, we decided that education was the first thing that we would tackle. And so we're educating providers, but I think in the future, we have to get a lot of this into the hands of patients to empower them so they understand when they are not being treated that they need to be contacting their physician and asking why.
Thank you so much. One last comment from Professor Kokinos.
Professor Starling, thank you very much. This is Dennis Kokinos. We meet once more in another capacity now.
Yes.
Wonderful exposure, excellent. One other thing is that to make guidelines more approachable and followable by the physicians is to give them also a mechanism and pathophysiology aspect. Because, you know, the physicians would be much better focused and assured that they are doing the right thing if they know also not just the results of the trials, but also the underlying mechanisms. I think this trend is increasing and is being adopted slowly, and I believe this could be very helpful if we very well explained why we recommend those things. Thank you again for an outstanding lecture.
Professor Kokinos, Dennis, thank you for those comments. And I was at a meeting in Toronto 4 or 5 years ago, and Milton Packer, it was primary care physicians, and he said, how many people in this room read the guidelines? And not many hands went up. Guideline documents are tedious and laborious, and I think the point that you made, so for example, sacubitril valsartan, how many actually know that it reduces mitral regurgitation, it can improve ejection fraction? Those are the messages that we need to communicate, not just a blanket sterile statement. You need to use this drug. So thank you for your insights. That was very helpful. Thank you.
Thank you. We're now going to move to the next session. Dr. Gathangelu.
It gives me a profound honor indeed to introduce our next honorary keynote speaker to deliver this distinguished lecture on the 2025 challenges for cardiovascular prevention, the two extremes of life, delivered by one of the biggest scholars of the contemporary cardiovascular medicine. Will be delivered by Professor Valentine Fuster, the president of Mount Sinai Fuster Heart Hospital and physician-in-chief of the Mount Sinai Hospital in New York. Professor Fuster is the general director of the National Center for Cardiovascular Research in Madrid, Spain. The innumerable positions he has held include those of President of the American Heart Association, President of the World Heart Federation, member of the U.S. National Academy of Medicine, where he chaired the committee for the document on promotion of cardiovascular health worldwide and presently co-chairs the advisory committee on the role of the United States on global health as advisor to the President, member of the European Horizon 2020 Scientific Panel of Health, Council member of the U.S. National Heart, Lung and Blood Institute, and President of the Training Program of the American College of Cardiology. He was named editor-in-chief of the journal Nature Reviews in Cardiology, and more recently, for 10 years until last year, he has been editor-in-chief of the Journal of the American College of Cardiology, the ACC's flagship publication and a main American source of clinical information on cardiovascular medicine. Dr. Fuster's research is in parallel in areas relating to the causes, prevention, and treatment of cardiovascular disease globally, and spans the full range of the hardcore basic science and molecular biology through clinical studies and large-scale multinational trials to population sciences and global medicine. His scientific contribution worldwide, has summarized by his age index, is 218, Google Scholar. He's 35 worldwide honoris causa and the most highly cited Spanish research scientist of all times, Google Scholar. Among his many achievements, it is noteworthy that Professor Fuster is the only cardiologist to have received the highest awards for research from the 4 leading cardiovascular organizations: the American Heart Association Gold Medal and Research Achievement Award, and the American College of Cardiology Living Legend and Life Achievement Award, the European Society of Cardiology Gold Medal, and the Inter-American Society of Cardiology Research Achievement Award. And most recently, Espan Cypriot Medical Association European University School of Medicine has awarded our leader appreciation for his lifelong achievement. In addition, in May 2013, King Juan Carlos I of Spain granted Professor Fuster with the title of Marquis for his outstanding and unceasing research efforts and his educational outreach work. In 2022, the American College of Cardiology instituted the Valentine Fuster Award in Science and Innovation for the next 15 years. Finally, in 2023, Mount Sinai renamed Mount Sinai Heart as Mount Sinai Fuster Heart Hospital in his honor. Professor Fuster, it's a great honor.
Well, thank you very much. You took so much time of my talk.
You deserve it.
Very kind. Thank you very much to all of you for being here today, and certainly it's an honor for many reasons, which I will discuss later. What to talk about? About the next 10 years, as I predict them. And it was about 15 years ago that I decided to change my line of investigation from understanding cardiovascular disease to understand health. And the question was why? I thought we knew more about disease than health. And how we have to approach disease is to promote health and to prevent it. So this was a change, but not the technology. We approach health with the most modern technology available. And I will be presenting today what happened in the last 15 years, which actually is now being published or going to be published within the last 2 years and the next year. So the data we'll present today is very, very modern, very up to date. Well, look the title, Science, Health, and Education. This is the name of my foundation. 3 words that I think are critical. And the question is, can we identify healthy or subclinical disease of the heart and the brain before are clinically manifested? We approach this in 3 different ages, from birth to age 20, from age 20 to 60, and from age 60 to 100. These are the 3 ages you can see in the circles. And actually today, although I will emphasize 60 to 100 and birth to age 20, the introduction really was in the original study of age 20 to 60 that is being published at this time, the data. On the top, you have the studies that either were the driving force for the 3 H's, or are the studies that we are doing now after we have preliminary data. So why we don't do this? Let's concentrate between age 20 to 60. What is the question? The question is, I am developing the disease or not? Disease of the arteries. How can we answer it? The answer has to be globally, to the whole world. We are not answering the question for specific rich countries or rich institutions or so forth. So we decided to really get into the PESA study, and which I am going to describe. Let me just see. The PESA study originated about 15 years ago, and this was in Madrid, where we have the Center of Cardiovascular Investigation. And this study is quite interesting. It's a study that goes over 20 years, and every 3 years we approach the following. First, imaging. What kind of imaging? Imaging of the carotid arteries, 3-dimensional, and imaging of the iliofemoral arteries. In addition, we do actually CT for calcification of the coronary arteries, and more recently CT angiography. And finally, to look at the large arteries with MRI and positron emission tomography. This is actually a research program. Now, here on the right, we image from the neck down, and then we image the brain separately. And on the left, we do every 3 years phenotyping, which by artificial intelligence, more than 4,000 parameters of risk are being evaluated. And in the bottom, multiomics, transcriptomics, genetics, and so forth. So this is the study. Now I'm going to concentrate on the question, can we identify disease before it's clinically manifested? So we really focus our attention on imaging. My friends, you have to help me here. Maybe I will do it through the slide is not moving. Oh, you think so?
The top one?
No, the top is the, yeah, I understand it. No, I am pointing out it's not working. It's the era of technology.
You want to change the slides, sir, or you want to point?
No, I want to change the slides. Okay, I hope it works. You stay here. Okay. This is the technology we have developed, which is fascinating. This is 3D ultrasound of the carotid arteries and of the iliofemoral arteries. And actually, as you can see, by artificial intelligence, we identify where the disease is developing. And then with artificial intelligence, we can quantify how much disease is in volume. And this is done at the present time. And I'm going to be presenting to you the data by such technologies. We actually screened over 10,000 people. And we have 7 findings, all published within the last year or in the next year. First, the disease, interestingly, starts at age 30, subclinically. We are talking about the carotids and the iliofemoral arteries. Progresses over 6 years in 33% of people. Interestingly, we are actually looking at young people between age 20 and age 60. And if you have risk factors at age 20, 30, 40, what happens at age 60, 70? This is the cardiac study, which I will be presenting in a moment. The other question is, if we see disease in the carotid arteries, for example, at age 60, we can then look at cardiovascular events. Is this predictive of cardiovascular events? But the most important question, I think, is the fifth one. Is the disease here and here telling us if there is coronary artery disease? And we have the data. Finally, microvascular disease, we all talk about it, but I have more to say also, very important. And finally, the bone marrow. You say the bone marrow? I still remember when I started to talk about platelets 50 years ago, the cardiologist didn't know even how to spell it. It was a thing of the hematologist. I can guarantee to you that the bone marrow is going to be a big hit in the next 5 to 10 years in the cardiovascular field. I'm not going to discuss 1 and 2. I'm going to go 3, 4, 5, 6, and 7 of the PESA study. First, the cardiac study. The cardiac study, as you know, is a study of about 5,000 people that were screened at age 20 to 40. And what we did is to look at the different risk factors, LDL, blood pressure. In the abscissa is age 20 to 40. And in the ordinate are the levels, in this case, of LDL. So you measure the area, and 20 to 40 years later, you look at cardiovascular events. We did this with blood pressure and so forth. The results are very exciting because you can see in red is when the area was the largest. And these are the cardiovascular events 20 to 40 years later. Triglycerides, blood pressure. But the most interesting data to me, we just obtained it a few weeks ago, is diabetes. So here you have the area of a patient who have diabetes, the follow-up 20 to 40 years later, and this is non-diabetes in terms of cardiovascular events. This is cardiovascular disease, this is coronary artery disease, this is a stroke, and this is congestive heart failure. So what we are really saying is that risk factors at young age are a problem. But I will tell you more. A high cholesterol at age 40 has much more impact on the disease in the arterial system than at age 60 or 70. And the reason probably is because the artery that is healthy reacts more to a risk factor than an artery that is less healthy and is older. But this is very important, young people. Well, now comes, what about if I do imaging of the carotid arteries, iliofemoral arteries? Is this causing events? You have to go to an older population because events basically can only be seen in older people. This is why the cardiac study was age 20 to 40, but then we look at 20 to 40 years later. With imaging, we image 5,000 people at age 60, and we look at cardiovascular events. And here is the relationship of the area of disease in cardiovascular events, in this case was mortality, 13 years later. But the most important parameter in this case was the carotid imaging, was actually the progression of the disease over a period of 2 to 3 years. So let me summarize. What I'm saying is risk factors at young age have a significant repercussion when you look at the area over 20 years, 20 to 40 years later. But a disease in the carotid artery, in this case, has repercussions 13 years later in terms of mortality. This is the concept. This, by the way, much more significant than looking at calcification of the coronary arteries, the calcium score. This is already published. Well, now comes the key question. What this has to do with coronary artery disease? So we recently did these 500 people that we look at the carotid arteries, the iliofemoral arteries, and CT angiography. And here's the answer. Here you have in green, no coronary disease, mild, moderate, and severe coronary artery disease. And here in the abscissa, no peripheral arterial disease, nothing in the carotids or iliofemorals, carotids, femorals, in both. What that means is if you have disease by external imaging of the carotids or iliofemoral region, you can already set 80% chance that the coronary artery disease is evolving. But on the other hand, if you are here and actually you don't have disease in the peripheral circulation, the chances of having coronary artery disease that is very significant is close to zero. Let me summarize. Here you have carotid disease and iliofemoral disease and coronary artery disease are strongly correlated, as I mentioned. And particularly when both carotid and iliofemoral disease are present, are additive to the concept of coronary artery disease. The absence of carotid or iliofemoral disease by the 3D ultrasound technology that I mentioned almost rule out significant coronary artery disease. And something very important, calcium score. Calcium score under the age of 50, you may have zero. You have a 50% chance of having coronary artery disease that is developing. That is, in young people, calcium score, I don't recommend it. Calcium score is healing, but at this young age, you are developing the disease, you are not healing. And that's the reason why a low calcium score under the age of 50 might not necessarily rule out that coronary artery disease is actually developing. The third issue, as I mentioned, is the microcirculation. We did a sophisticated study in near 1,000 people with MRI, stress MRI, of the microcirculation. I just want to mention the three findings. Finding one, when there is epicardial or peripheral vascular disease, the chances of here coronary microcirculation is number 2, is actually very high. This is not clinically symptomatic at all, but the fact of the matter is they are both very correlated. The early development of coronary artery disease and subclinical disease in the microcirculation. This is critically important when I talk about the brain in a few minutes, where the microcirculation is absolutely critical. So what I'm really saying is all of our people that we see with subclinical disease of the carotid iliofemoral artery, they are already developing microvascular disease, but in the heart, this is completely asymptomatic. It's not in the brain, as you will see in a moment. So this is an aspect I try to emphasize. I don't have time, this would be a lecture in itself. I don't have time to talk about the bone marrow, but what we did positron emission tomography in all these people in the PESA study. And what we found is in a significant number, the bone marrow is activated. And this coincides with this yellow material in the iliofemoral or carotid arteries, which is the conglomeration of cholesterol and macrophages that come from the bone marrow. And this is fascinating in 3 aspects. First, in the acute coronary syndromes, what we find, and I'm sorry I don't have time to present it, in the acute coronary syndromes, we now believe that many of these syndromes are due to the fact that the substrate of cholesterol is so significant that the defense mechanism from the bone marrow is not sufficient to take care and commit suicide, apoptotic phenomenon of the monocytes. And you know what? The suicide is very active because cytokines are released, metalloproteinases with plaque rupture, and tissue factor causing thrombosis. So our new concept of the acute coronary syndromes is a lot of in a way, is a decompensation between a defense mechanism and a substrate. And the defense mechanism decides to quit. And this is a very active phenomenon that may lead to plaque rupture. This is basically the new concept that is evolving. CHIP, you all heard about CHIP. CHIP basically are mutations of the defense mechanism from the bone marrow. You know how often it is? We found that 30% of the adults have CHIP. And you know what CHIP means? Activation of the inflammatory process. So this inflammation, that actually is a defense mechanism, it betrays you because it's overwhelming and it's not necessary. This is CHIP. And we believe that many of the people who do not have risk factors for heart attacks, they may have heart attacks because they have CHIP. And this is in the near future, we will be able to measure this much more simply than today. And that is an hyperinflammatory process on a mutation of the defense mechanism of the bone marrow, causing hyperinflammation. And finally, risk factors, and this has been to me very fascinating. The metabolic syndrome, diabetes, hypertension, low HDL activates the bone marrow. So it's not all in the vasculature that we thought in the beginning. It's like the endothelium is affected by hypertension. It's much more complex. And when the bone marrow is activated, there's a hyperinflammatory effect. And now with the group at Harvard, we have a paper coming out, which is very interesting. If you exercise, the bone marrow is much more quiet. If you have a sedentary life, the bone marrow is much more active. So what we are really trying to tell you is what I found on the platelets 50 years ago. To talk to cardiologists about the bone marrow means nothing. I'm presenting to you 3 findings that are very recent that really open up our understanding that the bone marrow is extremely important in the end results of the cardiovascular system. Well, having said this, now comes the pre-cut and the REACT study. Basically, everything that I presented to you, now we have to go to the clinic. What do we do with it? Well, let me start with the pre-cut study. This is in the PESA study. What we actually found is very interesting. If you go to guidelines, in a person who didn't have cardiovascular disease, if you have an LDL of 80 to 110 or 90 to 110 is considered normal. In color is subclinical disease. So what we found is that apparently normal people, the ideal LDL is less than 70 or 60. That's number one. Let's go into diabetes. Here is the pre-diabetes. Guidelines is an alarm for diabetes. An alarm for diabetes, look the amount of subclinical disease, even before pre-diabetes when there is insulin resistance. So what I'm really presenting to you, we miss the whole game here. Things that start earlier in life, and we only act when we have in front of us something that we call diabetes, when in fact even before pre-diabetes, during insulin resistance, we already see subclinical disease. So we have to change our minds and go earlier and earlier. And this is actually what we are trying to, what we are really understanding today, working on health. Well, this is the issue. We decided to do a study called pre-cut. And in the original aspect, we had individuals between age 30 and age 49 who have an LDL more than 70 are abnormal according to subclinical disease. Let's then randomize into aggressive statins at this age and follow the usual guidelines. We fail. You know what? Young people don't like to take drugs. Statins are not part. They can take a month. Afterwards, they don't go to the pharmacy for the prescription. And this led us to something very interesting, is the use of inclisiran, which is subcutaneous injection twice a year. And this has been fascinating. As you know, you approach the RNA of the liver, and only 2 injections a year blocks completely the PCSK9. And this is an inhibition that works. And it's interesting, they didn't take statins. This is the study. This is the study. In green is inclisiran. In blue is control, treated by physicians, 2,000 individuals, 30 to 49 years. With the statins, nobody entered into the study. Now, we entered into the study 350 people in just 6 months with inclisiran. So young people are ready to move if you are doing something that is easy. Subcutaneous injection, adherence is not an issue anymore. And what we found is 59% of the individuals that we are just tested, they already have subclinical disease. Well, the last meeting in Madrid, you know, the European Society meeting, we offered this technology to 500 physicians. I will tell you, we are not doing well. I cannot present to you the data, but there's a lot of disease. So today, to say that physicians we are treating ourselves better than the general population, according to what we see by this imaging technology. This is not correct. So we have to pay attention to ourselves too. Well, this is the pre-CAT study. It's very exciting, and what we try to do is to see if we prevent progression of the disease by the use of inclisiran in individuals with an LDL more than 70, and our goal is less than 50, compared with the controls. Well, this led to the REACT study between Denmark and our center in Madrid. It's the same study, but instead of 2,000 people, it's 16,000. We already started, and actually the main objective is to develop vascular ultrasound with artificial intelligence assisted, as I mentioned, and to really get more data than just with the 2,000 that I mentioned in the pre-CAT study. And then we will develop clinical trials appropriately when we have the whole data. So, interestingly, by the August, we already had 7,000 people who entered into the study. What I'm really presenting to you, to me, is the future. What we are going to be doing is we'll ask the risk factor profile as usual, and at the same time, we'll put the device here or in the iliofemoral, and we will know who is at risk. Why? Because we see in all the studies we have done that the most important risk for cardiovascular disease in the arterial system is to see the disease, much higher than any of the risk factors that we can mention. So I think this is the future. And we are now in developing countries, which is very simple. We use the device. We don't take blood because it's too expensive. But we use the other risk factors, and more or less obesity, hypertension dilutes the aspect, and we don't measure diabetes or glucose and cholesterol, but we can do in half an hour, really very cheap. This technology is very economic. We can do what we really do want, is to know the risk factor profile. This was not actually my talk. This is just the introduction of my talk, which is the elderly and the young people. And now I'm getting into age 60 to age 100. Big problem. Do I have disease? This is not the issue. How my brain is working is the issue. Cognitive function, Alzheimer's disease. So what we did is we used all the technology I mentioned to you and more to address the brain in people between age 60 and 100. And actually it's interesting, if you read Alzheimer's, he wrote about 125 years ago, my disease is a disease of the arteries. It's not fascinating? Today everybody is working on the cell because cognitive function means your neurons are not working. This is a very complex disease, but I can tell you from the very beginning what I'm going to show you is that the risk factors that affect the heart make the Alzheimer's disease to be more progressive and to move faster. This is what I'm going to show you. First of all, in the last 3 or 4 years, lots of studies are showing something that I think is quite important, and everybody's in agreement. The same risk factors that affect the heart affect the brain. We are talking about 8 risk factors. 2 mechanical, obesity and high blood pressure. 2 chemical, diabetes and cholesterol. 3 behavioral, smoking, lack of exercise, and eating poorly. And now sleep, poor sleep, is being added. From the 8 risk factors, the 3 that are critically important in the brain, and we'll show you the data, is diabetes, hypertension not treated, and high cholesterol. That's what it is. Anyway, this is very important. Now we go into the 3 aspects of the brain that I'm going to be discussing. First of all, we are talking about dementia, or even Alzheimer's disease. And what we are finding, and this is actually, if people are in agreement, there are 3 main factors that we have to take into account. The first is education as a child. Who is educated, who is not, young people. The risk factors I mentioned, most importantly, as I mentioned, cholesterol, diabetes, and high blood pressure. There are many others. And interestingly, here, personal isolation from society is social. It's very important to socialize. and also to be, in a way, to be motivated to do exercise and mentally. This is actually what is evolving in dementia, the factors that are beginning to be very, very important. But in the middle, I emphasize the cardiovascular risk factors that may affect the brain. Well, we began the study about 4 years ago. This was published in The Lancet, the 370 people that we follow for 6 years. And these people were already developing, they had 2 of the 3 risk factors, either hypertension, high cholesterol, or diabetes, not well treated. If they had 2 of the risk factors, these are the findings. Glucose uptake at baseline 6 years later. And this coincides with a decrease in flow with MRI from the brain. Why decrease in flow? We believe is the microvasculature, not the large arteries of the cycle of Willis. So it's not atherosclerotic disease, it's intimal thickening. When we talk about carotid intimal thickening, we don't pay attention anymore. In our 3D studies, we don't mean anything. In the microvascular of the brain probably is important. This is what we found. And interestingly, we found that the same regions in which glucose is decreased under the risk factors I mentioned is exactly the same regions that Alzheimer's disease develops. And this is critically important. Other investigators are finding the same thing. So we are getting a feeling that the risk factors that affect the heart can affect the brain with cognitive dysfunction, senile dysfunction, but also accelerating of Alzheimer's disease, which is much more complex, with deposition of a number of amyloid B, etc., in the brain cells. The study I just presented that was published recently had a problem. We did MRI in one person, we did PET in another person, and then we pulled the concept together, but was not a prospective study that all the technologies were using in the same individual. This led us in 2022 to develop the PESA brain study. 1,000 people, then we use all the technologies I mentioned, the same individuals every 3 years. And we look at cognitive function, and we look at biomarkers in blood that we are now identifying, like troponins in the heart. They are biomarkers now of minor injury of the brain. So what I'm really emphasizing to you is that we have a problem, and that is the conventional risk factors that we have so much trouble in taking care of for the heart are affecting the brain from very young age. Well, actually, we believe that the problem is in the microvasculature with the risk factors I mentioned. We are emphasizing this. We are emphasizing the biomarkers that circulate in blood. And we are emphasizing something I don't have the time to present today, that is blood clotting. Beta amyloid is prothrombotic. And we have now data in animals and in humans that is microthrombosis of the microcirculation in patients who are developing cognitive dysfunction of the Alzheimer's disease. And we are now in the process of developing a trial on anticoagulation, but I don't have time to go into the details. The news are not so bad, and it's never late. 3 studies are critical that just published in the last 3 months. This is the first one. In the United States, in 5 centers, 2,000 people at risk of cognitive decline and dementia, they were randomized. One group very aggressively treated the risk factors I mentioned and getting them out of isolation and motivating them for exercise and mentally. And the other group served as controls. The results were very interesting. Greater benefit of global cognition with the structural intervention that I'm mentioning. I don't present the data in detail. This was just published. The second piece of information was actually, is this one, which is very similar than the one I just mentioned, also with a large number of individuals. And I will say to you, the results are very similar. And in this case, not only cognitive function was decreased, but also the progression of Alzheimer's, just published 6 months ago. And the most fascinating one is the Chinese study published in Nature Medicine just 2 months ago on people who were resistant to hypertension, which is the next session, I believe, is going to try this aspect. This was uncontrolled hypertension in rural China. And actually, the people were actually divided into two groups, randomized, a very aggressive treatment of blood pressure. They dropped 22 millimeters of mercury versus control. All-cause dementia was lower in the intervened group. What I am saying is these three studies, the average age was 55 to 65 years. What I'm saying is never late when one is dealing with cognitive dysfunction. And at least one can stop or even improve that process. And I think this is quite exciting. The second aspect of the brain is chronological versus biological age. We have been very interested on this subject we just wrote about. And I just want to say a few words because this is critically important. One may be 70 years of age chronologically, but looks like 90. And another 70 years of age and looks like 60. So what is the difference between chronological and biological age? This is a very exciting field at this time. It is beginning to be understood, and that is a number of factors which are now being investigated. Some of are the risk factors I mentioned. They lead to methylation of the cells of the body. That methylation, like the cells of the bone marrow, what happens is lead to apoptotic phenomena. Cytokines are released, and an inflammatory phenomenon takes place in the whole body. And this is the progression of the chronological age. And that is the cells are being killed spontaneously by the apoptotic phenomenon. It's a cycle. As the cells die, more cytokines are being released. And on top, the telomeres are getting shorter. I'm not getting into this. How to measure chronological age? Methylation is complex, but something is evolving with CT of the brain. That is, thinner is the cortex. Then the volume of the gray matter is decreasing, and the density of the white matter is increasing. Chronological age is advancing very rapidly. This is to CT scan of the brain. One of the organs, all the other organs are involved, but this is now evolving. And it's interesting, last week, the cover of Nature Medicine is very fascinating. And this goes to the young people who are sitting here today. So much computer-oriented. This is an individual sitting all the time in front of a computer. In the future, it will be measured the chronological age. This is the same individual as he will be in the future looking at by many of the methods, methylation, CT, and so forth. What I'm saying is we have to be very active in life. Socialization, motivation, exercise, mental problem. People say to me, why you don't retire? They ask me. I am age 82. And I said, look, I have somebody will tell me when my brain doesn't function, but I will tell you I will do something else. I will not retire. And this is the point I'm trying to make. Let's use our minds constantly because this is very important in cognitive function, as I mentioned before, and socialization. I think this picture, to me, is quite important in the cover of Nature Medicine recently. Well, there are so many treatments that are now being investigated to affect chronological age, methylation, and so forth. But there is one that is quite interesting. It seems that the methylation of the cells have a lot to do with a family called of sirtuins. Very interesting. The sirtuins may be activated, and if the sirtuins are activated, methylation is blocked. So the laboratories in many places in the world are really working now. Can we stimulate pharmacologically the sirtuins and therefore making chronological age younger or avoiding to be older? This is something that to me is quite important. Well, the final issue of age is the polypill. You know, the polypill, all the studies being done are in people over age of 65. We developed a polypill that is working. It took us almost 20 years from the scheme of developing the polypill in patients with myocardial infarction. What's happened is I was doing a study on diabetes, the FREEDOM trial, in diabetes and multivessel disease. And what happened was only 20% of the individuals were doing what they were supposed to do. We were talking of surgery versus angioplasty when I became quite depressed to find out that only 20% of the people participating in the trial were treated properly for the risk factors. And this led me to really move into adherence. And I said, let's do a polypill, 3 pills together following myocardial infarction will be easier to take than all the pills separately. And this is how the polypill started. I don't go into the details. This was a huge problem to develop. And I just have this paper published in Cardiovascular Research Nature, where I explain what we had to go through. What was interesting, this, after a lot of trouble, led to the key trial, the SECURE trial. 2,500 people post-MI, 3 pills together, aspirin, atorvastatin, and ramipril, versus separated. The results were very striking. Mortality was decreased by 31%, and all due to adherence. That is, the polypill was taken much more than the pills being separated. And we have found this in a previous study called the FOCUS trial. Well, it's interesting if you go to the WHO 2003, WHO, increasing the effectiveness of adherence may have a far greater impact on the health of the population than any improvement in specific medical treatments. And now this polypill has now entered the list of essential medications in medicines in 2023. It has been approved in 20 countries in Europe. We're now in Latin America, and I'm dealing with the FDA. That is not easy to see if they can be approved and go worldwide. But perhaps this paper that was just published is of interest. I took my name out of the paper. And the reason was because there were a lot for primary prevention, and I am not sure that we might give a polypill to people who walk in the street and giving antihypertensives and so forth. So I am a firm believer of secondary prevention, or perhaps people at high risk. But the paper is of interest. What they found is in blue as post-myocardial infarction or post-stroke. This is high-risk people, and this is the whole population. And what they found is if you use targeted population, for example, population that is at high risk or for secondary prevention, we're talking about millions of dollars being, that you will prevent to be spent, and millions of lives that will be saved. So the concept of the polypill, if it moves forward, is very exciting in terms of particularly, I believe in secondary prevention, perhaps in high-risk people. All these studies are done in people over age of 65. Well, I try to emphasize what goes on in the brain based on what we learned in the PESA study. It's extreme of life that we have to take care since young age with the risk factors, with socialization, with motivation, and so forth. But let us to one issue, education. And I reached the stage personally that if we don't educate, everything I talk about is an academic, exciting, but don't going anywhere. This is my feeling. So we began to approach young people. This is the Lancet Commission on Adolescents, recently published. Adolescents are the future leaders of our world. We must ensure their health and well-being to secure a more just society in a healthier and more productive planet. So let's focus. I talk about the disease starts at young age. Here we go beyond that. It's education at a young age, even much younger. Well, in this issue of Lancet, they have this figure, which is interesting. They point out that the best results in health are obtained under the age of 20. The question is, I don't know where this figure came from, because there are no reference. It's like a concept. Well, I'm going to present to you our data. We are working now with 50,000 children around the world, and I'm going to present to you interesting data that actually fits with this figure. I'm sorry, this is my brother. And you say, why in the world you present somebody of your family? Well, he, I said, he is one of the people in the world who knows more about the frontal lobe. He's in UCLA in Los Angeles. And he developed the concept that when you teach young people anything, it sticks in the brain and comes out when you are an adult. Think about yourselves, who you are today, and you will see that the environment that you live in the first 10, 15 years of your life have a lot to do. How you are today, your family, the environment, the school system, the friends, and so forth. Why? This is in the bottom of the slide, or in the top of the slide. It's because the number of centers in the brain at a young age is much less, is much more reduced than the centers of the brain later in life, which is many and highly dense. So in an adult, you say something from one ear, goes off to the other ear, is not retained. That's the difference, is the number of centers that are available. With this in mind, we decided to take 4 randomized projects in over 7,000 children. And actually, a group of children very aggressively, with aggressive instruction, how the body works, healthy food habits, physical activity, and how to control the emotions. And that is to prepare them when in the future they are confronted with alcohol, drugs, and so forth. It's a self-esteem. We tell them they will be above the guy who presents to you the drug. This is, the young age is very, very important. This is one group. All the studies are randomized, and then the other groups are controlled. This is in the school system, and these are the 4 studies, and I finished. I was given 45 minutes. I have 2 minutes left. The first study was in Bogota and in Harlem, New York, 2 different socioeconomic areas. Number of children, 1,700, 3 to 5 years of age. One group intervened, the other group served as control. The results in terms of knowledge, attitude, and habits 2, 3 years later were extraordinary in Bogota and also Harlem, New York. But the problem is obesity. At 3 to 5 years of age, you cannot measure anything that is tangible, that has to do with your health. Well, here is what was published just a few weeks ago from the UNICEF, and that this is nothing worse today than obesity. And this is related to the unhealthy food environment. I don't have to go into this right now, but we measure it. And this is the second project. The children were older, and actually most of the children had between age 8 to 10. The study was done in Madrid. And we did exactly, we were randomizing the way I presented to you. But here we were able to measure obesity, fat, by all the modern technologies. This is BMI control group, intervene group. 3 years later, this is the circle of your belt. Sorry for that, my English is... And then this is another way to measure the height and the weight and so forth, the difference. The results were extraordinary. This is the first study I know that instruction aggressively, this is 6 months, 60 hours, that's the, can have an impact on something that is tangible, that is fat deposition in children 3 years after the intervention being done. And this is the third project. And the third project is bad news. When the group in Bogota that we did 7 years before, we look at age 10, 12, it's like they forgot everything. And you say, well, this is a disaster. Then what we did is we re-intervened this group versus single intervention, and we found exponential. That is, everybody forgets anything we do, adults and young. But if you re-intervene, the results are exponential in terms of behavior, health, and so forth. So adherence is important, and sustainability is important. And this led finally to the environment. Why the environment? What we found in the school system is the control groups did reasonably well. You know why? They are in an environment of health. And even if you are a control, you take care of yourself and your family much better when you go home. So we move into the environment, and we call the family project. This project has been the highest success we had. We go to the family, parents, children, and grandchildren, and we present the 4 aspects I presented to you before, but in this different degree of maturity, depending on the age. The results have been outstanding. And that this is 1-year project in which is in 3 parts. The 4 aspects are done in 3 different parts in terms of progression. And this led us to PWR, the patients' waiting rooms in 3 countries in South America. We went to the waiting rooms where the patients are there while waiting to the doctor. We present a video, do you want to participate as a family? And those who participated, exactly the same fantastic results. So this led to the following. We have learned adherence of the children to the project is critical. The environment is critical, and the sustainability with reintervention is critical. But we know sustainability until age 14. We don't know how many times you have to reintervene. This is why I have a big question mark. Although we believe in the original concept I presented, whatever happens at that age will come up later on. This has led the American College of Cardiology to develop a huge program, which is primordial prevention. It's going to start in this coming year. I will be the one running it, and that is to really educate cardiologists and physicians of how they can have an impact in the communities and in the areas where they practice. And this is actually 225 to 235. It was going to be a 10-year project. And basically, what I'm trying to say to you is what is in this statement of the Lancet Commission, a very important statement. The investment made in this generation of children and adolescents, in this case is education, will determine human and planetary futures, for good or for ill. What I'm really saying, and I am absolutely convinced, that if we don't go into children, we are not going to win. And if you tell me about the future of society, yes, not just in terms of health, but in terms, is the young people really who's going to run it? And the question is how these people are educated, but this is the future. So I finish by saying to you that I presented the last study, Science, Health, and Education, the one in children. I presented to you 5 studies that are really in 3 different ages, where I think the first 2, 20 to 60, 60 to 100, are more scientifically driven. How can we identify people early on before they develop disease in the heart and the brain? But the last one, which I think is the most important one, is education. So I finish in giving you the thanks for giving me this opportunity. As you can see, I am very passionate, but that's what life is about, is to be motivated. And I am very motivated to present this to you, particularly the young people who are up there, because you are the future, my friends. And this fund is very, very important that we take into account everything that starts at a young age. Thank you.
Professor Fuster, thank you for such an exciting and fascinating lecture, which was so masterly presented by you. I would like to call on stage Professor Patrikios to present the award to Professor Fuster. And I would like you to stay in the theater because we're gonna compromise the break due to the shortage of the schedule, and so we will carry on with the next chairman. So the next panel should be coming on stage, please.
Good afternoon, everyone. It's a pleasure to welcome you to this session on innovations in arterial hypertension management. Hypertension remains one of the leading global risk factors for cardiovascular disease, and advancing our understanding in the field is crucial. So we proceed to the first speaker, Dr. Miltiadous, please.
Well, I will ask adjacent Professor Dr. Andreas Pitsaras will give us a lecture, the great debate, re-evaluating the role of dietary sodium in hypertension management. New evidence, old questions. Professor?
No, it's Dr. Grasso's lecture.
Yeah, yeah. Okay. We apologize for this. We're going first with Professor Dr. Charalambos Grassos, who is give us a lecture, Beyond Blood Pressure, Addressing the Unrecognized Contribution for Endothelial Dysfunction in Treatment-Resistant Hypertension. Professor Grassos.
Dear chairmen, dear colleagues, dear students, before to start my presentation, I would like to thank my best friends, Professor Patrikios, for your kind invitation for once again as a faculty in this fantastic Congress in beautiful Cyprus. I'm going to talk about the role of a recognized contribution of endothelial dysfunction in treatment in patients with resistant hypertension. Before to start my presentation, I would like to give some definition about the role of endothelium. Endothelium plays a fundamental role in the cardiovascular system, forming an interface between blood and adjacent tissue by regulating the vascular tone through the synthesis of nitric oxide first, prostaglandins, and other relaxing factors. What others know about the endothelium? The endothelium dysfunction is characterized by vasoconstriction, cell proliferation, and shifting towards a pro-inflammatory and prothrombotic state. What about endothelium, especially in hypertensive patients? May be involved in the initiation and development of vascular inflammation, vascular remodeling, and atherosclerosis. It is independently associated with increased cardiovascular risk, as you know. Different conditions such as impaired vascular shear, stress, inflammation, and of course, oxidative stress, activation of the renin-angiotensin system that play important role in the endothelium, have been described as important pathophysiological mechanisms involved in the development of endothelium dysfunction. Some information about endothelium dysfunction. Endothelium dysfunction has reduced nitric oxide viability, leads to oxidative stress and inflammation, causing remodeling and arterial stiffness. Another important issue is the chronic sympathetic renal nervous system hyperactivity ameliorates the renin-angiotensin system cascade that inhibits nitric oxide and increase vasoconstrictions. In these slides, you can see all these factors that affecting both positively and negatively the role of endothelium, especially in hypertensive patients. And for this, it's important to know that the positive factors coming from the AC or AC2 angiotensin 1-7, laminar flow, some exosome, and of course, interaction and perivascular adipose tissue. What about renal denervation? The definition of renal denervation. The renal denervation is a percutaneous procedure that increases the endothelium AC2 expression, activates PMK enzyme, inhibits PMTOR, and promotes autophagy. With this mechanism, the vascular endothelium is protective from the sympathetic hyperactivity. renal denervation is a minimal invasive option to treat hypertension because it interrupts sympathetic neural activity between brain and kidney. As you can see, there is the efferent sympathetic signal from the CNS to the kidney, and the afferent sensory feedback coming from the kidney to the CNS modulate renal function and overall sympathetic overactivity. Here is the 3 types of radiofrequency ablation. The first type is the superficial ablation of forerenal and sympathetic nerves, multi-electrode radiofrequency ablation. The second is the radiofrequency used ultrasound-based denervation. And finally, we have the third types, alcohol-mediated perivascular renal denervation. As you can see, the renovascular treatment is delivered bilateral in a number of locations along the main and extraparenchymal renal arteries, ranging from 3 to 8 millimeters in diameter. Here you can see a radiofrequency catheter disables to the nerves, and the vascular endothelium is protective from the sympathetic overactivity. According to all the guidelines, the European Society of Hypertension guidelines in 2023, and of course the European Cardiology guidelines in 2024, patients suitable for renal denervation are adults with uncontrolled resistant hypertension. It means blood pressure systolic over or equal 140 and diastolic 19 millimeter mercury on 3 or more drugs therapy, who have but an GFR renal function over the 40 ml per minute and suitable for renal artery anatomy. As you can see, the selection of patients to whom is candidate for renal denervation is offered should be done in shared decision-making process after objective and completed patient information. Another important thing is to take this procedure only in expertise centers. What others we know about the class recommendation for the renal denervation? It may also consider in patients an increased cardiovascular risk who have uncontrolled hypertension on fewer than 3 drugs, again, contingent on patient prefer and center of expertise, as I mentioned before. Before to diagnose resistant hypertension, is necessary to verify the blood pressure is high outside of the office. We use ambulatory blood pressure monitoring 24 hours or home blood pressure measurements. After that, it's necessary to exclude secondary hypertension and, of course, to find and optimize medication regimen. And finally, we need to communicate with the patient in order to decide the therapeutic strategy in two places. The first, go to the renal denervation, or the second, to ongoing medical therapy. Important thing is the shared decision making. Patients should be fully informed about the benefits, risk, and limitation of the procedures. We need to have a multidisciplinary team, and decisions should be made in consultation with the multidisciplinary hypertension teams, including, first, hypertension specialists, a second, interventional cardiologist. What about the safety of the catheter-based renal denervation? The answer is the renal denervation is a safe procedure. According to the meta-analysis of 5,769 patients undergoing renal denervation, reported only 26 patients with renal artery stenosis or dissections with a less than 0.20% pool annual incidence rate of stent implantation in the renal artery. Almost all occur with the first year post renal denervation procedure. Another meta-analysis with a half of these patients show no significant changes in the renal function, I mean changes in the GFR after a mean follow-up of 9.1 months. What others know about the renal denervation? We know that renal denervation is effective on top of medical therapy. Patients should be continuing taking their medication after renal denervation. Renal denervation is a good technique, is intended to be additional to optimize medical therapy. Finally, this is my last slides. I would like to mention some potential future indications for renal denervation beyond hypertension, such as chronic kidney disease, chronic heart failure, atrial fibrillation, ventricular tachycardia, sleep apnea, and finally, type 2 diabetes. Thank you very much for your attention.
Professor Grassos, thank you for your excellent presentation. Because out of time, we'll proceed to the next lecture. So I will ask Professor Andreas Pitteras to give us the lecture, The Great Debate, Reevaluating the Role of Dietary Sodium in Hypertension Management, New Evidence, All Questions.
Dear Chairman, dear colleagues, ladies and gentlemen, the myth says that the English word salary was derived from the Latin salarium when Roman soldiers were paid in salt for their service. Salt was precious due to its ability to preserve food, so partly responsible for the development of our civilization. And there is a theory about the hypertension in African Americans, the slavery theory about a lot of consumption of preserved foods rich in salt and so forth. There is strong evidence for an association between high sodium consumption and increased blood pressure and mortality in the overall population and especially in hypertensive patients. And high sodium is a leading food category associated with cardiometabolic mortality, as you can see here, in both men and women. And it's between the dietary priorities we need to avoid. You can see here the high sodium foods. And 15 years ago, more than 1.5 million deaths from cardiovascular causes were attributed to sodium consumption more than 2 grams per day. And here you can see the relationship between the high salt intake and cardiovascular disease via many pathophysiological mechanisms like hypertension, heart and vessel damage, immune system and inflammation, prostanoids, genetic and epigenetic changes, gut microbiome, and sodium sensitivity and nocturnal hypertension. And starting salt creates fluid retention, increases blood volume and cardiac output, increases arterial pressure, creates nocturnal hypertension, and overstimulates renal angiotensin-aldosterone system, creates sustained hypertension and cardiovascular damage. Via heart and vessel damage, creates left ventricular hypertrophy, congestive heart failure, endothelial dysfunction, atherosclerosis, and lastly, cardiovascular events. Via immune system and inflammation, creates an inflammatory reaction, increase in IMT thickness, creates vasoconstriction, releases pro-inflammatory cells, leading to hypertension, leads to endothelial disruption, prothrombotic status, and last cardiovascular events. Via prostanoids, which are lipid mediators, has an effect on blood vessel tone, platelet function, inflammation, and hypertension. And via genetic and epigenetic changes, leads to salt-sensitive hypertension, DNA methylation, histone modifications, inflammation, endothelial dysfunction, and cardiovascular events. And going to the gut microbiome leads to dysbiosis, inflammation, hypertension, and cardiovascular events. And here you can see all the mechanisms here leading to arterial hypertension and cardiovascular events via short-chain fatty acids to increase sympathetic nervous system activity, and trimethylamine to increase the sensitivity to angiotensin II, leads to vasoconstriction, and releases in interleukin and tumor necrosis factor, as you can see here in this slide. The relation between sodium-restricted diets and improved blood pressure control has been widely recognized by randomized trials and confirmed by meta-analysis. We have greater blood pressure reductions after sodium restrictions in some special populations, like hypertensives, non-white people, older populations, diabetes, metabolic syndrome, chronic kidney disease, resistant hypertension, and maybe in postmenopausal women, and reduced number of drugs to achieve blood pressure control. A recent meta-analysis observed that restricting sodium intake to less than 5.8 grams salt per day, resulting in an average of over 2 millimeters of mercury systolic and diastolic pressure respectively in patients with hypertension. Another meta-analysis examining sodium intake reduction to as low as 800 milligrams per day showed a linear decrease in blood pressure, and in addition, an average reduction in dietary sodium intake from 3.6 grams per day to 2.7 grams per day has been found to be associated with up to 26% reduction in cardiovascular disease. As you can see here, the sodium reduction leads to the blood pressure reduction up to 6 millimeters of mercury, average of 4.3 millimeters of systolic, and 2.1 millimeters of diastolic blood pressure. And here you can see the effect of reduced sodium intake on systolic blood pressure. You can see here a linear effect. The more the reduction, the less the blood pressure. And here, looking at the upper quartile of systolic and the lower quartile of diastolic blood pressure, you can see here a clear linear reduction in systolic blood pressure there for the upper systolic blood pressure quartile, but it's not the same case for the lower diastolic blood pressure quartile. As you can see here, no much difference as previously. And here from the DASH diet, those following the typical American diet rich in salt, in comparison with DASH diet, contains almost about 2.3 grams of salt per day. You can see here a clear benefit for low sodium diet here in both systolic and diastolic blood pressure, a linear reduction for the whole period of study. And for the DAS diet, just for the first week we saw a reduction, and after that a kind of plateau. Although there is an association between salt intake and blood pressure, both in randomized controlled trials and in observational studies, the association is weak, especially in non-obese individuals with normal blood pressure. And the blood pressure in general population is likely to be weakly responsive to changes in sodium intake. And from CDC and FDA, you can see here a small benefit of 2.2 millimeters of mercury per 100 millimoles of salt reduction, as you can see here. So, what about the potential adverse effects of low salt intake? The lower is better, as the picture. There is considerable controversy about optimal sodium intake between low or moderate sodium intake. And you can see here many studies, many citations, and with blue color is the supportive data, and the other colors, the other. And from almost 270 reports, 54% were supportive and the others were not. A reduction in mortality with salt reduction has not been demonstrated in randomized clinical trials. Population studies show low sodium intake to be associated with increased mortality. As you can see here, a U-shaped association between the urinary sodium excretion and heart failure risk in middle-aged healthy population. And from another study in New England Journal of Medicine, the sodium intake between 3 and 6 grams per day were associated with lower risk of death and cardiovascular events. And you can see here a U-shape association here between 3 and 6 grams per day. The lower the the lower the worse, and the higher worse too. And here, from this study, both low and high sodium intakes are associated with increased mortality. As you can see here, no difference between high usual sodium and low usual sodium. And here, all-cause mortality, you can see here the comparison between usual sodium and high sodium. And here, usual sodium in comparison with low sodium. And from another study in Lancet, lowering sodium intake is best targeted at populations with hypertension who consume high sodium diets. As you can see here, a U-shaped form. And we have difference between hypertensives and normotensives. And of course, there is many times a genetic predisposition for salt sensitivity for particular individuals with hypertension. And after all these things, in general, we consume vastly more salt than we need. And here you can see the equivalent of grams of salt, sodium chloride, and sodium. You can see here 1 gram equivalent to 400 milligrams, 5 grams equivalent to 2,000 milligrams, and a teaspoon equivalent to 2,300 milligrams, and equivalent about to 100 millimoles. And the guidelines suggest a salt restriction to less than 5 grams, equivalent to 2 grams of sodium per day, and increase potassium consumption, with exception of chronic kidney disease, carefully, and salt substitutes, replacing with potassium chloride. And from the International Society of Hypertension and European Society of Hypertension, you can see here a suggestion to eat less than 5 grams per day, equivalent to 1 teaspoon. And the European Society of Cardiology, same suggestion, reduce table salt intake. And from recent American guidelines, they suggest less than 2.3 milligrams per day, moving towards an ideal limit of 1.5 grams per day, which is maybe impossible. And at the same time, suggest potassium-based salt substitutes to gain up to 6 to 8 millimeters of mercury reduction in blood pressure. Our culture is a culture based on the use of salt. We use a lot of salt, and unfortunately, you can see here, in every single country, they used to consume more than 2.5 and 3 grams per day, as you can see here. And in European countries, the usual consumption is between 9 and 12 grams per day. 90% of Americans take in more sodium than the recommended daily requirements. And the most of salt is hidden in processed foods, as you can see here, the 77%. And you can see the clear difference between processed and unprocessed foods in salt here. So we suggest salt with lower sodium and higher potassium with salt substitutes. And we have many studies. Here is one study. You can see the difference in strokes and all-cause mortality for those following the salt substitutes. So 9 of 10 individuals in states consume too much sodium. So even modest reductions in sodium intake are associated with some substantial health benefits. In conclusion, there is strong evidence for an association between high sodium consumption and increased blood pressure and mortality, especially in hypertensive patients. Strict sodium intake is associated with increased risk of cardiovascular disease mortality. Modest salt reduction between 3 and 6 grams per day is associated with a lower risk of death and cardiovascular events. It is questionable whether the modest systolic dose-response relation justifies the strict sodium intake in the general population, and evidence supports the use of salt substitutes in adults with pre-hypertension and hypertension. Thank you very much for your attention.
Thank you very much, Professor Pitaras. We have to proceed to the next speaker, please. It's my pleasure to introduce Professor Konstantinos Makaritsis, Professor of Internal Medicine at the University of Thessaly Medical School in Larissa. He will present on a highly relevant topic for all of us involved in patient care, emerging antihypertensive medications. Dr. Makaritsis.
Yes, good evening, everyone. I want to thank Professor Patrikios for his kind invitation to this Congress. And the title of this presentation will be the Emerging Antihypertensive Medication. Here is the list. Because of the shortage of time, I will do my best to be as quick as possible. You can see here the list. It's the ARNIs, the SGLT2 inhibitors, GLP-1 or GLP-1 and GIP receptor agonists, non-steroidal MR antagonists, endothelin receptor antagonists, aldosterone synthase inhibitors, and last but not least, the RNA therapeutic agents. Going to the RNAs, we all know the beneficial effect of inhibition of the RAS, but during the last years, with the development of RNAs, we have seen the beneficial effect of inhibiting the neprilysin system, which we know that it deactivates, actually degrades the natriuretic peptides, and in that way, it increases vasodilation, lowers blood pressure, along with increased natriuresis and diuresis. The RNAs have been tested mainly in heart failure patients, but there is a parameter study in which Entresto, sacubitril plus valsartan, was compared to olmesartan in elderly people with systolic hypertension. And from this study, we can see that there was a significant reduction until week 12 in patients taking the combination. Also in Paragon heart failure study, in patients with heart failure and preserved ejection fraction, it was also shown that Entresto was much better than valsartan in patients with resistant hypertension. And as you can see here, it was more effective for non-resistant hypertension, in apparent resistant hypertension, and also in MRA-resistant hypertension. Now going to the SGLT2 inhibitors, we know that SGLT1 is located primarily in the intestine, and SGLT2 is responsible for more than 90% of glucose reabsorption and 65% of sodium, and it's located exclusively in the proximal tubule. SGLT2 inhibitors have shown their efficacy in patients with heart failure, both with reduced and preserved ejection fraction, and they were tested also in patients with chronic kidney disease or heart failure, as I said before, and this was really beneficial irrespective of diabetes status. Here in this meta-analysis, about 4 years ago, we can see that with regard to epagliflozin and dapagliflozin, these agents were effective in reducing blood pressure, systolic blood pressure, but also 24-hour ambulatory blood pressure. In that context, these medications are recommended in patients with chronic kidney disease in order to improve outcomes. Now, moving to GLP-1 and dual GLP-1 GIP receptor agonist, like semaglutide or tirzepatide. These medications not only promote weight loss, but also substantially lower blood pressure and reduce cardiovascular events. However, there is no trial yet evaluated blood pressure as the primary outcome, which remains a limitation. In this recent meta-analysis in hypertension, with semaglutide mainly, we see that there was a modest reduction in blood pressure, and also with the combination, the tirzepatide medication, it was shown that there was a quite effective lowering of blood pressure using the combination GLP-1 GIP receptor agonists. Now moving to the non-steroidal MR receptor antagonists, mainly finerenone is the drug that has been tested mostly, and it is well known that this non-steroidal medication has the same potency to spironolactone, higher selectivity to MR compared to spironolactone, but its major advantage is that it has very low sexual side effects and lower risk of hyperkalemia. The lower incidence of sexual side effects is due to the non-significant affinity for the other receptors, like estrogen, androgen, or progesterone receptor. This drug, finerenone, has been tested in 3 major trials, Fidelio, Figaro, and Fine Arts, and it was shown that it was quite effective with regard to the hospitalization of heart failure, kidney outcomes, and also the all-cause mortality. Finerenone has not been assessed in a dedicated hypertension study, and the effect of finerenone accounting for a small proportion of the treatment effect on cardiorenal outcomes in these 3 studies I just mentioned, I mean Fidelio, Figaro, and the Fine Arts. However, there is a study on ambulatory blood pressure in patients with diabetic nephropathy, actually, and in that study, ARTS-DN, it was a phase 2b trial with about 800 patients, and it was shown that finerenone in different doses of 10, 15, or 20 milligrams of dosage had a significant effect of lowering blood pressure in those patients. In that context, finerenone is recommended by the European Society of Hypertension in patients with kidney disease or patients with diabetes mellitus. Now, moving to endothelin receptor antagonist, aprocitentan is a novel dual endothelin receptor antagonist, which has demonstrated its efficacy in long-term control in patients with resistant hypertension. However, we should keep in mind that there are some safety concerns, such as hepatotoxicity, fluid retention, and embryo-fetal toxicity. In the precision study, that's a major study with aprocitentan, it was shown that in patients with resistant hypertension, it was effective, significantly effective, in lowering blood pressure in 2 different doses of 12.5 and 25 milligrams dosage, both in day and nighttime ambulatory blood pressure. In the recent meta-analysis some months ago, with 5 randomized controlled trials, the 3 different doses of aprocitentan were quite effective in reducing blood pressure, both systolic and diastolic blood pressure. Now, with regard to the aldosterone synthase inhibitors, that they are new drugs, new medications, we know that aldosterone synthesis is in the zona glomerulosa of the adrenal gland by the enzyme called C11B2, that is also called aldosterone synthase. And selective aldosterone synthase inhibitors, such as baxdrostat and lorundrostat, directly suppress aldosterone production while sparing cortisol synthesis. They are selective inhibitors of this enzyme, so they do not have any effect on cortisol synthesis. These 2 drugs are what we call small molecule drugs, which have very low molecular weight, typically 0.1 to 0.6 kilodaltons, and because of their small size, they can penetrate the cell membrane and bind intracellular targets. Another advantage of these medications is that they are more stable than biologic drugs, and in that way they can be administered orally. There are some studies here. We have the BAX-HTN study that tested baxdrostat in different doses of 1 or 2 milligrams, and it was shown, as you can see on the left side, that there was a significant reduction in systolic blood pressure. However, there was an increased risk of high potassium levels. For lorundrostat, it was also, there was also 2 studies published this year with different doses, again 50 milligrams or up to 100 milligrams. Again, there was a significant reduction in systolic blood pressure, but the same with regard to potassium levels. And the last study with lorundrostat has been very recently published with 50 milligrams of this drug, and in patients with resistant hypertension, it was shown that there was a significant reduction in blood pressure in those patients. Again, hyperkalemia was an issue. And moving to the last part of this lecture, the RNA therapeutic agents. Here we have the short interfering RNA, siRNAs, and the antisense oligonucleotides. I have not included the miRNAs, as Professor Fuster has earlier mentioned. But we know that here we have two medications. The one is zilebesiran, that is a small interfering RNA, which is a double-stranded RNA. And the ion is an antisense nucleotide, actually both of these medications act in a way to degrade the target mRNA. Here the mRNA targeted is the angiotensinogen mRNA. Zilebesiran, there was a study about 2 years ago, and single doses of higher than 200 milligrams of zilebesiran were associated with reductions in blood pressure by 10 and 5 millimeters of mercury in systolic and diastolic blood pressure, respectively. And these changes were consistent throughout the diurnal cycle and were sustained at 24 weeks. There were 100 patients enrolled, and they had only mild transient injection site reactions. Here is the levels of angiotensinogen that there were steadily lower for about 24 weeks with one injection of this medication. And also that was the case, the reduction in blood pressure in all patients included in this study. The Cardia-1 study with K, not with C, also randomized patients with mild to moderate hypertension, and again, different doses of zilebesiran were effective in reducing blood pressure, whereas the Cardia-2 randomized trial with zilebesiran used zilebesiran as an add-on therapy in patients already taking indapamide, amlodipine, or olmesartan. And it was shown that in 24-hour ambulatory blood pressure, for 3 months, there was a significant additional reduction in these 3 groups of patients. The Cardia-3 randomized trial is testing the effect of zilebesiran in patients with either established cardiovascular disease or high cardiovascular risk, along with or without advanced chronic kidney disease. Different doses have been tested here, and the first results were reported in Madrid, in the European Society of Cardiology Congress, and there was a reduction in systolic blood pressure with 2 doses of zilebesiran, which were not statistically significant. The Ionis medication is an antisense oligonucleotide, and it also targets angiotensinogen MRA. There is a small study here, and it was shown that we had a lowering angiotensinogen levels for at least 3 months, along with reduction of systolic and diastolic blood pressure. With regard to RNA agents, they reduce significantly blood pressure, but actually they can be quite useful in the context of non-adherence because they may be administered as a single injection every few months. Thank you for your attention. I did my best.
Thank you very much for your time.
To the time.
You had a great talk. Please, dear George, close the session.
Well, thank you for these lectures, and we go on, proceed with the next presentations.
Good afternoon. It's a really honor to present the next session with my co-chair, Dr. Nikolaidis. It's a real privilege to present the next speaker. It's Dr. Michalis Efremidis, head of the Cardiac Electrophysiology Department of Onassis Heart Center in Athens. Dr. Efremidis.
Dear President, dear colleagues, I would like to thank Professor John Patrikios for his invitation to participate in this Congress. It is a pleasure to discuss this topic that defines the daily clinical practice, managing arrhythmias in patients with multimorbidities. We know that these patients are fragile patients and represent the majority of AF patients. According to the recent guidelines, the care framework defines the management of atrial fibrillation. C is the comorbidity, A is reduce stroke, R is reduce the symptoms, and T is evaluation dynamic reassessment. We know that atrial fibrillation rarely exists in isolation, usually is a part of a broader disease with many comorbidities like hypertension, heart failure, obesity, apnea, alcohol intake. During the evolution of atrial fibrillation, there are several phases. The first phase is atrial arrhythmia that increases the risk of atrial fibrillation. The second phase is the screen-detected atrial fibrillation, the preclinical atrial fibrillation. The third phase is the subclinical atrial fibrillation, the device-detected atrial fibrillation, and finally we have the clinical atrial fibrillation with the paroxysmal, persistent, and permanent form of atrial fibrillation. This evolution, we can see that this evolution is parallel with summation of many comorbidities. The more comorbidities we have, the more chance to have clinical atrial fibrillation. One emblematic study that we have in cardiology is the EAST-AFNet study that included more than 2,700 patients with many comorbidities and also atrial fibrillation detected less than 1 year. This study randomized patients in two groups. The first group followed the early rhythm control, and the second group followed the usual care of rate control and demonstrated that the early rhythm control was associated with a better outcome as compared to the rate control. The primary endpoint of this study was a composite endpoint including cardiovascular death, stroke, heart failure, hospitalization for heart failure, and also acute coronary syndromes. One group of patients with a high comorbidity burden is the group of patients with heart failure. In the sub-analysis of the EAST-AFNet study, also in this group of patients, the early rhythm control was associated with a better outcome as compared to the rate control. The question that comes up is whether the early rhythm control was associated, the benefit of the early rhythm control is isolated in one or of both groups of patients with high and low comorbidity burden. We can see that in the sub-analysis of the EAST-AFNet study, the beneficial effect of the early rhythm control is isolated only in the group of patients with a high comorbidity burden with a CHA2DS2-VASc score more than 4. Almost 10 years ago, we saw in Europace that the patients with a high comorbidity burden with a CHA2DS2-VASc score more than 3, they had low probability of sinus rhythm maintenance after AF ablation. Other iconic study that we have is the CASTLE-AF study, included patients with continuous monitoring and also with ejection fraction less than 35. And the important messages of the sub-analysis of the CASTLE-AF study were that AF recurrence did not show any relationship with the primary endpoint of this study, but the AF burden below 50%, the reduction of AF burden more than 50% after 6 months after AF ablation was associated with a significant decrease in primary composite outcome and all-cause mortality. This data upgraded the indication for AF ablation in patients with ejection fraction, with heart failure ejection fraction, and low ejection fraction in class 1 indication. And other group of patients with high comorbidity burden is the group of patients with HFpEF, heart failure with preserved ejection fraction. This Chinese study included 1,700 patients and categorized the patients in 2 groups, the group with a CHA2DS score more than 4 and the group of patients with a CHA2DS score lower of 4, and showed that only the group of patients with a low CHA2DS score benefit from the AF ablation in this group of patients. So we have different results between this study and the sub-analysis of the East AFNet study. We know that the use of SGLT2 is one of the pillars of therapy in patients with heart failure. This is an interesting study because they measure left atrial pressure just before AF ablation. And they saw that the peri-procedural use of SGLT2 was associated with a lower pressure, the left atrium, and this decrease in the left atrial pressure was associated with a better outcome in these patients after AF ablation. Also, we know that there is a relationship between sleep apnea, sleep disorder, and atrial fibrillation. Atrial fibrillation, we know that in patients with atrial fibrillation, we have a lower expression of connexin 43. And in this study, they demonstrated that in patients with sleep apnea, there is a lower expression of connexin 43 by taking biopsies from the right appendages. Other evidence of the relationship between sleep apnea and atrial fibrillation is data from the SLEEP AF study. It's a randomized study. One group followed CPAP therapy, the other group without CPAP therapy, and demonstrated that the group of patients with the CPAP therapy showed a beneficial effect in electrophysiological substrate with better velocities in atrial velocities, with lower areas of low voltage, and also low proportion of left atrium with fractionated electrograms. So in this study, we have the electrophysiological substrate in patients using CPAP therapy. Even we have strong data suggesting the pathophysiological pathway between sleep apnea and atrial fibrillation. In this randomized study failed to demonstrate that the CPAP therapy is beneficial in patients who underwent atrial fibrillation. This study published a few days ago in JAMA and included patients with a high BMI. We know that one of the detrimental comorbidities in patients with atrial fibrillation is the obesity, and randomized patients in aggressive risk factor reduction strategy, and the other group followed the usual care, and showed that only patients with the aggressive risk factor reduction showed a better outcome after AF ablation. Again, back to the care framework. The second letter is A, avoid stroke. It's well known that we have to use the CHA2DS score in order to stratify patients in high and low risk for stroke. In patients with high risk, we have to use DOAC instead of VKA. And also, it's important to manage the modifiable risk in order to reduce the bleeding. One innovative therapy that we have is the use of left atrial appendage occluder. The option study is a randomized study, included 1,600 patients, randomized patients in the LA occluder, and the other group, the usual care, followed the usual care with the anticoagulation. And the group of patients with the left atrial appendage occluder showed that there was a significant improvement in the primary safety endpoint tested for superiority, and also it was not inferior in regarding the efficacy endpoint, including stroke and systemic embolization. Finally, a group of patients with a high comorbidity burden is the group of patients with severe kidney disease. Even patients with hemodialysis, the use of a left atrial appendage occluder is associated with a reduction in the bleeding risk and also with a safe profile regarding the stroke. Finally, in conclusions, I would say that the multimorbidity is the rule, not the exception. The early rhythm control, we have to select the early rhythm control in order to stabilize the rhythm. We have to intervene in comorbidities like heart failure, sleep apnea, kidney disease, obesity. Also, we have to consider the alternative stroke prevention strategy like left atrial appendage occluder, even if in ERA guidelines the use of left atrial appendage occluder is 2B indication. And finally, we have to embrace the holistic care in order to have a better long-term results. Thank you in advance.
Thank you so much. Very thorough and interesting speech. In the interest of time, we're not going to take any questions. We're going to head on to the next speaker.
Yes. Professor Frankakis is going to talk to us about the silent storm.
Dear presidents, dear colleagues, it's a great honor to be here, and I would like to express my gratitude to my friend and my friend Yannis Patrikios for this kind invitation to be part of this very prestigious Congress. I'm going directly to my presentation, which, as you can see, sorry, may I have my slides? Okay, thank you very much. You can see in my title, like pompous expression, navigating to the silent storm. I think that probably in the next few minutes you may realize that this is not very far from the reality. And let's start from the basic, from the definition of symptomatic AF, and you can see that according to the last ESC guidelines share the same definition as symptomatic AF. That means that they both are part of a clinical AF and they both need to be confirmed with clinical ECG. Of course, it's needless to say that in my speech is not included subclinical AF, which is the AF which is detected with devices but is not confirmed with clinical ECG. In addition to the clinical ECG, there are some other tools that may provide evidence of ECG, and these are tools like smartwatches that provide ECG with 1 or 6 leads, and these are enough to put the diagnosis of atrial fibrillation, but in these devices are not included those that they are based on plethysmography. But is the incidence of asymptomatic AF is something frequent? Let's see, the actual frequency is not known in reality, but we expect to find in a percentage between 10 or 40%, and we expect to find in a higher percentage among elderly men and patients with non-paroxysmal atrial fibrillation. When we face someone with, who is considered to be as a patient with asymptomatic atrial fibrillation, there is a critical question that we have to answer. Is truly asymptomatic this patient, or he unconsciously adjusts his lifestyle to remain comfortable with the limits of his physical capabilities, which is something that very often happens among the patient. And the most effective tool to distinguish these patients, to answer to this critical question, is to proceed to electrical cardioversion, especially for those that they have a persistent atrial fibrillation. And this is something that is supported from the guidelines, and is also very critical because the strategy that we are going to follow afterwards is mainly based on whether this patient, they are really symptomatic or not. But I think that skipped one, yeah, sorry. Sorry, skipped. Could you put my presentation again, please? Sorry. Okay, thank you. But apart from the symptoms, and another very critical question that we have to answer is if symptoms really affect the prognosis of atrial fibrillation. And actually you will recognize that there are very few things that we can find in guidelines regarding those things. Going back to 2020 ESC guidelines, you will see that asymptomatic clinical AF has been independently associated with increased risks of stroke and mortality compared to symptomatic AF. This statement really comes from a few observational and observational studies and some registries. I don't know what. And in addition to this statement, before going to the 24 ESC guidelines, you can see again that ablation for AF should not be offered in patients with asymptomatic atrial fibrillation. And only this is preserved from a very small percentage of those patients. In addition to this, please see that in the recent guidelines comes for the first time the concept of stop the progression of atrial fibrillation, which is quite important. And this is valid, sorry, I don't know what's going on with my slides. And this is valid for both I was saying that for the first time in guidelines comes the concept of progression of AF. So this is the indication, a new indication for not providing rhythm control either with antiarrhythmics or with ablation. And this is, of course, keeping in your mind that there is this new concept. But going back to the guidelines again, you will see that there is very, very few things that refers to symptomatic. And this is what is really striking, is that even going to those sections that we really recognize the lack of evidence. You can see that in the last guidelines there is nothing, there are no referring anything on asymptomatic AF, and again there is nothing about what to do and what not to do in the case of asymptomatic AF. And does this matter? Really matter? Because if you see from this ERA survey, in clinical practice, rhythm control is the preferred strategy in 97% of symptomatic patients versus only 77% for asymptomatic. And ablation is performed independently of symptoms by only 15% of physicians. So it's very important to realize if there is a symptomatic or asymptomatic AF. Just trying to answer to these gaps, we published last year this meta-analysis in European Heart Journal where we addressed all these very important outcomes like all-cause mortality, cardiovascular mortality, stroke, hospitalization, myocardial infarction, new onset heart failure, and AF progression. And we see if there is a difference between asymptomatic and asymptomatic AF. There are three major outcomes from this meta-analysis. First of all, we did not find that there is any difference in prognosis between symptomatic and asymptomatic AF as this statement that I showed you before in 2020 guidelines. The second important issue is that symptomatic AF patients seems to have more chances to receive therapy and treatment like antiarrhythmic or ablation compared to symptomatic. And the third important issue is that a symptomatic patient is more likely to progress, it is more likely for AF to progress to persistent or permanent AF. And as Dr. Efremidis showed before, in this East AFNet trial, the early rhythm control is very important because it reduced this composite outcome of hospitalization, of cardiac death, stroke, heart failure, and this was proved in both asymptomatic and symptomatic patients. In addition to that, you can see, and from this study, the ATTEST study, that the most effective tool to hold the progression of AF to persistent AF is ablation, and you can see that a patient with RF ablation is 10 times less likely to develop persistent AF. Taking all these things into account, I think that this consideration that in asymptomatic AF patients should offer ablation in only a small percentage of this patient should be reconsidered, and actually we should really rethink about this approach. Is needless to say that we definitely need a randomized trial to support this concept, but I think that we should be more aggressive to this population, which we expect to be exponentially increased by using smartwatches and other tools now in recent years. And with this slide, I would like to thank you again for your attention.
Thank you very much, Professor Frangakis, for the excellent presentation. As we said, due to lack of time, we're not going to have any questions. And we're going to ask to the stand Dr. Andrigopoulos, who is going to enlighten us about pacing strategies for heart failure.
Thank you very much, and thank you very much, Yannis. We finally have to change that photo in the program. It's misleading, and it's already 13 years old. Okay. So I'm going to talk about a topic that possibly is not the major interest of most of you, and I will try to make it totally subjective. I was told to give my opinion about two ways of resynchronization of the heart: biventricular pacing and conduction system pacing. So this is my disclosure information, and this is the first patient that underwent a pacemaker implantation procedure. He was 43 and outlived its inventor, the surgeon, and 26 pacemakers that he had to use throughout his life. So the good thing with pacemakers is that they keep patients alive. Because if you are 40 and you have atrioventricular block, you have to have a lead in your heart. The topic today of my presentation is where to put the lead, because you have to avoid deteriorating systolic function of the heart, or if the patient suffers from heart failure, you have to improve function of the heart. The problem with pacing, because initially we started for decades to pace the heart from the right ventricle, because it's handy. You go from the vein and you are inside the heart. It's what you see. Students that are up there, which possibly is the most important part of our audience, because as Professor Fuster said, you are the future, so you do know that this is not the right way that heart works. The heart does not work like shifting this way. It should work like that, homogeneously. This is synchronized movement of the myocardial walls. This is desynchrony. And for the rest of the presentation, I'm going to use the term CRT, cardiac resynchronization therapy, which is our effort to restore normal function of the heart. And if you go to the ECG, the easy way to find a patient with desynchronized heart is to find a patient with left branch block. This is the left part of the ECG. And if you manage to make the heart depolarize from the left part, not from the right heart, then you have initial R wave in V1 and other leftwards leads. You have negative deflection in leftward leads because you want to make the heart depolarize from left to right, at least from left to right, because normal contraction and normal depolarization is much more complex than this. And this is the first patient where we tried in Evangelismos Hospital to correct what happens with heart failure and pacing from the right ventricle. And we were very lucky. We were almost ignorant. You know, by 23, 24 years ago, there was no TikTok. There was a little bit of YouTube, because today you can practice new technologies through TikTok of YouTube. We were almost ignorant, but we were very lucky. This is what you see is coronary sinus. It's a vein that comes on top of the heart. So if you manage to cannulate coronary sinus, you can put a lead on top of the left ventricle. So left ventricle can be depolarized first, and you are likely to restore the synchrony of the heart, which is what happened in this case, because this branch was ideally put it there, and we managed, although ignorant, to put the lead in the right position. And we're also lucky enough to see that our patient significantly improved only a few years later. You can see it's the same patient, the same heart. The magnificent is not the improved left ventricular ejection fraction. But the beauty of this is that the heart changed its shape only a few days after cardiac resynchronization therapy. So the improvement of the patient is sustained and lasts for decades. I have patients that have been implanted CRT systems that I follow them for 20 years, and they are still doing well. One of the few problems is that as electrophysiologists don't have the time and don't understand echocardiogram that much, so we used to undervalue the fact that this is a complex therapy that needs to be optimized through the echocardiography, and we tend to neglect that. We focus on ECG because this is what we know better. Anyway, let's forget about that. The other bad thing with this effort, trying to correct the synchrony through biventricular pacing, is that we have many uncommon coronary sinus anatomy and occluded veins. And, you know, in our job, uncommon may be common. So quite sometimes it was used to be 20 to 30%, now it's 5 to 10%. We are not able to provide, that's an easy way to do that, but we never managed to improve systolic function through positioning the lead in the right side of the septum. So it didn't seem to work. About 20 years ago, we firstly used the word physiological pacing. You are going to hear more about it in the next decade, because now physiological pacing, the so-called physiological pacing, is the target. And thanks to Professor Manolis, my director then, we had a series of patients that we tried to pace in the Bachman area of the of the right atrium and in his battle there. And you see, we managed to produce marvelous ECGs, very good clinical results, but at the follow-up, some of these patients lost capsule, lost pacing ability, because they developed, some of them, infrahysian, below the his, problems of atrioventricular conduction. So this is not a very stable pacing. That is why it was almost abandoned. Let's forget about pathophysiology a little bit, and let's go to the comparator. The first part was biventricular pacing to restore normal contraction. Now, we couldn't do that all the time. It is a little bit complex and costly. We need to find another way. So we try to think, why don't pace directly the left branch? The left branch is moving subendocardially in the left part of intraventricular septum. So we have to penetrate the intraventricular septum and go close to the left branch in order to pace it. It's simpler. It's much simpler than appropriate and biventricular pacing through coronary sinus. You have the ECG to guide you. If you see, the important lead is V1. It's a unipolar lead that faces heart from the right side. So you need a terminal R wave in V1 in order to have evidence that you pace from the left side of an intraventricular septum and the terminal S wave in V6. But the good news is that even if you don't go exactly onto the left branch and you pace the area around the left branch, then you have also good results. So let me show you why the left bundle pacing area is very useful, at least for some patients. This is a patient that we managed about 1 week ago. You see the patient was deteriorating rapidly. He started during the last 6 months to enter the so-called cardionephric syndrome. He was presented with deterioration of heart function, deterioration of renal function. During the last year, he came to our hospital every now and then because he had started to present increasing rate of pacing from the right ventricle, and these patients, when they present pacemaker-reduced desynchrony, they get worse and worse rapidly, but the subclavian vein was totally occluded, so we couldn't go from the right side. I had changed the RV lead, which had been implanted in another hospital almost 20 years ago and stopped to work 10 years ago. So 10 years ago, I implanted this lead. Now we had to do something because the patient is an old patient who is getting worse and worse. So we went from the from the left side, and we implanted this lead. It's the simplest thing to do, because if you need to provide biventricular pacing from the other side, you should implant at least 2 leads, plus an atrial lead if the patient is in sinus rhythm, which means 3 more leads. And implanting only 1 small lead, because these leads are small and lumiless, then you may have the chance to have a minimal procedure with a maximal effect on the patient. So this is the result. I like this picture because you see the 3 more important positions of electrodes when you want to pace: the RV apex electrode, the RV septum electrode, and the LBB area pacing electrode. The results were very good, and the patient felt very much improved even from the next day, possibly because his QRS, his pace QRS was 160 milliseconds. The pace QRS from the left branch area is about 100 milliseconds. It's a very good thing, but this is the LBBB pacing story, but there is a bad side in every good story in invasive cardiology. And these are some of the problems with LBB pacing. When you penetrate intraventricular septum, where there are many branches of coronary branches from LAD that goes inside the septum, you may hit one of these branches. I don't like the fact that I have no control in possible complications when I do that, because you just screw the lead inside the septum, and there is always the possibility to create a huge hematoma the next day or a permanent perforation in intraventricular septum. So it's not an entirely innocent story. But the worst thing is that you cannot control the complications, at least these complications, with this method. Although it's faster, it's very easy for an experienced implanter, but still there are uncontrolled complications that may occur. Not to mention that they have suggested that the combination of biventricular pacing and left branch pacing is the best situation for our patients, but it's too complicated. I don't think that in the near future we're going to provide the LOT CRT. LOT CRT is that both of these modalities, in order to improve the function of the heart. I'm going to finish within time, hopefully, saying that the guidelines are, for the time being, very conservative. I totally agree with them. For the time being, biventricular pacing is the best method to restore the synchrony of the heart, because we have long-lasting data for decades, not for years. LBBB pacing is very promising. Possibly it will be a part of our clinical practice which will grow in the next years, but meanwhile, there is no winner, but it's good news for our patients in the future, because now we have one more reliable way to improve function, or at least not to deteriorate the function of the heart. Thank you very much for your attention.
Thank you so much. We're now going to head on to the next speaker, Professor Vasilis Vasilikos from Aristotle University of Thessaloniki, who is going to talk about the role of wearable technology in arrhythmia detection. Professor Vasilikos.
Dear Presidents, dear ladies and gentlemen, thank you very much. Dear Yannis, thank you very much for the invitation. I would consider myself very lucky and you very unlucky because I'm the last speaker. So can I see quite a lot of young people there. What kind of watch do you have? Do you have a smartwatch? So, George, I know you have a very good smartwatch. Why don't you vote? So, when everybody, now this kind of technology is in everyday's practice, but are we mature enough as doctors, or the patients are mature enough to use this kind of technology? So, my declarations of finish are this, and I have to say that I prepared this presentation. So I won't go into arrhythmias. You know that it's a very important topic. And wearable technology is very widely used. When I was an intern, I remember the patient sometimes had to buy a very expensive wrist thing, that could monitor their heart rates. In the old ages, Professor Kokinos, if you remember. But now we have smartwatches, we have patches, we have rings for those who like to be engaged or whatever. We have glasses. Of course, we have ILRs, but we have lots of new technology coming up. And for the users, both patients and doctors, you have to remember that there are two different kinds of sensors. One is based on the plethysmography and the other one on electricity. You have to know that because you have to expect different things from the smartwatch you're using. Of course, in modern technology, we have other sensors. We started to work now with the voice. And also there are some very interesting data watching your face. And there are, very, very important features that somebody may understand that you're going to have atrial fibrillation or not. But are these wearables accurate? And of course, everybody's talking these days about AI, but do we trust AI? To start with, I would say this is a very nice study which shows that these are reliable. These watches are reliable. And this study is done in different color patients, because you may think that if you are Caucasian, the watch may be very good, but if you are black, it may be inaccurate. And also, during exercise, we want to know what your heart rate is doing during exercise, but are these watches reliable enough? And from this paper, it was shown that in general, the skin tone doesn't make any difference, so everybody can use this. But during exercise, during rest, it's very accurate. But during exercise, you see that it's not accurate. I don't want to be an Apple pro, but the Apple Watch show to have the best correlation between the rest rate and during exercise. Already there are 3 big studies using these smartwatches for the detection of atrial fibrillation in the general population, and these are very accurate in detecting atrial fibrillation. But what does it mean? Also, AI, you know better than me, I'm not an AI person, but I like to talk about it. You have from one side the algorithm, which has been developed by engineers, but the algorithm needs very good quality data to work. And the critic is how appropriate is this algorithm when you use it. For example, we developed this algorithm in Greece, and we want to use it in Australia or in a different kind of population. Does it work? We have a collaboration with the New York University, and we had developed a similar algorithm for predicting the atrial fibrillation from the ECG. So we thought it's a good idea to exchange our data. So we exchanged our data, and nobody's algorithm worked well. And then it was not a technical problem, but it was the selection of the patients we used. Also, always you have a result from AI, but what does it mean? And we as humans, until now, we want to explain that and not letting the black box of AI to explain this. And again, sometimes the data we are using are biased. For example, if you use data from the faces from a very poor neighborhood to predict who is a drug dealer, you understand that when the algorithm you're going to create is going to be very, very, it's going to have discrimination. So you have to think all about this. What about clinical validation, and what about regulatory issues? In Europe, we have better regulatory policies, but this is good and bad. It's good because our data are protected better than the States, but it takes a long of time to understand and to go. The technology is very fast, so at the end of the day, we create another problem. Also, there is a lack of standardized protocols for validating this data. There are variations among countries, and again, technology is running faster than our legal department or our way of understanding things. Of course, data ownership. Who owns the data? The patient, the institution, the country. Privacy laws are different across the world, and also AI and medical decision. If AI gives you an indication that this patient is going to have sudden cardiac death, for example, with a high percentage, what are you going to do? And again, cyber security. Now, this is a practical point. You have somebody who you ask, why don't you go and buy a wristwatch? And at 3 o'clock in the morning, after he had heavy drinking, he thought unwell, and he transmitted that to you. So, can you think? For example, you have just one piece of an ECG. There is a delay. I'm sleeping at 3 o'clock in the morning, and I want to see more data. And also, I don't have any other information as a physician. Also, again, there is the privacy and information, the security problem. But again, I'm going to ask the patient to do something, and the patient may or may not be proactive enough to send me more data, for example. And at the end of the day, who is responsible if this patient has something bad or not. Also, patients who use this kind of technology, we realize that they have a different kind of, some of them, not all of them, have a specific type of personality. And this very nice paper coming from North Carolina, from Lindsay Rosman, they looked retrospectively in patients who were wearing wearables or not, and the wearable users reported higher rates of symptom monitoring and preoccupation. They went into a vicious circle, if you like. And of course, you can read this with two different ways. They used more and more the healthcare, whatever the healthcare can offer them, because they were very anxious or because they realized that they have atrial fibrillation and they had more treatment. That's, we need to discuss that. But also, the wearable users were more likely to use informal health care resources, which is, you know, the information pollution. So it makes things a little bit more complicated. So at the end, you know, as citizens, we need to be quite literate with the new technology, and in our department, we understood that, and we train our patients to use this modern technology in order to participate in our daily practice. And summarizing, of course, we have the techniques here, we have the toys to play, but the consumers and the patients need to be, to know what they're talking about. Also, there are differences in countries. And of course, this kind of technology may increase their anxiety levels. What about the devices? They may be false positive or false negative. I would stay here that we're producing lots of data. Who is going to analyze them? Who is going to take the decisions? And luckily, not in our country, but as far as I know, in the US, they have been burned because they have to fill in and fill in and fill in and analyze more data. And of course, who is going to reimburse that? This is an extra job for you. And what about security again? At the end of the day, ladies and gentlemen, I am a technology pro. I like the modern technology. But still, when we use something, we have to know why we're using that. And we have to know the limitations in order to integrate that into clinical practice. And it's our job to train our fellows, our fellow doctors, and our patients, and the scientific community, because we have here a big opportunity to have a better practice of medicine. Thank you very much, and I just want to, we in IRA and ISNE, we have developed, we have this, we can scan this. This is a survey among physicians, how they understand, how they use AI in their clinical practice. The Hellenic Cardiac Society also supported that, so if you want to scan this, it takes not more than 10 minutes to fill the form. Thank you very much.
Thank you, Professor Vasilikos. As expected, excellent presentation. And we would like now to finish this session. Thank you very much for attending.
Ladies and gentlemen, we would like to proceed with the Scientific Poster Presentation Awards, which will be presented by Professor Kyriakos Kypreos, who is the chair of the judging committee.
So I think now we reached the best part of this conference, which is the announcement of the awards for the posters. To say that it was another year of hard decisions because we had too many good works to decide from. As a matter of fact, at first we thought that we should not have a first, second, and third. We should have 3 winners, but it is customary to choose the first, the second, and the third, and this is going to happen again this year. So I would like to move straight forward to the announcement of the winners. And the first prize will go to generation of alpha thalassemia Hader cells line model for gene therapy development using CRISPR-Cas9. With the first author is C. Constantinou. So you will receive your award at the front desk outside, at the registration desk. But please come join me. Please come join me. So congratulations. Congratulations. The second prize will go to angiogenesis-related genes predict outcomes and immune traits in skin melanoma. First author, Lazeraza Vladova. So please come up to the stage. Congratulations. Congratulations. You will receive your award. And the third prize goes to aortic surgery in post-transplantation patients. First author, Yorios Theodorous Kountis. So please come join us. Congratulations. Congratulations. Very nice. So on behalf of the rest of the members of the committee, Professor Gravanis and Professor Gainer, I would like to congratulate all participants because, as I said, all posters were fantastic. And I want you to keep up the good work. Congratulations to everybody.
Good evening. Dr. Christoforos Hadjikyprianou, CEO and President of the Council of European University Cyprus, Dr. Petros Agathangelu, President of the Cyprus Medical Association, distinguished guests, ladies and gentlemen, dear students. We would like to ask you to please remain seated for the School of Medicine processional. Is now entering with Dr. Christina Kousparou, Professor Anastasis Stefanou, Dr. George Georgiou, and Dr. Stegios Kagoulis, Chair of Clinical Training Committee. The Senate is now entering the ceremony arena with Professor Loizos Simeou, Vice Rector of Academic Affairs, Professor Panos Papagiorgis, Vice Rector of Research and External Affairs, Professor Apostolos Zaravinos, Dean of the School of Sciences, and Dr. Georgia Petroudi, Dean of the School of Humanities, Social and Educational Sciences. Also following are the members of the Senate, Professor Elizabeth Johnson, Dean of the School of Medicine, Professor Ioannis Patrikios, Deputy Dean of the School of Medicine, Professor Valentin Fuster, President of Mount Sinai Fuster Heart Hospital, and Professor Andreas Evstathiou, Rector of European University Cyprus. Please be seated. Thank you. Distinguished guests, members of the Senate, faculty, ladies and gentlemen, dear students. Welcome to the Doctor Honoris Causa conferment ceremony of European University Cyprus School of Medicine. We are proud to have you with us as we confer the title of Honorary Doctor Valentin Fuster. I would like to invite the Rector, Professor Andreas Evstathiou, to the podium for a short address.
Good evening, everyone. Distinguished guests, ladies and gentlemen, dear colleagues, dear students. It is my great pleasure and honor to address you this evening on the conferment ceremony for the award of Doctor Honoris Causa to Professor Valentin Fuster, a renowned cardiologist, President of Mount Sinai Fuster Heart Hospital, and General Director of the National Center for Cardiovascular Investigation in Madrid, Spain. At European University Cyprus, we pride ourselves as one of the most historic academic institutions in Cyprus, with roots going back to the early days of the establishment of the Republic of Cyprus itself. We also consider that our most important asset is our people. We are very proud that our academic community has been enriched in recent years by several eminent scientists, including Nobel laureates in medicine and chemistry. These distinguished scientists attended one of the multi-thematic biomedical congresses organized by our esteemed School of Medicine in the last decade. Our institution has come a long way since its foundation more than 60 years ago. Today, our faculty and researchers collaborate with scientists in some of the finest universities in the world. Our faculty also coordinate or participate in a number of prestigious projects which are funded by the European Commission, the Research and Innovation Foundation here in Cyprus, and numerous other funding agencies. Our research activity in the last decade increased by a factor of 10, boosting external research funding and publications in peer-reviewed journals. As a result, the university already ranks among prestigious universities around the globe in rankings such as the Times Higher Education World University Rankings. Ladies and gentlemen, we live in an exciting time for medicine. Artificial intelligence is reshaping modern medicine, offering powerful tools to enhance diagnosis, treatment, and patient care. From analyzing complex medical data to predicting disease risks and personalizing therapies, AI enables faster, more accurate, and often life-saving decisions. supports clinicians in managing workloads and improving healthcare access, especially in underserved areas. Yet these advancements come with serious concerns. Data privacy, algorithmic bias, and the potential erosion of the doctor-patient relationship must be carefully addressed. To ensure AI serves as a force for good in medicine, ethical oversight, transparency, and equitable implementation are essential. European University Cyprus reaffirms its commitment for international collaboration and welcomes students and academics from all over the world who are interested to work towards a better world. Dear Professor Fuster, we are very proud and honored for conferring to you today the title of Doctor Honoris Causa in recognition of your enormous contribution to medicine and society. There's absolutely no doubt in our mind about the significant impact your presence here today has on the academic life of our university and the development of our faculty and students. I would like to conclude by wishing you warm congratulations and by extending our best wishes for success in all your endeavors and all your professional and personal aspirations. Thank you very much.
Thank you, Rector Eustathiou. I would now like to call Dean Professor Elizabeth Johnson, the Dean of the School of Medicine, to present the laudation.
CEO and President of the Council, Dr. Hadji Kyprianou, Rector and members of the Senate, distinguished guests, ladies and gentlemen, and of course, my dear students. Today, we have the distinct privilege of gathering to bestow one of the highest accolades the medical school can offer, an honorary doctorate. This honor is reserved for individuals who have demonstrated exceptional dedication, extraordinary achievements, and a profound impact on the field of medicine. So today, we celebrate a truly remarkable individual, Professor Valentin Fuster, and his outstanding contributions to the medical community. Dr. Fuster's remarkable journey begins in Barcelona, where he grew up as the youngest of 5, with deep intellectual roots and strong ties to medicine. His father served as the head of psychiatry. His grandfather was the rector of the University of Barcelona, 2 figures whose commitment to scholarship, to leadership, and service profoundly influenced him and the family identity. Yet, in spite of this environment, medicine was not his first calling. As a young man, he was drawn instead to agriculture, fascinated by the harmony between plants, soil, and biology. But agricultural studies were not offered in Barcelona, and at that time, young people in Spain rarely moved away to study. So he remained in Barcelona, and another influence quietly took over and took shape in his life: sports. An avid competitive tennis player and later a passionate cross-country cyclist, he cultivated endurance, discipline, mental clarity that would later characterize every facet of his scientific work. But it was through tennis that he met a figure who would change his life and change the direction of his life, Dr. Pedro Ferrares, a highly respected clinician. Dr. Ferrares recognized in the young athlete a talent he hadn't actually seen in himself, and he urged him to pursue medicine. And later, after suffering a heart attack, he encouraged him towards cardiology. It was an early and very decisive lesson in mentorship, how a single person at the right moment can reveal a path that one doesn't know is waiting for them. During his second year of medical school, Dr. Ferrares insisted, go out and see the world. So Dr. Fuster traveled to Liverpool, and this was at the height of the Beatles era, to work under Harold Sheehan, the chair of pathology. From Liverpool, he went to Edinburgh and trained with Desmond Julian, a pioneer of the world's first coronary care units, where he completed his PhD. These formative experiences abroad opened his scientific horizons, and set the stage for a truly international career. Now, it was a single moment during these years that profoundly shaped his scientific direction. In Liverpool, Professor Sheehan showed him a histological slide with platelets from a patient who had died of myocardial infarction. He asked, "Is the heart attack the cause of the clot, or is the clot the cause of the heart attack?" And Dr. Fuster replied that he didn't know. And Dr. Sheehan answered, "Well, I don't know either, and that's why you need to study it." That question, that slide, became the seed for a research career that would transform global cardiovascular medicine in the future. From Edinburgh, he moved to Mayo Clinic, where he spent 12 years developing pioneering work on graft patency and platelet biology. It is there that he carried out the first clinical trial demonstrating the benefit of aspirin in preventing bypass graft occlusion, research that would eventually shape global clinical guidelines. Later at Mass General and Harvard, he expanded his work, developing MRI techniques to visualize arterial wall in vivo. And this work fed directly into the early development of drug-eluting stents and models that revolutionized interventional cardiology. His career has never been confined to one institution or even one country. Since 1994, he has led Cardiovascular Institute at Mount Sinai, becoming chief physician of the Mount Sinai Hospital in 2012, and today serving as president of the Mount Sinai Fuster Heart Hospital, renamed in his honor in 2023. Simultaneously, he has guided cardiovascular research in Europe as the general director of the National Center for Cardiovascular Research in Madrid, building into one of the world's leading translational research centers. In recent years, however, Dr. Fuster has undertaken what he describes as a complete about-face, a turnaround, moving from the study of disease to the study of health itself, recognizing that we know far more about illness than we know about wellness. He has applied state-of-the-art imaging, genomics, and AI to reveal the mechanisms of lifelong cardiovascular health in adults and children. Throughout his career, he has remained a passionate educator, a passionate mentor. He believes that one of the greatest duties of a successful scientist is to help others discover their own talent, a conviction obviously shaped by the mentors who once did the same for him. His counsel to young people is simple and very profound. Be grateful, be creative, find your talent, and work as part of the team. His accomplishments are legendary. He has an H-index of 212, 35 honorary doctorates, editor of the world's leading cardiology journals, and leadership roles at the top cardiology associations. Actually, he's the only cardiologist to receive the highest awards from all 4 major cardiovascular societies. His scientific discoveries have reshaped modern cardiovascular practice. But among all of these many honors, I think one stands out for its reflection of his character and who he is. And that was the moment when the Spanish version of Sesame Street introduced a new character, Dr. Rooster, inspired by Professor Fuster, to teach young children about heart health. For a scientist whose mission increasingly focused on prevention and youth, a few tributes could be more meaningful. Today, we honor not only an extraordinary investigator, a visionary leader, and a global health advocate, but a man whose personal journey from the tennis courts of Barcelona to the pinnacle of world cardiology reflects resilience, curiosity, humility, and an unwavering dedication to man's well-being. Dr. Fuster, the Doctor Honoris Causa that you will receive today is a tribute to your scientific achievements, your personal journey, and the countless lives that you have touched with your work. We thank you for your extraordinary contributions to medicine, to science, and to humanity. Thank you.
Thank you, Dean Johnson. I would now like to invite the Deputy Dean, Professor Ioannis Pantrigios, to read the School of Medicine resolution on the award of the title of Honorary Doctor to Valentin Fuster.
Resolution to award an honorary doctorate of medicine to Professor Valentin Fuster. Whereas Professor Valentin Fuster has an outstanding contribution to cardiovascular medicine, pioneered research in the prevention and treatment of heart disease, and is committed to advancing global health, education, and societal well-being. The councils of the Department and School of Medicine at its meeting on September 29, 2025, recommended to the Senate of European University Cyprus to resolve that the School of Medicine of European University Cyprus award an honorary doctorate in medicine at the 13th International Multi-Thematic Biomedical Congress on November 8, 2025, to Professor Valentin Fuster.
Thank you, Professor Patrikios. I would now like to invite Professor Andreas Evstathiou, Rector of European University Cyprus, to read the Senate resolutions on the award of the title of Honorary Doctor to Valentin Fuster.
Resolution. Following an anonymous recommendation of the Council of the School of Medicine and decision of the Senate and ratification by the Council of European University Cyprus, whereas Professor Valentin Fuster has significantly contributed to the science of medicine, developing an acclaimed international scientific activity, the School of Medicine, the University Senate, and the Council unanimously decided to award him the title of Honorary Doctor of Medicine and the Rector to serve him this resolution on the date of inauguration. In the city of Nicosia, Cyprus, on the 8th day of November, 2025. Thank you.
Thank you, Rector Evstathiou. I would like to invite Rector Andreas Evstathiou, Dean Elizabeth Johnson, and Professor Ioannis Patrikios for the academic investiture of Professor Valentin Fuster. Congratulations, Professor Valentin Fuster. I would like to invite for the first time Honorary Doctor of European University Cyprus School of Medicine, Professor Valentin Fuster, to give his conferment speech.
Well, thank you all. Professor Andreas Evstathiou, Rector of the European University, Professor Elizabeth Johnson, Dean of the School of Medicine, Professor Ioannis Patrikios, Deputy Dean, and other authorities of the medical school and of the Medical Association, colleagues and friends. Of course, one feels very honored by having this honoris causa, and particularly from a university that is very well known worldwide. It is amazing to me. I have been following this university for many years, and it's interesting that in a short period of time, this is just one of the best in the world. And I have to congratulate you for this accomplishment, all of you. And certainly, why not the students who really are the substrate of this university? So it was about 5 years ago that we created a collaborative effort between the Institute of Health Metrics Evaluation in Seattle, the National Heart, Lung, and Blood Institute in Washington, and the Journal of the American College of Cardiology that I served as an editor until recently for the last 10 years. This effort had the objective of evaluating on a timely basis the global status of cardiovascular health and disease. I think it is appropriate in a few minutes to highlight 5 critical challenges that define the current global cardiovascular situation in 2025, as I was asked to present these 5 challenges to the United Nations New York Agenda this past September. I think this is actually, again, quite appropriate. I receive an honoris causa today. It's a great honor. But the question is, what is next in our cardiovascular specialty? What are the challenges? It will not take long, I can tell you, no more than 5-6 minutes. But I'd like to go one by one as I see them and as we presented again in New York recently at the United Nations. The first challenge, around 80% of cardiovascular events occur in low and middle income countries, where effective treatment and adherence remain very low. This underscores the pressing challenge of inequity in healthcare delivery, a fundamental concern of science, health, and education worldwide. The second challenge, projected from 2025 to 2050, the disability-adjusted life years, age standardized, related to the overall cardiovascular risk factors, are expected to decline, which suggests improved management. That is, at age 60, for example, projecting the next few years, cardiovascular disease will decrease. So something that we are doing appropriately. But there is something else, though. Due to population growth, aging, and relatively high incidence of hypertension and obesity, overall, the incidence of cardiovascular disease in the world is going to increase significantly. And this is an issue that we all should be aware of. And this leads to the third challenge. According to what I said, the economic burden of cardiovascular disease and stroke from 2020 to 2050 is expected to increase substantially. And we have to be aware of this economic issue. The fourth aspect, very important, obesity and high blood pressure as modifiable risk factors are 2 critical problems to be addressed, with hypertension having a significant impact on cardiovascular disease, dementia, and overall mortality, making early intervention essential. And fifth challenge, in relation to dementia and Alzheimer's disease, according to the ARIC study, from age 55 to 95, the lifetime risk of dementia, including Alzheimer's disease, is 42%. And this is in the United States. So a critical issue that we discuss in some detail this afternoon. Having outlined these 5 critical challenges in the global cardiovascular landscape, we must consider how these challenges unfold across the various stages of life and from the different socioeconomic regions of the world. Conventionally, the first stage of life, from birth to 20 years, is a period of vulnerability, but of significant opportunity. Importantly, children and adolescents, as I presented this afternoon, are the future leaders of the world. Very early health education and intervention will determine our future, as pointed out in the recent Lancet Commission report on adolescence that I presented this afternoon. The second stage of life, adulthood, from 20 to 60 years, brings new and pressing challenges to the heart, for the heart. Early detection of subclinical disease and management of cardiovascular risk factors, including obesity and high blood pressure, all become increasingly critical. The third stage, from 60 years onward, confronts us with the profound challenges for the brain, meaning aging, multimodality, and dementia, all in part preventable, and I emphasize, in part preventable. Let us reaffirm our resolve to ensure that every child, every adult, and every elder is given the chance not only to survive, but to thrive with dignity, health, and hope. Thank you very much to all of you.
Thank you and congratulations, Honorary Dr. Professor Valentin Fuster. Distinguished guests, ladies and gentlemen, dear students, you are kindly requested to remain in your seats until the recessional is complete and the platform party of the faculty have left. Thank you. Thank you for joining us. Please, you may join us outside in the foyer for some wine and cheese. Have a wonderful night.